Good morning to CSI TV studio, and the weather in Mumbai, you don't have much to speak about. It's always hot, hotter and humid. But today we have ensured that in the venue, the temperature is going to be cool. It's right now at 21 degrees and it's very comfortable. As the day proceeds, you might have more people coming in and it will get more comfortable. Well, before I begin, I must tell you all that everybody should download the CSI app. Now, Jio is providing us with a 4G Wi-Fi, and first thing you do in your settings is to get this Wi-Fi enabled. When you go to this Wi-Fi setting, use the Jio net and it asks for your mobile number, submit that, it will give you the OTP, enter the OTP, and once you do that, you will be logged in for the next 24 hours. Please use this. It's a 4G high-speed connectivity. Once you have done this, if you have not downloaded the CSI app, do it now. Either in your Play Store in the Android or in the App Store in the iOS. In the CSI app, we have very interesting features. Go to the e-resource. In the e-resource, we have CSI Live. What have we provided this time in CSI 2018 is that if you go to CSI Live, you will be able to see live proceedings in all the four halls, hall A, B, C, D. So even if you are outside the halls, even if you are in hall A, you can easily see what's happening in hall B, C or D. Make the best use of it so that you have a platter of all the scientific content that's going on live at the same time. Similarly, CSI TV is live. So if you hit on that icon, you will be able to see the live proceedings of what's going on in CSI TV. All right, with this brief note, let me tell you what's in store today. I think we had a very hectic day yesterday. Almost 2,500 attendees were there in the four halls, 9 to 6, packed program. We had a fantastic inauguration by our Municipal Commissioner, Mr. Ajoy Mehta. And what a fantastic message he gave. He told us that medicine challenges technology and technology inspires medicine. Very true. But where is that human touch? The human touch needs to be preserved, needs to be intact. What's in store today in the scientific halls? Well, we have a joint scientific session with two big societies, ACC at CSI, ESC at CSI. In the ACC at CSI, we have emergency room to interventions, Michael Wellington, Richard Chazelle. In ESC at CSI, we have everything about dual antiplatelet therapy, non-STEMI, cardiogenic shock, Stephen Windecker and Marco Raffi. And we have plenary sessions. I think make use of this. Plenary sessions are going to run between 11 to 1 in the morning and in the evening between 4 to 4:45. Interesting plenary sessions. Mystery of HDL by John Chapman. Diabetes and cardiovascular diseases, Prakash Didwania. DM and DNB training. What's happening? Are we losing the track? Dr. Satyavan Sharma, our organizing chairman. Dr. P.K. Deb is going to highlight on DAPT. Update in the management of stable coronary artery disease, none other than Samin Sharma guiding us through optimal medical therapy, percutaneous coronary interventions or bypass surgery. Jagat Narula is going to help us in revascularization of a stable angina patient. Is it the eyeballing of the stenosis that's important, or we need more imaging like FFR? Jitendra Merkar is talking about TAVR. What is the current status? Hypertrophic cardiomyopathy. How do we prevent sudden deaths? Martin Maron. Secondary prevention ACS. Michael Valentin. John Cam, the most revered electrophysiologist, is going to help us. What is the value of real world assessment in the use of anticoagulation for atrial fibrillation. And finally, we have an update on the use of antithrombotics by John Cleland in heart failure patients. Also, we have interesting debates. A few of the debates, if I highlight, I must say that STEMI, what happens to patients in STEMI in the 24 to 48 hour segment? Do we need to do revascularization immediately or later? The cholesterol controversy, have we been fooled all these years? What is the role of devices in LV dysfunction? Is there a role of CRTP at all? And finally, the most awaited session is going to be by Professor Eugene Braunwald, 5:30 p.m. Don't miss it for the world. Well, the other thing which I need to highlight or mention about is that today the Hall E is open. Hall E has e-posters and oral abstracts. Make use of it. First time a concept where poster presentation is happening on an electronic format. We have 12 stations, 9 to 10, 10 to 11, 2 sessions. In one station, we're going to have at least 8 presentations happening. So through the day, we're going to have roughly 200 presentations today, 200 presentations tomorrow. In the afternoon, 1 to 5 p.m., we'll have the oral abstract presentation happening. So Hall E is going to be open today. Now, 2 other areas which we would like everybody to make utilize of what we have created is, for the delegates, it's Meet the Experts Lounge. Please make use of it. Meet the Expert Lounge gives you a platform wherein you will be able to interact in a one-to-one manner with the international and esteemed national faculty. Meet the Expert Lounge is on the right side of the trade area. There is a special space created. US Whitman people are helping to get this lounge functioning. We have important faculties. You can spend 1 hour with them in a roundtable format, clarify all your doubts, all your clinical dilemmas. It is going to run in the morning 10 to 11 and in the afternoon from 1 to 5. You can also, you need to pre-register. You need to book your appointment with a particular faculty. You can do it through the app or go to the US Whitman stall and in the lounge and register yourself. And finally, we are having a CPR workshop. We have realized the importance of reviving a patient with sudden cardiac arrest. It's very important. It's a basic CPR course which we are going to start today. The iCare team, the Life Institute Health Supporters team are going to teach us about CPR, basic CPR. It is essentially meant for the trade people, for the spouse people, a 1 hour short training program where there will be a brief take-home message and then a hands-on CPR training. How to identify a victim of sudden cardiac arrest, how to call for help, what should you do in terms of chest compression. It's a chest compression only message that we are going to give because that's the thing which saves lives. So everybody needs to do this, learn this and make use of AED. I wish you all the best and have a great day today. Thank you.
The organizing secretary of the conference and a professor of cardiology at the KEM hospital. Today, we have in our studio a pioneer in the field of alcohol septal ablation for hypertrophic obstructive cardiomyopathy. We have with us one of the international faculties of the conference, Professor Dr. Hubert Segevis from Frankfurt, Schweinfurt, close to Frankfurt, from the Leopoldina Hospital. That's correct? So, welcome to Mumbai.
Welcome,
Amchi, Mumbai.
Papula. Welcome, Papula. Thank you for the invitation.
Yes.
And we know that we both stood in the CAS lab years ago to start with you the program of septal ablation in KAM.
So, Mumbai, I also would give you a German welcome if you like it.
Yeah,
and you tell me if is it good. The German welcome is Herzlich Willkommen im unsere Mumbai.
Yeah.
Is that good?
Yeah, very good. Unfortunately, I cannot answer in Hindi.
Oh, lovely. So by the time Professor Hubert Sigvis lives from here, we'll give him a few tips about Hindi.
Yeah,
Okay.
yeah, okay.
आपका स्वागत है मुंबई में.
Oh, that's difficult.
That's
That's
difficult.
difficult.
Anyway, let's get on with the business. So we are here, Professor Hubert Sigvis, to discuss the nuances of alcohol septal ablation. As you, what I would like to tell you is that we, most interventional cardiologists also are today shunning away from alcohol septal ablation, mainly because of the risks which are, so to say, overplayed. So what do you have to say about the risk of septal ablation?
The risk of septal ablation in general is that you can create a complete heart block in about 10% after the procedure. But the main risk is that you may produce complications you want to avoid. That means especially infarction in areas you don't want to be infarcted. As you know, alcohol septal ablation means you create a septal infarction, a therapeutic septal infarction, in the second part of the septum that is part of the building of the obstruction. And once you overcome this region, you can create an infarction, especially in papillary muscles. It's very dangerous. And there are some tricks or some specialties to avoid these complications.
So what you want to say is echo guidance is absolutely mandatory.
Yes.
Am I right?
Yes,
Oh, okay.
that is what we want to say. And when we started it in 1996, we had an echo on every of our first 20 patients on the intensive care unit the hours after the intervention. And then we saw in one patient that the alcohol depot was too far distal or apical in the septum. And then we thought, how can we predict the location of the alcohol? And then we had the idea to inject at that time Levovist, a contrast agent, in order to avoid these missed
So taking it further on the contrast agent, today Levovist is not available. So how do you substitute for Levovist?
Okay, this was a problem in the early 2010 years when we heard that sharing would stop the production. And we tested every contrast agent that was available at that time. And then we had the idea to use gelafondine, a colloid. And the important thing is that you have to agitate.
For viewers, let me say, you mean gelofuscin?
Yes.
That's correct.
Yes,
That's
yes.
exactly what we use too.
Yeah. And the trick is you have to take it from the fridge and you have to agitate it. And once you have done it, it gives a very good contrast.
So does it retain as well?
Yes.
Yes.
It retains.
So it is a good substitute
Yeah.
and a cheaper substitute
And
for
it is-
Levovist.
And it's
Very
cheaper.
relevant in our
Yeah.
country.
Yes.
Okay.
Yeah.
Yes,
That's
correct.
very good.
So to go on with it, now the real question, a big question in other words, is that do you go by the size of the septal artery or do you go by the septal thickness in terms of how much would you inject?
I go by the septal thickness. The septal
Which is
artery-
very important for our viewers.
Yeah, the septal artery thickness does not play a role. The septal muscle thickness plays a role. And we inject about 1 cc per centimeter septal thickness.
So would you attempt it also with septal thickness more than 30 millimeters?
This is a very difficult question, and you have to answer this question very individualized to the patient. And if you have a lot of scar in MRI in these patients, there is no good chance that you create a good result. And then you should discuss it with the patient. And if the patient said, okay, we try, and I've done patients with more than 30 millimeter septal thickness, and it worked, and there are some patients it didn't work. But it's very individualized.
So once you've injected alcohol, So like for instance, in the more than 30 millimeters septal thickness patient, you tell me one thing, is that what are his chances of being able to, say he fails, about being able to go to the surgery afterwards? Does the surgeon ever complain about what you've done in there?
Surgeons always complain if interventionalist does something. So
Okay, that's a valid point.
that you have to expect. But there is no additional risk unless you created a right bundle branch block. Then you have a high chance after surgery that you have a total heart block, because surgery results more or less in 50 or 60% in a left bundle branch block. So if you have a pre-existing right bundle branch block, you may expect that the patient is pacer dependent afterwards.
So having said that, what percentage of patients do get right bundle branch block in the lab? And say there is a right bundle branch block that's occurred, okay?
Yeah.
If there is a right bundle branch that has occurred, then would you stop further from alcohol? How do you weigh that decision about the end point?
No,
Would you strictly yet go by the alcohol depot that's created on?
I go by the alcohol depot. There are analyses that you create a right bundle branch block in about 40 to 50% of the patients. And patients with a right bundle branch block after the procedure have the best results.
Oh, okay.
Have the best results.
Okay.
So, it's
So
due
right
to-
bundle branch block occurring during alcohol septal ablation is not a contraindication to go further with your alcohol injections. So having said that, what would you do if you do get a CHB on table and you haven't really injected much alcohol?
I go further, because you have only one chance to ablate this branch and the area that is supplied by this branch. So if I have a total heart block during alcohol injection, I go on for injection, and whatever happens, it's the same with the other patients who develop a heart block after the procedure. At the end, 10% require a pacemaker, and it's not dependent whether the patient gets a heart block immediately when you inject the alcohol or whether he develops a heart block afterwards.
Oh, okay. So which means occurrence of complete heart block will not deter you from injecting more alcohol. How about coming again? Like for instance, the success of the procedure could be determined later on. You have that typical triphasic response.
Yeah.
You do get the gradients coming down later on. Yeah. So what about that? Meaning you inject, you come back, if he's not succeeded, you can always do it again. You don't believe in that?
Yeah, that depends what is your primary strategy. My primary strategy is to inject one alcohol in one septal branch per session, and then wait, because we know that there is a kind of remodeling process after the alcohol injection. That means that you have to have a redo in about 15 to 17% of the patients. But this is not a failure, because you also see that there are a lot of patients that have a good result after 3 months, after 6 months, with this small area of necrosis. And to have a smallest area of necrosis to reduce the gradient, that is my aim. And this includes that you have some redos. I know other people who inject more alcohol in more than one branch, but they have higher complication rates. And our complication rates, I told you we analyzed our complete data of Schweinfurt. Our complication rates, mortality is 0.2%. And this is very low from my point of view for an interventional procedure.
Oh yes, indeed. That is why you are here, Professor.
Yeah. And we don't we didn't have lost any patient on the table. The complications were afterwards. These are the dangerous, the first 2 or 3 days are the dangerous phases, because they develop a gradient after 3 days again, because there is edema. And then it's the question, can everybody in the hospital manage this situation?
Okay. So what happens, you never go by gradient on table?
No.
So gradients may drop, may not drop. Is there any minimum amount of alcohol that you would necessarily inject? Or if you get a response with just say half a ml, will you stop or will
No.
you still? No, you
in
wouldn't.
in the late 90s, there were some studies to have less alcohol than 1 cc per centimeter, and these results were not good. The hemodynamic results for long term were not good. And once you have injected 0.5 cc of alcohol in a branch, the branch is occluded. You can't do anything more in this branch. And if this is a branch, you have lost it for treatment. So you have to go for 1 cc per centimeter septal thickness, whatever happens in between.
Oh, okay. So at least 1.5 ml of alcohol
yes.
would be in
Yes.
there, correct?
There's also a question, how thin can a septum be in order to make a septal ablation? We have treated not few patients with 15 millimeter septal thickness. And if you do not go beyond 1.5 cc of alcohol in these patients, you don't have any problems. We never had a VSD.
Oh, okay.
Yeah.
So you never have had a ventricular
No,
septal
we never had a
defect.
VSD. I know about some VSDs, but analyzing these cases, it's that the alcohol was in the wrong place. So, and then these patients got an VSD.
So what about the other complication, ventricular tachyarrhythmia? In the ICU afterwards, ventricular tachyarrhythmias. Have you ever experienced that?
We have it in
how
one.
do you go about them?
Yeah, we have it in one, but this was a dislocation of the temporary pacemaker.
Oh, is that
And
right?
this was artificial, but you have to think about it, but it's not due to the infarction. From this standpoint of view, it's not dangerous. And you may know, I'm sure you know, that in the late 80s, alcohol injection in septum branches was introduced to treat ventricular tachycardia originating from the septum. And so alcohol can reduce the number of ventricular tachycardia. And you also know that there is another type of scar. It's not this typical scar coming from coronary artery disease. It's a sharp bounded scar after septal ablation, and therefore you do not have the overlap.
So it is overplayed, you think, the
Yeah,
thing
yeah.
about ventricular tachyarrhythmias?
yeah.
Oh, that's good. Now, having said that, would you offer it to the young as well?
This is also a question
Because
you
that's
have to-
like a
you
that's
have-
like a
you have to
contraindication.
to decide individualized. The results in younger patients are not worse. And we have, I told you, we have now our long-term follow-up results up to 17 years. And even in the Bad Oeynhausen cohort, more than 20 years. And we have no increased risk. We have also reduced risk of dying. So our overall survival free of cardiovascular events analyzed by Kaplan-Meier after 15 years is 0.92.
Oh, wow. So it is comparable to surgical results.
It's comparable to surgical results. We cannot state that we can reduce the risk of dying, but if you compare it with normal people, normal population, the risk is not increased, even in this people in this disease.
Oh, that's excellent. So if and when you publish these results, do you think they will make a change in the guidelines?
I think there is a change in the guideline, but one word of caution. Septal ablation is not simple PCI. And sometimes you see that people who are not very familiar with the disease and with the problems of the treatment, they do septal ablation because they think it's very easy. First a guide wire, then a balloon, and then alcohol. This is not the case. You must know, you must have an idea of the disease, and then you have the good results. And with these results, we have a change of guidelines.
Oh, okay. So that's a point well taken. So there is a good long-term follow-up. The scar business. Now, what do you have to say about the scar caused by the septal myomectomy versus the scar caused by alcohol septal ablation? Do you have anything on that?
We don't have, there is a scar also after septal myectomy. Whatever, there's no surgery without any scar. Also, the surgeon states that there is no scar, but you see a scar. If you analyze these patients after death and they had myectomy before, you see some type of scar. It's a different scar, but there is a scar. But nevertheless, myectomy is a very good option. But on the other hand, it's not so easy. And you don't find many surgeons that can do a perfect septal myectomy. That is the other point. So in both treatment options, you must have experts.
So you said that in our country also, we do not have, or for that matter, that's a story world over. We do not have those kind of surgeons that Mayo Clinic has or Cleveland Clinic has, or for that matter, Schonduber, the famous surgeon with you in Germany. So, which is very much here. So, you think alcohol septal ablation is a procedure that's extremely important and it changes the natural history of this disease from which most of us, even cardiologists, want to stay away from decision making about hypertrophic obstructive cardiomyopathy. So they have a good prognosis.
From the scientific standpoint of view, you need controlled trials. But from the clinical observation, I think septal ablation changes the natural history of the disease.
So very important take-home message that.
Yeah. We have, I personally have in Germany performed more than 1,500 septal ablation, and we have more or less a complete follow-up in these patients. And we do not harm the patients.
1,500, that's an astounding number.
Yeah, and so we do not harm the patients. So, and therefore, I believe that we change the natural history of the disease.
That's excellent. So from viewers' point of view today, I hope you have been educated in the business of the finer nuances of alcohol septal ablation for hypertrophic obstructive cardiomyopathy. Now let us go beyond alcohol septal ablation. A person who's done the maximum number of alcohol septal ablations probably in the world. What do you do beyond alcohol septal ablation in interventional cardiology? Let's move out of cardiology. And what do you do beyond cardiology?
Beyond cardiology, of course, I have many interests. First of all, it's my family. You know, we have 2 children, and we travel a lot. So
lovely. You love to travel.
Yeah, I like to travel. I combine meetings like this to get to know the countries we go to. And I'm a little bit in music business. We support young musicians so that they can produce their music, and hopefully sell them. And we support musicians by sponsoring concerts.
Oh, lovely.
This is a very important point. And I don't know whether cardiologists like to hear it. I drive motorbike. And
and you're well protected with headgears and all that?
Always well protected, unless we drive in the US. So we have this, in the US the traffic is not that like in Europe.
So you drive your motorbikes on the autobahns of Germany, and how fast do you go on your motorbikes?
Normally we try to avoid the motorways because the curves are better in the mountains. Once I tried to be higher than 200 kilometers per hour. And there was no traffic. But it was fun.
It was fun? Oh, lovely. So, like, you are an interventional person even outside of your field of cardiology, right? You have that kick of an interventionist.
Yeah, I was lucky. I was very young in the early 80s. To get involved in interventional cardiology. I did my first PCI in 1985.
Wow, so it's like
And
30
you know
years
that
ago.
I was in Bad Oeynhausen before. You have been in Germany too.
Yes.
And at that time we had a high number of PCIs, and I introduced more or less every new tool till the early 2000s that came on the market. And then I know that many tools came and more tools went.
Oh,
So
lovely.
the only thing that stayed from my point of view is the balloon, the stand, and the roller blader
Correct.
to do something like that. I've seen many, many things. I also introduced that it's in Germany with my colleague mitral valvuloplasty for mitral stenosis.
Oh, so there is.
And we had the chance that Professor Inoue visited us as the first clinic in Europe and all the other things. Unfortunately, I worked in a community hospital, and I did not have the facility to go further with MitraClip and TAVIs. I know about it, but I didn't personally do it. But closure devices,
but I
have it.
think now you should look at life beyond cardiology, and with your love to travel, I think you can come back to Mumbai again and be outside of this conference area and experience the other things that people can do in Mumbai.
Yeah.
Well, thank you so much, Professor Sikibis.
Okay.
We had
Thank
a
you.
good time.
Yeah,
Thank you
thank
so
you,
much,
thank
and
you.
safe travels.
Thank you. Thank you.
Bye-bye.
Karthikeyan. I'm Professor of Cardiology at the All India Institute of Medical Sciences, and with me here is Professor Shripal Bangalore, very well-known, multifaceted personality. So we can talk about many things today, but we've decided to just talk about a few of his more recent interests, and hopefully this will be of interest to everybody. So, morning, Shripal.
Thank you.
So first of all, I mean, just by the way, because people in India would like to know where you're from, so originally, so if you can tell us something.
Yeah, so originally, as my last name indicates, I'm from Bangalore. So grew up in Bangalore, did my medical school there, but I've been in the US, in New York, for 18 years now.
Okay, great. So that, we'll put that aside for the moment, and I thought we'll talk a little bit about ischemia now that enrollment is complete, and you will be presenting the results later next year, I suppose. Right. And also about ischemia CKD, which is part of your interest. And then we will talk about, because we've done quite a few the meta-analysis in various aspects of cardiology. We'll talk a little bit about one particular thing which I'm interested in, and then we talk in general about meta-analysis. Is that
Yeah,
okay?
that sounds great.
So, ischemia, can you tell us about the progress of ischemia right now, just because people are looking for the results of ischemia? So
Yeah, absolutely. So, so we have finished enrolling in ischemia trial. So we have randomized around 5,179 participants. The revised target was actually 5,000. So we are kind of pleased that we were able to get to 5,179. And I think that number is important to keep it in perspective, because if you look at Courage and Barry 2D combined together, it's around 4,500 patients. So now ischemia has enrolled more than Courage and Barry 2D, and we have enrolled a higher risk group of patients. So the follow-up will end in June, and we are hoping to present end of year next year. I mean, it's a tight timeline, so we are hoping that we can get our data in, lock it, and then present next year.
So what is your gut feeling about?
I wish I knew. So I think it will be an interesting results to see.
Most certainly, definitely. So before we move on from ischemia, I just wanted to talk to you about the controversy about the changing endpoints that I think many people have misunderstood it a little bit. So maybe you can just take this opportunity to clarify it.
Yeah, I think part of the issue is, it was triggered by an editorial where they said shifting goalposts, etc. The sites which are actually involved and the team which was closely involved right from the design part of the trial will know that everything was pre-specified. Nothing was changed, and we had a plan when we went in. Initially when the trial was approved by NHLBI, it was a 5-point composite endpoint. And we wanted to make it more stringent. We said, let's start with a 2-point. And during the conduct of the trial, if we find that we are underpowered, we'll have a special committee which will recommend what to do at that point. And that's exactly the procedure we followed, and the committee recommended switching back to the
Reverting
5-point
to the,
endpoint. So in other words, there is no non-pre-specified change in our endpoint. So everything was pre-specified.
And also the data is still blinded, right?
Exactly,
So
exactly.
I
It's all
don't
blinded,
think
so we...
so I think the main concern of the editorialist Daryl Francis and his group from Imperial, they probably, I think the issue was that they were looking at the three non-hard endpoints within the composite. So maybe you'd want to clarify how in the whole scheme of things, this is still going to be adequately powered for you to assess what you set out to assess.
Yeah, first of all, I want to emphasize that if you look at our endpoint of CV death and MI, it's still our major secondary endpoint. So if you go back to the primary endpoint, the 5 composite, we have response. I mean, we published this viewpoint after Daryl Francis published theirs, and where we emphasize, like, look, I mean, all of these, true, there are softer endpoints, but we have very strict objective criteria. So for example, the hospitalization for unstable angina, the criteria is very objective. I mean, you need EKG changes or angiographic evidence. So it's not like somebody walks in, complains of chest pain, they will be coded as hospitalization for unstable angina. The same applies for hospitalization for heart failure. So even though these are softer endpoints, our definitions are very stringent, and that's why we feel that. So at the end of the day, I know we in clinical trials categorize primary, secondary endpoint, but here I think the totality of data is important. We will present the 5-point composite. There is still the secondary 2-point, more robust endpoint, and people have to look at all the results and conclude themselves as to how best to take those results.
The non-fatal, say unstable anginas, non-fatal NST, ACS endpoints will not be like FAME2, for example. I mean, that was the main concern I think they raised. So it's more stringent than FAME2.
So it's absolutely more stringent, more objective, and given the fact that this is unblinded, I think this is very important, because if it is unblinded, you can imagine that a patient walks in, complains of chest pain, the sites know that...
Which happened in FAME2.
So exactly, which happened in FAME2. So this definition is much more stringent. I think that's important to emphasize.
Right. So moving on, let's talk about your part of the study, so the ischemia CKD. So can you tell us what you're really looking for and why there is a need to do a specific CKD trial?
Yeah, so if you look at the CKD population as such, I mean, it's a growing, complex group of patients with a high prevalence of coronary artery disease. And the problem in the past, I mean, if you look at Courage trial, there was no exclusion based on GFR. But if you let a trial run by itself, you'll see that physicians don't enroll these patients. They are very sick and they feel like, oh, we shouldn't enroll these patients. Patients themselves are not willing to be part of clinical trials. So that's one of the reasons we say, like, we need a dedicated trial. If we just said ischemia trial will enroll all ranges of GFR, I don't think we would have gotten to where we are right now. So that's one of the reasons we designed this parallel trial. And I'm pleased to also note that the trial has finished enrollment. We have randomized 777 patients, and that's the largest randomized trial for this advanced CKD cohort. The timelines are very similar. The last follow-up is June of 2019, and we are hoping to present later next year.
Great. Let's move on to your one of your main interests. I presume it's one of your main interests, which is doing meta-analysis of a lot of stuff. So one particular thing which I'm interested in is there have been, as far as I know, at least 5 or 6 meta-analysis on culprit only versus multi-vessel PCI for STEMI. I know that your one of the recent meta-analysis was looking at per procedure, during the first procedure, multi-vessel PCI versus staged versus compared to culprit only. So, and you presented slightly different results than previous meta-analysis did. Do you want to elaborate on that a little bit?
Yeah, so what we did for this is to look at data to date. I would say whatever were the randomized trials which were published up until that day, and dividing trials into 3 different arms, where the first one was culprit only, which is easy. The second one was complete in 1 setting and complete in 2 settings. And we wanted to look at the difference in outcomes to try to figure out which is the best strategy based on data whenever we published this. This was like 6 months ago. Given that we have 3 different arms, so we did a couple of different strategies. One was to do a direct comparison, and one was also to do a network meta-analysis of comparing all of these 3 different groups, and to see, can we come up with, at the end of the day, can we say which is the best strategy for these patients? And interestingly, what we found was a single setting complete revascularization was associated with significant benefit. And of course, the benefit, all of us can say, if you completely revascularize, you'll have the benefit of less repeat revascularization. And the culprit only, you will have, the patients will come back, at least a small proportion will come back later on. But we also found that in the single setting complete revascularization, there was actually a benefit for reduction in death or MI. I mean, that being said, all of these confidence interval, point estimates of wide confidence interval, so we need more definitive trials. I mean, 2 such trials are in the works currently, and I think we'll gain more insight sometime next year about what strategy to follow. But I think this is one of the good example because if you remember 10 years ago it was class 3 to do complete revascularization at the same time of the culprit revascularization. Now 10 years later, multiple randomized trials, and now we are seeing a trend that maybe completely revascularizing may be a better option. So the guidelines now from class 3 is now to 2B and 2A and so forth. So I think this kind of emphasizes the value of randomized trials to one extent, but also meta-analysis of randomized trials to incorporate all of these data.
If I were to play the devil's advocate and tell you that that there have been trial sequential analysis for this particular subject, and people have said that there aren't sufficient data to arrive at some conclusion regarding at least the hard endpoints, death versus MI. So, how would you respond if I were to tell you that so many meta-analysis, and many of them have said they've sort of jumped the gun. So we're waiting for complete or one of those big trials which will tell us more definitively. But before that, we've already jumped the gun. We've said, okay, this is the best way to do it. At least the meta-analysis seem to suggest, without being adequately powered. So
good point. I mean, in most of that's why even with this analysis, we emphasize that the confidence intervals are wide. But what we are seeing, we also published a trial sequential analysis, but despite all of this, the trend seems to be in the same direction. What we are seeing from all randomized trials so far is the culprit only seems to be the worst strategy, and the complete seems to do better. The question is, should we do complete at the same setting or should we stage it? I think that's the question. And then second question is, will it actually make a significant impact in reducing death? But what we are seeing so far, at least for many of the different endpoints, that culprit only seems not to be the best strategy. So I think it's some form of complete repass. But I also want to emphasize that we have to be aware of what kind of patients were enrolled in these trials, because these trials had a lot of exclusion criteria. Patients with CTOs were excluded. Any kind of left main disease were excluded. So I think we have to be careful in implementing this to clinical practice. But at least for 10 years ago, there was no randomized data. Everything was based on observational studies, and guidelines put in class 3 don't do this. Now, multiple randomized trials, none of them well powered until we get to complete and other trials. But at least the point seems to be that the guidelines are aligned with the data as of today.
One more little point that I find a little bit niggling is the fact that mortality, the mortality difference in all these meta-analyses is driven by one single trial.
Yeah.
It's the wall trial, right?
Right.
So, the moment we do a meta-analysis and present the same results, knowing very well that just one trial has influenced that so much, it kind of legitimizes or maybe makes it even more robust than it seems.
Right.
So I kind of think that, I know that you've said that as a limitation, but I think people should recognize that as an important
absolutely,
limitation.
absolutely. I think again, just like anything else, I would say it's the totality of data, and this is one of the things. I teach meta-analysis for a master level course. Meta-analysis, I don't think it adds anything more than what you have, right? So you have randomized trials, so it'll provide data from those randomized trials. It'll have the same strengths and limitations. And that has to be taken as one more evidence in the totality of data. and that evidence will change with accumulating evidence and so forth. So will it actually, do we have robust data to actually say complete revascularization will reduce mortality beyond any reasonable doubt? I don't think that's true. I mean, at least we're seeing a signal, and the signal is actually interesting because in clinical practice, I rather go by, okay, it's going to reduce other endpoints, maybe MI, surely repeat revascularization, and maybe potentially there is a mortality benefit. If the signal was in the opposite direction, then that would make me getting more concerned.
So in this context, I mean, this is one approach to do things. You do go at it from the data perspective, and the other approach is to look at it from a physiologic perspective. So I'd be interested in knowing what your thoughts are on, for example, you know that in the situation of shock, multivessel PCI has gone out, where we thought that it's probably more physiologically going to be more useful in terms of myocardial salvage or stuff like that. So I wonder what you think about that, because
absolutely. I think that this is the reason why we need to do randomized trials, right? Because everything is switched around. So many years ago, 8 years ago, we were planning on a randomized trial for STEMI complete versus culprit. So I have more insights into this. I mean, the preliminary data did suggest that if you were to completely revascularize, there is faster recovery of LV function when compared to culprit only. And physiologically it does make sense, because if you have a patient with multivessel disease who comes in with the STEMI, it's not only the infarct-related territory which is affected, of course that wall is not moving. We really want in those situations for the rest of the walls to be hyperdynamic, not just contract normally, it should be hyperdynamic to compensate and make sure that the output is maintained. So if you have a critical lesion, it's going to impair that. And the physiological rationale for complete revascularization is, okay, so you're taking care of that, and hopefully that's the reason that the risk of future deterioration or future events is minimized by completeness of revascularization. And that again goes back to why should there be a benefit of a single stage PCI versus single procedure at the time of culprit only versus staging it. And I think the reason is if you stage, it's likely that you may miss out on events. So if you stage it in a month time, patient may come back like 2 weeks later with an MI. So you may not provide the upfront benefit. So if you can complete it at the time, maybe it's beneficial. But of course, as we discussed, we need more data, and it's not feasible in all patient subgroups.
And what do you think about repeat revascularization as an outcome for these studies? I think it's not.
Yeah, it's always been a softer endpoint, and it's one of those things that
it's also a self-fulfilling prophecy.
It's a self-fulfilling prophecy, and this comes up with every time we debate on PCI versus CABG, and CABG reduces the repeat revascularization, and from patient perspective, I don't know which one. It's better to lay out all the options. That your point is very valid, because the repeat revascularization is not in 100% of culprit-only revascularization. It's only on proportion of patients, a third of them at the max. So in other words, 2/3 of them, you're actually keeping them away from the cath lab. So I think it needs a full disclosure. So that's why if there is superiority only on repeat revascularization, I think the conversation is much different with the patient. Rather than a harder endpoint, I consider MI to be a hard endpoint too, and not necessarily mortality. Because if you look at now, we are waiting for the results of the complete trial. The complete trial is not going to be powered for mortality, so we are not going to see the difference in mortality.
It's death and MI.
It's death and MI, and we suspect that the results is going to be driven by MI rather than death.
So now, once you're done with ischemia and ischemia CKD, what is next?
Yeah, so there are many trials that are in the pipeline, are in the works. So one of them that I have been passionate about is to answer the question of how effective beta blockers are for stable coronary artery disease patients. In other words, we know that it can reduce angina, but beyond that, is there a role for beta blocker to reduce cardiovascular events in patients with stable coronary artery disease? So we are calling it the ischemia 2 trial, and so there is. So we are waiting to hear back from NHLBI. So there is interest, and we should hear more in January whether the trial will be fine.
And which beta blocker? do you think?
Great question. So the trial design is going to be interesting because what we've seen is in this day and age, many patients, or most patients on stable coronary artery disease, are being placed on a beta blocker. So the design is, if you're already on a beta blocker, there'll be a careful downtime. They'll be randomized either to continuing or discontinuing. So if you're discontinuing, it will be a carefully planned discontinuation, slow discontinuation. If you're continuing, we will recommend switch to a couple of beta blockers. I mean, a couple of beta blockers more to make sure that it's feasible worldwide. And we want to use newer beta blockers with more evidence. So we are advocating for carvedilol, bisoprolol, nebivolol, and if you're using metoprolol, the long extended release metoprolol.
That's great. So that would be a great trial to look forward to.
Yeah.
And, what about the field as such? What do you think is the future for ischemic heart disease?
So the field of ischemic heart disease is getting more interesting, and I think that's why it ties back because as you can see, there are more and more therapies, more and more efficacious therapies. But what we've been doing so far in the last 3 decades or so is we have had effective therapies back in the day, and then we add on medications. And there was, one of the recent articles looked at how many medications these patients are. On an average, many patients are on 10 different medications if you have stable coronary artery disease. The question is, when can we pull out some of the medications? So that's why this beta blocker trial is designed to deprescribe, take away older medications that were proven efficacious back in the day, but now you have more effective therapies, statins, reperfusion stuff. So I think, in addition to getting more effective therapies longer term, we need a mechanism to say, when can we actually take away medications proven back in the day, but maybe not as important these days. Because at the end of the day is medication compliance. If you have 10 medications on a patient, the compliance is going to be very poor. We need methods to actually maximize compliance, whether it's combination therapy or other means, because medications don't work if patients don't take them. So I think that's very critically important.
Right, great. So before we close, I just want to ask you one particular question about your thoughts on the inflammatory hypothesis. Now that CANTOS has been published, so what is your take on that?
So it's interesting. I mean, the inflammatory hypothesis has been talked about for a couple of decades now, and it's only now with the CANTOS trial we see a positive results. And of course, with the methotrexate trial being negative, so it's kind of a setback. But I must say that the CANTOS trial being what it is, I think has opened up more avenues. We need to test more. It's potentially that the difference in mechanism of action between methotrexate versus canakinumab may be driving this.
Methotrexate did not reduce.
It did not reduce CRP levels, and so I think there is a difference. So at least the field is open to target a novel pathway that we weren't routinely targeting in clinical practice. And of course, I mean, the medication is still not approved in the US, canakinumab. But I think that we'll see more and more trials targeting the inflammatory hypothesis. I know trials of using colchicine and stuff. So I think so far we've been targeting the lipid pathway, the thrombotic pathway, and I think this will be a very interesting avenue to test future medications.
Colchicine is a new canakinumab.
Yeah.
Anyway, great talking to you, Sripal.
Thank you. This is great. Thank you.
Good morning. This is Dr. Brian Pinto, the head of cardiology and the director of the cardiac catheterization laboratory at Holy Family Hospital in Bandra, Mumbai. And today I have with me a very good friend, Dr. Soumitra Kumar, who is the professor and the head at the Vivekananda Institute in Kolkata. But besides that, he's closer to me because we have been part of CSI. He's presently the Honorary Secretary General of the Cardiology Society of India, where we're having a wonderful conference this 2018, slightly preponed this time to the month of November, and it's all going very well. We're on the second day of the conference here in the morning, and Soumitra, welcome
Thank
to
you.
And let us get going with a topic which is
Sure,
close to both of our hearts, heart failure and the management, especially focusing on RNE. So Soumitra, I'm going to start initially with what are your thoughts on the burden of heart failure, both in the world as well as in India? Do you have some kind of insights into that?
The burden is actually huge and it's a global problem, but the main problem with our country is that it is very underreported. I mean, we have more of data pertaining to coronary artery disease and acute coronary syndrome, but as far as large-scale registries are concerned, we only have regional registries, but even going by that, the problem is actually huge. I mean, we do not actually have data regarding the entire burden of heart failure, but that should run into probably 10 million or so.
Maybe more.
Yeah.
But you know, what I'm looking at today is we have two parts of heart failure. We have heart failure with preserved ejection fraction, which was for some time called diastolic heart failure, and we have heart failure with the reduced ejection fraction. And now the ESC has brought up another kind of area of mid-range, which in some ways becomes a little confusing, but it falls neither here nor there. But we do have patients like that. So our discussion, I'm going to ask you one or two questions about preserved ejection fraction, because our concentration is going to be on heart failure with reduced ejection fraction. So Soumitra, when you see patients with preserved ejection fraction, what are those kind of patients that you normally see? And what's the kind of therapy that we have today for them?
Generally, HEPPEF patients are much less diagnosed than HEPREF patients, because HEPREF patients are very easy to pick up with a very simple echocardiogram. Everyone can tell you that the systolic function is impaired. But when it comes to HEPPEF, the echo apparently can look normal unless you are going for specific parameters. So unless the echo lab in question has looked into those parameters, often the diagnosis is missed. So that is a topic very close to my heart, because a lot of patients undiagnosed by many of the practitioners at the grassroots level do come to me with symptoms of long-standing breathlessness, and when we do those echo parameters and maybe at times supported by the biomarker studies, the NT-proBNP, those people are picked up. These are generally little elderly population and more of females.
And
female
maybe
population.
more hypertensive
and more lifestyle diseases that they have. The obesity is a big factor, diabetes, uncontrolled hypertension, and chronic kidney disease.
And sometimes we try to send them off to the pulmonologist when actually the echo can give us a lot of information. And I think we in our center have started doing the GLS, global longitudinal strain, for almost all patients. And I think there is there is not so much variability from observer to observer if it is done well.
Yeah, it is
so
it's
really
observer independent, and contrary to the popular belief that these HEPPEF patients do not have systolic function impairment, if you do a GLS, it will also show some degree of systolic function impairment as well.
Absolutely. So you actually add to the value when you're doing that.
Absolutely.
Unfortunately, is there any drug per se that works on?
I mean, that one of the tragedies about this HEPPEF segment. We do not have any disease-modifying drugs. Okay, it's fine that if we control hypertension and the comorbid problems, the obesity part, the diabetes part, the exercise part of it, it does improve the symptoms, but actually it does not change the prognosis. So we are still looking at some disease-modifying drugs or drugs with positive CVOT data from the trials, and one segment is of course ARNI, which we are looking for HEPPEF as well.
Correct.
And another are the new fascinating diabetes oral hypoglycemia, the SGLT2 inhibitors.
Absolutely.
Which we are looking for an answer in this segment.
So I think there could be answers in 2019, 2020.
Probably. We are very hopeful.
When the trials come, of both the ARNI with HFpEF and SGLT2 with HFpEF, we may have something in the pipeline.
Yes.
But we have to keep our fingers crossed for the moment.
Absolutely.
My next question to you, Soumitra, is related to the therapy that we use for our patients. And I somehow find that it is quite inadequate in many segments of our prescriptions. We see a lot of prescriptions with many add-on drugs which do not cause any change in mortality or even in morbidity for heart failure patients. So, drugs like beta blockers sometimes are missing, mineralocorticoid receptor antagonists, ACE inhibitors, and I'm talking about and for that matter, ivabradine also, when your heart rate is more. So I'd like you to emphasize on what do you think first about beta blockers in heart failure. Does it need to be given in every patient of chronic heart failure with reduced ejection fraction?
Absolutely, unless there is some very strong contraindication, which which fortunately for us are not there in majority of the patients.
Absolutely.
People are too skeptical about the lung problems that the patients may be having. Those lung problems may be secondary to heart failure only. So one should be bold enough to prescribe beta blockers in majority of our patients. In fact, patients who do have comorbid bronchial disease, carvedilol is a very good drug, good beta blocker for heart failure. But in those patients, probably beta-1 selective beta blockers are preferable, like metoprolol or bisoprolol for that matter.
Yes,
They are beta-1
yes.
selective. But other than that, you prescribe any of the three, metoprolol, bisoprolol, carvedilol, but do give it in the dosage that have been shown to produce results in randomized controlled trials, and those which are recommended in the guidelines. But the unfortunate thing is that in the most of the prescriptions that we see, either beta blockers have not been given, or they have been given in very, what should I say, minuscule dosage, which probably doesn't work.
Yeah.
So, and you have to, when you give it, you have to control the heart rate adequately.
Correct.
And if beta blockers are not enough, as you just mentioned, we should not hesitate to add ivabradine in those patients.
So I just want to know from you that what would be the dosages of, let us say, bisoprolol that you would like to go to? What would be the dosages of metoprolol that you would aim to get your patient up to, and the dosage of carvedilol?
You see, for bisoprolol, I mean, the flexibility is tremendous, and the dose titration is relatively simpler. That's what I find in my practice. The dosage that is available in the market, it starts from 1.25 and can go up to 10, 15, whatever is required. But do ensure that the patient gets adequate heart rate control below 70. I mean, that is the heart rate that has been shown to produce results. So it is in a comfortable range, but of course don't reduce it too much, less than 55 or so. So whatever dosage is required and as much as the patient can tolerate, we should go up. Similarly, for carvedilol, we should go up to 25 milligram BID or maybe 50 milligram BID. And for metoprolol also, starting dose maybe 25, but then 50, 100, and even if the patient tolerates, why not 200?
So actually we try to push up to 200, but
Yeah.
with metoprolol I find it rather difficult
Titration
to reach.
is difficult. As far as titration is concerned, I find bisoprolol the most user-friendly drug.
Most user-friendly to get to 10 milligrams,
Absolutely.
that is what is recommended.
Absolutely.
Carvedilol is good in my opinion when you have patients who have significant hypertension as well.
Yes.
Because if the patient has a high blood pressure, then carvedilol is the most powerful of the beta blockers to give you some additional
But incidentally, high HEPREP patients tend to have their BP quite low down.
Yeah, but if you have a patient who has hypertension,
one odd patient, you
but
can definitely.
On the other hand, if you have a patient who's hypotensive, then you may change from carvedilol to bisoprolol. So both ways.
Yeah, and in fact, if you bring down the heart rate, to your satisfaction, you will find actually the blood pressure picks up.
Oh, it does.
If you lower the heart rate, the blood pressure actually picks up.
And the patient feels better.
Patient feels better.
It takes some time. Sometimes the blood pressure goes down slightly and then again picks up.
Absolutely.
So first 4 to 6 weeks you may see a little drop. After that you will see a pickup in blood pressure, and your patient starts feeling better, and you can up titrate the dose every 4 weeks or so and get there. What about your, since we are on the topic of heart rate, we'll go on to ivabradine before we bring in the ACE inhibitor, because we'll take it in some. So when do you add ivabradine? I'm quite a fan of adding ivabradine.
Absolutely.
Even
I am. As I said, you should up titrate beta blockers to the maximum tolerated dosage. Yeah. If you find that there is still a room for lowering heart rate further, you should add ivabradine. Maybe you can start with a very low dose, 2.5 milligram BID, and go up to 5 BID, and 7.5 BID is the maximum recommended dose.
You don't need to go above that, but it's very important that you bring it in early. In fact, there's now talk of combining bisoprolol with ivabradine.
If the blood pressure to start with is low, where you cannot give adequate dose of beta blocker, start with both. That I often do.
You may even start sometimes, the blood pressure is very low.
You start with ivabradine and
then bring the beta blocker.
Absolutely. Actually, heart failure management is an art.
It's an art. It's an art and a science. Both.
Of course.
You have to be able to handle both sides of it.
Absolutely.
So, ivabradine, funnily, I wanted to ask you that when you give it, if the heart rate is faster, like when the heart rate is 90, I get much better response than when the heart rate is 70.
Yes, definitely.
So
I mean,
this kind of is because of the more amount, the larger number of the IF channels being open. So when more IF channels are open, you get a better response.
that is one good thing about Ivabradine, that the heart rate lowering is proportional to the initial heart rate.
That is
if
what
it is
so
90, it will come down quickly to 70. But if it is the initial, the
75,
beginning is at
sir.
75, it will only come down to 65. So really speaking, you don't have much hazard
Danger.
or danger of lowering heart rate too much.
which is such an important thing.
Very
because,
important.
you know, off-label, I also use it sometimes in patients who are on intra-aortic balloon pump and they are having a very fast heart rate. It's not indicated as in the guidelines, but we see the reduction in heart rate and the improvement in blood pressure because the heart gets more time to fill and pump. you know.
Sure.
So these are very important aspects that we see with Ivabradine and which we take forward. What is your take on the use of ACE inhibitors in our practice? And then we'll go further.
Yeah, ACE inhibitors again of the mandatory drugs, if I may call them so, which have to be prescribed in any patient with HEPREF, that is beta blockers, RAS blockers. ACE inhibitors are the first line, and
Yeah.
if not tolerated for some reason, then ARBs, and then mineralocorticoid receptor antagonists. So of these three, probably ACE inhibitors are most prescribed because they are the first to emerge in the HEPREF management. So they are mostly prescribed, but again, dosage is a problem. People
Dosage is a
don't go
problem.
up to the highest dose that is
I
recommended.
agree with you
Yeah.
completely. I think that they very often get stuck at the minuscule dose at which
Yeah,
they
I
have
mean,
been
if
started.
you give Ramipril 1.25 OD and or 2.5, you don't expect to achieve results with
So
that.
you must go to. So what are the doses? Let us take of the few drugs that we tend to use.
Yeah, Ramipril, of course, one should go up to 5 milligram BID. I mean, it's recommended BID. 10 milligram is a ceiling dose.
Yeah.
Again, perindopril is my favorite because dose titration is very easy.
Easy.
You 2, 4, 8 and stop.
You don't have to go beyond
But
8.
enalapril is a problem. You have
Up
to
to
go
20.
up to.
So
You
this
can
is
go higher,
but,
the better.
But, you know, but the
Lisinopril,
first trial
but-
came with enalapril.
Yeah.
Okay.
Enalapril is, I mean, still the standard drug because you remember in paradigm heart
It was
failure.
compared because that was the first drug.
First drug. So it has.
So you know, but you need to go up to 15, 20 milligrams of
So
enalapril.
people don't
and
do that.
People don't reach that. I
Yeah.
don't see a 10 milligram BID
Yeah.
dosage
Yeah.
of enalapril being given to patients very commonly. So I think, as you said, perindopril is a good choice, easy to titrate, not so much drop in blood pressure
Yeah.
also, and so is Ramipril. And but if you use enalapril, then you must titrate it up. You know?
Absolutely, absolutely.
Now, where is the scenario where you tend to use ARBs in place of ACE inhibitors? See, the data is so large with ACE inhibitors.
You see, number one, the data is large. Number two is that the intolerance to ACE inhibitors is probably over publicized. Not cough is a problem, but many people tend to tolerate it or be silent about it.
Yeah.
It is we physicians, we ask, do you cough? He said, okay, doctor, okay, then stop. I mean, unless the patient finds the cough quite, intolerable, one should stick to ACE inhibitors.
So you prefer ACE over ARB for heart failure?
I always prefer ACE to.
I think more data. I would also prescribe.
More data. There are skepticism about cardiovascular mortality with ARBs, at least initially. Now they have been removed. But whatever, ACE inhibitors are the first heart failure drugs that were reported.
Studied, reported.
So we should stick to that as far as possible. Other problems, angioedema, other things are very rare, fortunately. So most people tolerate 90 to 95% people tolerate ACE inhibitors. So that
What
5
about,
to 10%.
Yeah, if you had to start an ARB, which one would you choose?
Yeah, in heart failure, only few ARBs have data. So that's one. I am often taken by surprise to find that olmesartan is preferred
That is
for
not
heart
something
failure.
which is acceptable.
You should prescribe valsartan, which has the biggest data, and then losartan
Or
has some data,
candesartan.
or candesartan. So these are the three molecules
which have shown
some data.
Even
In heart
losartan
failure.
is the, I would say.
I would say in
and-
preference, valsartan and candesartan are the toppers. Yeah.
I would be the top two
Yeah,
ones in
absolutely,
ARBs
absolutely.
that you need to prescribe for
Yeah.
heart failure. I'm not talking about hypertension over here.
No.
We're talking about heart failure and the data with heart failure and also and so. What has been your experience, Soumitra, with mineralocorticoid receptor antagonists?
Yeah,
Now,
that-
I'm a
that
big user
is-
of that. Okay, so
Even I am, and that I think had it come first before ACE inhibitor, that would have swept the market.
I still use it before ACE inhibitors at times.
I do. I mean, that we are sitting together
Yeah.
is a very good coincidence that we conquer on so many points. It is a very good group of molecules. People who are given diuretics initially, they become the automatic first choice even before ACE inhibitor, because many of the acute heart failure patients are given diuretics. So you have to
You
give
can
a potassium
combine it
sparing
with the-
that combined with the MRA, and MRAs again should be given in the dosage that is prescribed. For eplerenone it is 25 to 50. Spironolactone for non-ischemic segment, one can go up to as high as possible, maybe 100 milligrams per day. There is
No,
no
it's
problem. But
fun-
there is a dosage 25 to 50 is the one that has shown results. So
Funny that you're mentioning this, because many people prescribe it in a very small dosage.
yeah, it doesn't work.
But you know, I think, Soumitra, the main concern is hyperkalemia with it.
Yeah.
If you can avoid hyperkalemia, you can step up on your dosage.
Absolutely.
So what I do is, if I find the creatinine values are a bit high and I still want to bring it in, I would start it with twice a week or alternate day dosing. You know,
I do that.
And if the potassium is ranging in the region of 5 or something, I would start it slowly, hold back the fruits, fruit juices, any other substances that may raise, potassium levels, and then bring it in slowly. So do you tend to,
Yeah, I often do that. As I said, heart failure management
Is art.
is quite an art. So you have to develop your own tricks how
Yeah.
to overcome
But the aim is
specific
to-
problems.
the aim
But
is to get-
but you should give it. You should not deprive your patients of the benefit of MRAs to the best extent possible.
In fact, what is in the data is that if your patient has a lower GFR, he gets more benefit out of
Absolutely.
an MRA.
That applies to
Both.
RAS blockers
Yes,
also.
both for cardiac as well as for renal.
Absolutely.
So it's protective not only for the heart, protective for the kidney, as you know, the cardio-renal axis. So clearly, these drugs, ACE inhibitors, ARBs, MRAs,
Absolutely.
and beta blockers.
And good news for us, some new potassium binders are coming.
come.
So Petairomar and
Petomia is one of
ZS9,
them.
and they are
Yes.
coming. So that should make our life easier.
So we
as
can
well.
use them,
In
and they will bind
conjunction.
to the potassium in the gut itself.
yeah.
So, bring down the potassium
Absolutely.
values, and with them coming, I think we will be able to use mineralocorticoid receptors, because the number of prescriptions for MRAs is extremely low.
Absolutely. Absolutely. I don't think that in general practice more than 10 to 15% patients get MRAs.
Yeah.
So
that's a very
that percentage should go
up. I think education is very
at
important.
least 60-70% of people should get MRAs.
more than that also, but I think that's.
I mean, at times
the
with
times we
RAS
can't give,
blockers,
because
hyperkalemia is indeed
is
a problem. But
is indeed a
but
problem.
then
Yeah. So now, stepping forward to the area of the new agents, I will talk to you about Arni now, which has recently come to our markets. The combination of valsartan with sacubitril in a salt, which has been in 3 dosage forms, and the paradigm trial. We can go a little bit into it, but what is your kind of thought process on using Arni up front? Let's take in 2 situations. One is according to the paradigm trial, that means the patient is about 3 months out of the acute event. And do you tend to run in your patients with ACE inhibitors first, or ARBs, and then switch to Arni, or do you bring them in directly? And at what left ventricular ejection fraction do you think that you would bring this drug in?
in the paradigm heart failure, the ejection fraction cutoff was initially 40%, then it was brought down to 35%. So that is the segment obviously we should target. Of course, one has to develop some kind of familiarity with a new molecule. So initially we have been only prescribing to patients who have tolerated ACE inhibitors in the significantly good dosage, both in terms of blood pressure, also in terms of renal parameters, the creatinine and the hyperkalemia. So once they have tolerated this, we were switching patients from ACE inhibitors after a 36 hours gap to Arni. If they have been on ARBs, we were switching straight away. So that has been our maybe the second or third OPD visit from the discharge point. We were starting on Arnis. But now new trials are coming in the transition, the pioneer heart failure, which are telling us that probably you can start them in a RAS naive patients. So those who have never been prescribed RAS blockers, you can start Arni probably in a low dose to start with 50 BID. and then build it up. And the safety parameters are there, the efficacy parameters are just beginning to emerge. In terms of biomarkers, in the pioneer heart failure, has been a significant reduction right from the first week in NT-proBNP with ARNI as compared to enalapril. And remember, the first re-hospitalization for heart failure takes place in a big chunk of patients in the first month. So if you have a early result from ARNI which is superior to enalapril, as early as first week from discharge, you can prevent a large number of rehospitalizations.
From rehospitalizations.
Yeah.
How, coming back to this point which you brought up about NT-proBNP, how often do you use the NT-proBNP in your practice?
NT-proBNP, for that matter, one should not estimate BNP at all if you are using ARNI, because BNP is one
which will go up.
Will go up. So NT-proBNP is the only biomarker to be considered if you are treating with ARNI. NT-proBNP, to be frank, I don't use in all patients. We have a very active echocardiography lab which tells us about all the hemodynamic parameters and which tells me how we are monitoring. It tells me about the left atrial pressure, the right atrial pressure, how am I controlling both. So I use it very selectively. There are odd patients where I'm still in a dilemma whether the patient has heart failure in the first place, and if I have treated the patient, whether I have treated the patient adequately or not. So I'm rather selective about use of NT-proBNP, but I do
I
use
think
it.
that you are in a very privileged situation of having such a powerful echocardiography lab. But I think for the general people, I think NT-proBNP makes a lot of sense.
Fully agree.
Because if you come in and, I was presenting yesterday on biomarkers, there are almost 60-70% of patients in heart failure who you may not be able to make up your mind about, whether they are really in heart failure, they have a respiratory origin, so on and so forth, or a combination of them. And therefore, the NT-proBNP at the time in the emergency room can give you a tremendous information. So suppose you get your NT-proBNP in thousands, and your echo lab is not open, you have a clear-cut indication. And one more thing I want to say is that what is more important is the at discharge NT-proBNP, especially if you bring ARNI in early, will give you a prognostic indicator of how this patient is going to fare. Lower the NT, for example, if it is 1500 first and it's come down to 400 now, you have a patient who is going to fare much better than a level who gets discharged at 800 or 1000. At his euvolemic status, if he's 1000, he is in a worse situation than this. But repeating it afterwards, in the case, is not proven to be so useful as in a guided study. Guided study showed that then the benefit was not so much. But these two are important.
But only problem is with a serial test is, of course, the financial part of it.
Correct.
A good surrogate, I will tell you, is just having a look at the IVC. Okay, and that's a very easy thing to do. Any one of us can do it. Just put your probe on the abdomen and
take
find
the
out.
daily weight also.
Daily weight and IVC can be a poor man's surrogate for NT-proBNP.
I agree with you completely. That's a very good point that you brought in. But I just want to now understand from you about your use of ST2. Do you use ST2?
Again, I would say no, because it's quite costly. Not widely available, but in odd patients, I mean, if you think that this patient could be a candidate for advanced devices or cardiac transplant, you have to identify them early. Okay, so if you think this person is not going to improve with time, he is going to decline, I mean, in terms of his heart failure parameters, ST2 tells you about the long-term prognosis and the cardiac remodeling that the patient is going to have.
Very good point.
So if you have to pick the patients up for advanced treatment, so ST2 should be a very good parameter.
What happens is that even say you have a large anterior wall myocardial infarction and the ST2, let's say, is high at 170, but at discharge you get him down to below 35. He's a better prognosis than a patient who continues to remain high. So you can prognosticate.
So if you want to identify those...
the costs we have been able to bring down in Mumbai. So, it's not so cost ineffective.
With higher number of prescriptions, cost will come down.
And then it allows us also the fact that in this group of patients, you can start ARNI faster.
Yes.
So it will give you that indicator that, this patient is going in for fibrosis, It's a marker of fibrosis. It marks fibrosis elsewhere also, unfortunately. So if you have pulmonary fibrosis also, your ST2 values will be high. So you have to know, and you cannot be stupid while testing your biomarkers.
Yeah, same applies to NT-proBNP. It is a age-related values are there,
Age-related,
and then there are other
renal-related.
things like sepsis and other things which will
Can raise both.
So
you have to be careful about that. A little word with you about SGLT2. It's the new kid on the block. We are running alongside army.
As I was hopefully projecting that ultimately it will become a heart failure drug rather than oral hypoglycemic molecule.
Appears to be
and probably it will be used in non-diabetic subjects as well.
60-70% in the new trials, the Emperor reduced and Emperor preserved, have 60% of patients.
I'll tell you why I'm so hopeful. It's not just a blank projection or something like that. It has definite effect on the heart.
Yeah.
It reduces LV mass.
Correct.
It acts on the myocardial interstitium.
Absolutely.
And it has effect on myocellular energetics. It has a shift in favor of more energy efficient fuels like the ketone bodies and other things. From every point of view, it is a heart failure friendly drug.
It may be more heart failure than diabetes.
Absolutely,
in the
absolutely.
Future. And one more thing, I think what is underutilized in our country still is the use of CRT for patients who have got wide QRS complex, especially LBBB, and some patients with RBBB also who have a QRS
very
more
wide,
than 150, so 180. So I think that, and LVADs and cardiac transplant, we can pick up these patients. So heart failure can really be a spectrum,
So it's a huge spectrum. We should start with prevention of heart failure, then medical management.
Prevent the risk factors.
Yeah.
All the risk factors.
Prevent risk factors,
diabetes,
identify patients, and treat them very aggressively.
Start with primordial prevention.
Absolutely.
Teach young children what are bad. Exercise is adequate. Walk every day.
Weight control.
Be active. American Heart Guideline now. Keep your weight under control. See that if you are likely to become diabetic, control your diet and control your weight. So all the preventive measures should also come in.
Absolutely.
Now in a lighter vein, let me take you, Soumitra, through what are your hobbies and what do you enjoy?
Hobbies have been put on a shelf for the time being because I hardly have time. But I am avid music addict, so I love both Western and Eastern varieties of music.
We both do the same then.
Yeah. So I am, and I used to be a sports lover as well. I used to be a table tennis champion in my medical college days. I did play lawn tennis also for a fairly long time, but unfortunately, as I said,
but we must start again.
Yeah. So looking forward to maybe in another 3 years, I'll retire from lot of activity. I'll restrict them and take up lawn tennis. I can't play singles anymore, but probably I'll play the doubles.
It may be more interesting also.
Yeah.
You could also play mixed doubles.
Why not?
So I think, we have had a wonderful chat.
Sure, it was absolutely a pleasure talking to you.
Amazing talking to you, and thank you so much.
I enjoyed every bit of it. Thank you, Brian. Thank you.
Thank you
very much.
I am Dr. Nitin Burkule from Mumbai. We have a very exciting topic here about the myocardial imaging. With me, we have got very distinguished panelists. On my right is Dr. Jagat Narula. He is the Director of Cardiac Imaging at Mount Sinai Hospital, New York, and also is Associate Dean with the ICANN School of Medicine. And we have Dr. Jerome Bax. He is the Director of the Echocardiography and Non-Invasive Lab at University of Leiden, and as you know that he is the past President of European Society of Cardiology. Welcome you on the CSI TV. We will start with the tremendous progress that has been done in the multimodality imaging of the myocardium, the echocardiography, the CT and the MRI, and we'll see what promise it holds, what the technology has achieved now and what promise it holds in future. So we'll start with the echocardiography, and as you know, the nuclear kid on the block has been the deformation imaging by speckle tracking echocardiography. And I'll ask Dr. Jerome, what is the current status of the global longitudinal strain in echocardiography, whether it has really shaken the pedestal of ejection fraction, where exactly the clinician should be using it, and what is the future promise with the speckle tracking echocardiography. Dr. Jerome.
Well, thank you very much. It's a pleasure to be here, and I think the strain is something that has become very useful for us. We are used to measure left ventricular performance by looking at ejection fraction. And ejection fraction, if you carefully analyze, is basically nothing different than the amount of volume of blood that's in the ventricle and the amount of volume of blood that's leaving the ventricle during systole. So the ratio of what is in and what goes out is what determines the ejection fraction. So the ejection fraction is not directly reflecting what is happening in the muscle. And if we talk about how good or how bad one's heart is performing, the first thing that we ask is what is the ejection fraction. But you will start to realize when you look at patients, let's say patients that have had radiation for oncology or they had chemotherapy for oncology, the ones with a, let's say, almost normal ejection fraction, if you look at the strain, which is the deformation of the myocardium, which is really showing what's happening in the myocardium, then you see that often where the ejection fraction is normal, that the strain has already become reduced. So the strain is more sensitive because it depicts what actually is happening in the muscle and is not dependent on loading of the ventricle. The other where you could use it very well is when you have a very low ejection fraction. So we just discussed about high ejection fractions, normal ejection fraction, where strain can already show that something is going on. I gave you the example of radiation or chemotherapy, but there's also the issue of severe aortic stenosis, where your ventricle seems totally normal, but if you do the strain map, you see that the strain is already reduced. Now let's go to the other extreme where the ejection fraction is very low. That can be, for example, in mitral regurgitation, severe mitral regurgitation. When we see a heart that's moving like this, then we see an ejection fraction that's still 30%. And you ask yourself, that cannot be, because the heart is not doing anything. But if you look then with ejection fraction volume in, volume out, you see that half of the volume out goes in the left atrium. So this is not the performance of the ventricle. This is just volume that is in and volume is going out. If you measure the strain in severe mitral regurgitation, despite the relatively okay ejection fraction, you see that the strain is way, way, way reduced. So I come to the point that in the very high ejection fractions, the very low ejection fractions, strain gives us more because it shows to you what is really happening at the level of the myocardium. So we need to start thinking different, no longer looking at ejection fraction, but asking ourselves, how well is this muscle of the ventricle performing? And if you do that, you come to strain and you see that it's quite often different than an ejection fraction.
Let me ask a question, Nitinji, from Giron. GLS, as you know, are the global longitudinal strain, as you very well know, not the regional one, but essentially the global. And all that is just based on the convenience of measuring it. And leaving aside the convenience, what do you think, how exactly would you be able to add the global circumferential strain on it or regional circumferential strain on it? Because no ventricular mechanism will be complete unless you bring in the circumferential forces. I'm not bringing in the radial forces, but I'm bringing in the circumferential forces, number one. And number two, would you really like to involve the vortex velocity also into it as to how exactly the blood transport occurs through the ventricular chamber? Would that be able to assist us and make the strain as a more complete parameter?
Well, thank you. For the moment, we're just learning that there is more than ejection fraction. And by doing that, we start understanding what is ejection fraction. As I said, volume in, volume out. So we're shifting away from the volume shifts going to the ventricle and really looking at what's happening in this ventricle. If we start doing that, we started with the longitudinal strain, which is the up and down deformation. But as you rightly point out, there are two other forms of strain. One is the inward strain, which is what we call the radial strain, and one is the rotational strain, which is called the circumferential strain. So for the complete picture of a heart, like Torrance Guasp already indicated, We need to look at the up and down, the inwards, and bring it together with the deformation in the circumferential region. If you want to have eventually the full picture of a ventricle, what it's doing, you need to combine those three. For the moment, for convenience, we're just starting with the longitudinal global strain. But you anticipate rightly that in the future we start to think three-dimensional, and with the three-dimensional comes these other two forms of strain. It's quite complex, so we should not make the things too complex and keep it practical. For the moment, what I advise to you is the global longitudinal strain is more sensitive than an ejection fraction because it focuses on the muscle. If you want to make steps forward in the future and you want to understand certain pathophysiologies better, maybe predict outcomes even better, you could anticipate that we're going to use these three types of strain in an integrated model which drives us in the direction of three-dimensional imaging.
That's great, Dr. Jerome. Since we are on the myocardial imaging, as you know that you are also an expert in CMR, we know that the new things that in the CMR advances have been the established role of late gadolinium enhancement and also the evolving role of T1 mapping and the extracellular volume mapping. So can you just give an insight for the clinical cardiologist, what does actually the T1 and ECV mean? And then I'll go to Dr. Jagat Narula and I'll ask him whether all these three modalities, how they help us in differentiating the cardiomyopathies. So Dr. Jerome?
Yes, very good point. I believe that every disease has three components. It has an anatomical component, anatomical abnormalities. These are then superimposed or resulting in, I should say, in a functional abnormality. So let's take, if you have a stenosis in your coronary arteries, then the functional consequences are a reduced FFR. Or let's say if we have scar formation, the functional consequences is a reduction in function. So you have an anatomical component, then you have a functional component, and the third component is an inflammatory component. And every disease is characterized by these three components. Now if we talk about CMR, CMR is very good in anatomical assessments. So we have learned to work with the late gadolinium enhancements. Using the contrast, we see very clearly on an MRI this white dense tissue, and that is macroscopic infarcted tissue or macroscopic fibrosis. The more we have been starting to use the T1 mapping, which is a non-contrast imaging, we actually see that there is differences in extracellular volume. And extracellular volume means more fibrosis. If the cells disappear and extracellular volume gets bigger, means that more fibrosis is becoming. We cannot visualize that, but we can measure it with the T1 mapping. And so let me give you two diseases. If we look at severe aortic stenosis, the walls get thicker and thicker, you get septal hypertrophy. As a consequence, the perfusion is not supportive enough for this thickened wall. So what happens? You get mid-wall fibrosis formation. That's one where the T1 mapping is excellent. The other one is mitral regurgitation. There it's not a pressure overload like aortic stenosis, but it's a volume overload like mitral regurgitation. So ventricle dilate, dilate, dilate. At some moment the ventricle cannot handle anymore and it's becoming too stretched. So fibrosis is going to be formed. So these two are excellent examples of where the T1 mapping can help us seeing if this ventricle is still okay or too much fibrosis is coming. Late gadolinium is visual, what you see, the white, dense, macroscopic scar. Fibrosis formation with the T1 mapping, measuring extracellular volume, reflecting the amount of fibrosis you cannot visualize, but you can quantify it. And I believe that if we want a better time, for example, when we need to change the valve in aortic stenosis, when we need to repair or replace the valve in mitral regurgitation, we need to understand how much fibrosis there is in the ventricle. And that's where T1 mapping is going to play a big role.
So it pertains to the myocardial health in that individual patient. That's a very good point. I'll come to Dr. Narula, because you know he has given us a new classification of cardiomyopathies. So how does this MRI helps, especially in the diagnosis and prognosis of various cardiomyopathies?
Excellent question, Nitinji, again. So as Dr. Bax just suggested, that this difference in the relaxation times between the myocyte compartment and the interstitial compartment, that gives an excellent index of prognosis in the patients with cardiomyopathy. Now, as you very well know, that T1 mapping, native T1 mapping, does even better than the late gadolinium enhancement, specifically in the dilated varieties, where you may not have a significant amount of replacement fibrosis and you may have the extracellular volume expansion. Now, it is our belief that every patient with cardiomyopathy at least has to have one CMR in his or her lifetime. It is extremely important that we characterize these patients. It will not only be able to ensure the type of cardiomyopathies that we are talking of, it will also be able to prognosticate. It probably would be able to help us in identifying the people who are likely to benefit by the defibrillator therapies or some of the other areas which could be specifically addressed, specifically in the types of cardiomyopathies which may have specific telltale features of cardiomyopathy.
Excellent. So I think if we take a classical example of say hypertrophic cardiomyopathy, then I have a question for both of you. How does the echo and MRI is going to help us in deciding about the say ICD therapy and also for prognostication?
So I think that the scar formation or the fibrosis formation is probably a trigger for electrical instability. And electrical instability translates probably in ventricular arrhythmias, and ventricular arrhythmias could result in sudden death. So if we want to use the ICD to counter that, then probably one way, and people are building evidence at the moment, one way to risk stratify who would benefit from ICD therapy, let's say in ischemic cardiomyopathy, would be measuring the extent of scar tissue. One way to do it in a non-ischemic cardiomyopathy would be by measuring the extent of fibrosis, the non-visible fibrosis at the T1 mapping. There is already some small studies indicating that, but it's still not enough in guidelines to support that. I believe that guidelines are very good, and we need to have evidence to support what we're doing. But guidelines are very large trials, and if you look within these large trials, you always have different phenotypes who respond differently. So the counterpart of guidelines, if you like, is the personalized medicine.
Yeah.
And if you want a more personalized medicine, the way to go forward is better phenotyping the substrate of the disease. And if you want a better phenotype substrate of the disease, you come to imaging. So I believe that this imaging may help on top of guidelines that exist to better phenotype, to avoid that we implant too many ICDs in patients that don't benefit. And at the same time, we could look at patients with a higher ejection fraction where there is already significant fibrosis, considering that they may be candidates for ICD therapy as well. So it will better allow, hopefully in the future, selecting the patients that have the most benefit from ICD implantation.
So I will add on that essentially, and that's what you exactly wanted me to speak about. So as Dr. Bax just suggested that we have to characterize the cardiomyopathies better so as to have the ICD therapy and all, I would say that essentially the basis of this phenotype is obviously the genotype.
True.
Right? So ESC actually in their guidelines have already started approaching that topic. We haven't started doing that as effectively in the ACC and AHA guidelines, but ESC specifically when we talk about the hypertrophic cardiomyopathy, they have started to talk a lot about it. For example, a patient with myosin defect in hypertrophic cardiomyopathy, like with the myosin heavy chain defect and all, you require a significant amount of myocardial hypertrophy to occur before you are advised or you are recommended to have the defibrillator therapy. On the contrary, in cases of troponin defects or troponin genotype here, you may need a very little amount of a hypertrophy, and the patient may have more arrhythmogenic potential. So basically we would need to characterize it, we will need to balance the genotype or phenotype, and exactly as Jeroen just said about the dilated cardiomyopathies, for example, in the patients with dystrophinopathies, in the dilated cardiomyopathy, you may not require, even if the ejection fraction is lower, although by the guideline, we are bound to give the defibrillators, there may be a reason to consider or reconsider in these patients, because they may not be as amenable to the arrhythmia as a patient with Lemon cardiomyopathy will be. So a patient with Lemonopathy, even at 45% ejection fraction, may be a candidate for the defibrillator therapy, but as the current guideline stands, this patient has to die first to be able to deserve a defibrillator. So essentially it will have to be a combination of, as Dr. Bax just said, the phenotype, and we will really need to go further with the genotype also. So we need a more comprehensive picture when we need to make the decision. So obviously we are not there.
True.
And guidelines are still not there. We really need to work towards it.
True. So the imaging is going to play a very important role in the management of these cardiomyopathies. So I think we'll shift the gears and enter into the CT imaging of the heart. Now from the clinical cardiologist perspective, what is the role of calcium scoring of the coronaries for risk stratification of an asymptomatic individual? So when should a clinician ask for a CT calcium scoring and what it impacts his decision making in managing the patient? Dr. Jerome?
Okay, so the calcium score is the easiest way of looking at the CT scan. You just look at the amount of calcium being present. One of the things that I think is very important, you started with the word asymptomatic. If you have patients that are symptomatic, you should not use the calcium score, because those patients may present at a very early stage of coronary artery disease and have non-calcified lesions, which may be, as you will indicate later, more vulnerable.
True.
So stable patients, either symptomatic or asymptomatic, you can do a calcium score as a first test. I think it's a very good test. I think it's a test that shows immediately how much calcium is, which is a surrogate marker of the amount of calcified atherosclerosis there is in a coronary artery. And the more it is, the higher your likelihood of eventually cardiovascular events. That has been shown. I think as a first screener, it's perfect. You can use it both in symptomatic patients as a rule in, rule out, but you can also use it in asymptomatic patients, because if patients are at high risk, multiple risk factors, we have learned indeed that the majority do have calcium, but there's also a part, maybe 20%, that do not have any calcium at all. Strange enough, you can have a lot of risk factors, but still have no atherosclerosis calcified.
True.
So I think it's a very good first risk marker. In which patients, I think we start using it more and more at a very low threshold. And in some countries, patients can self-refer because they're worried about their health. I think this is not a bad development, because people are engaging in being responsible for their health. So they want to see what's going on. So I think, just to summarize, it's a very good marker of the extent of atherosclerosis calcified in your vessels, and you can use it in symptomatic and asymptomatic patients as a first screener.
True. And once you have a visual impression, it will definitely impact your lifestyle and also probably escalate the use of statins.
Absolutely.
Now the thing is, from the CT calcium score, as we know, the CT has advanced to an extraordinary imaging of coronaries, and now we have reached a stage where we are having plaque characterization and also the CT FFR imaging. So I'll ask Dr. Narula, where exactly in the management pathway of the ischemic heart disease patient, where exactly this piece of CT FFR fits in a clinical cardiologist practice?
So, well, I think I'll have to slightly rephrase your question here.
Yeah.
And I would say that when you are talking about the CT angiography, I truly think that there is a lot to consider about the CT angiography in the stable coronary artery disease patients, and for the decision about the revascularization in these cases. Now, the revascularization in the patients who have a stable disease has been quite contentious, as you know. Now, to the extent that last year when the Orbiter trial came in, it almost told us that the stents are not going to be helping us. On the contrary, we have seen it for the numbers of years, or rather decades, that the coronary revascularization did well in the patients with triple vessel disease, specifically with the included left main disease, when there was the inducible ejection fraction, inducible ischemia or low ejection fraction in these cases, that the revascularization did better than the optimal medical therapy, which was time sensitive optimal medical therapy. It may not have been the same what we have today. Now, when we do these studies in today's day and age, as you have seen in the Courage trial or as you have seen in the Barry 2D trial, that this did not succeed. The revascularization was something similar to what the optimal medical therapy was, and that is the time when we started to realize that is FFR the way to go? Should we be looking at the functional impact of the stenosis and go with that? And then came the FAME family of trials, both the FAME and FAME 2, that clearly told you that the fractional flow reserve determined or guided therapy or revascularization was superior to the angiographically guided therapy. And not only that, if the FFR was abnormal, if you treated them with medical therapy versus with the revascularization did particularly better. However, if you really tease the data of the FAME study, and also was later on confirmed by the FAME 2 also, the essential advantage of the FFR was when we looked at the people who had normal FFR, that the people who had normal FFR did quite well. Not that all the people who have got the abnormal FFR are likely to have the event. The likelihood of event is going to be approximately 8%. So positive predictive value would be to that range, while the negative predictive value was to the tune of 2 per 1,000, in the sense that 2 people will have an episode out of 1,000 people if you really had a negative FFR. So FFR brings us quite close to a ideal negative predictive value. Now, why is it that the positive predictive value is not as good? That happens with all possible tests that are available to us. They all have a lot to do, because for an event to happen, you really require a perfect storm. There are multiple things that have to converge so as to create a situation where the person is going to result into an event. And most important out of them happens to be the plaque characteristic, as you mentioned, that the patient has to have a plaque which is a vulnerable plaque or a high risk plaque. Now the question here is that every high risk plaque is going to result in the same thing? No. Again, the same thing, the positive predictive value for the plaque ranges between somewhere around 12% to approximately 25%. But essentially, again, it correlates with the FFR. If the plaque is not a high risk plaque, the FFR is going to be normal. Right? Yeah. So it is a good surrogate for that. Yeah. If the plaque is abnormal, it is likely to give you an FFR which is abnormal. So something which is sitting in the lumen, that is the luminal stenosis, or something which is sitting outside the lumen, which is the large low attenuation plaques, they basically contribute to the abnormality of FFR. And I mean, we recently suggested that, but I would like to mention that Giron happened to be one of the first people who had proposed this concept, and I remember having taken that paper for the JACC imaging when there was so much of an opposition because he was going against the stream of what is currently believed. So basically, are we going to be able to say that FFR gives us an outstanding negative predictive value? Should we be able to exclude those patients who are likely to do very well, regardless of the amount of these stenosis, who are likely to do very well on the optimal medical therapy and proving what the Courage and the Barry 2D trials showed us. So, as it stands, CT-FFR would be able to give us or CT angiography should be able to give us a triply effective phenomenon, including all the stenosis of the plaque, or stenosis induced by the plaque characterization, which is likely to contribute to it, and finally the FFR also, making it probably a preferable therapy or preferable diagnostic modality which we should explore further. I do not want to compare them to the functional status and all, because we have seen multiple trials, but I would stop there by saying that this has immense potential which needs to be fully evaluated in the coming days.
Excellent. So it's the plaque characterization and the FFR will be a very strong point of CT imaging for deciding the prognostication and the outcome of the patient. So I think here we'll again go back to the CMR. And so what do you see the role of CMR in deciding the culprit lesion, especially in the non-ST elevation MIs, where you are not very sure about the culprit vessel, and as we have seen from the FAME trials that unless you revascularize only the culprit vessel, your outcome is not that good. So can you elaborate on that?
Yeah, I think the non-invasive imaging in general is very good in assessing again the functional consequences of the anatomical significant lesion, responsible lesion if you like. And what we can do with the non-invasive imaging is look at the consequences of what's being developed is ischemia. And the ischemia we can measure in different ways. We can look at the changes in regional and global ventricular function, including strain, changes during stress. And we can also look at the changes in perfusion following a stressor. So we can do either functional or motional imaging, or we can do ischemia imaging in terms of perfusion imaging. You can do that with any technique. You can do that with a nuclear scan, you can do that with an echo, and you can do it probably the most high resolution with an MRI. And if your question is specifically which territory is the problematic territory relating to this or that vessel, and probably your first choice would be an MRI. I know that from the Danami sub-study, they have one article coming soon on the use of this. So MRI looking either at dobutamine-induced wall motion abnormalities, but maybe even preferred because it's more sensitive, is the perfusion imaging with CMR.
True. So the CMR, if you really look at it, and specifically as you were asking about the high-risk plaques and all, the techniques are not very advanced at this point in time, not prevalent at this time, but very elegant work that comes from Japan, specifically from Teruo Noguchi's group from Osaka, where they are looking at the plaque to myocardial ratios on the native T1 mapping of the plaque. And essentially they are trying to tell us again the same story, that whenever there is the high plaque to myocardial ratio, plaque to myocardial ratio, it correlates so well with the FFR. Essentially, regardless of the stenosis, if the PMR is high, you basically find that these plaques would result in the abnormal FFR regardless of the stenosis. So that is an upcoming technique which you will be seeing more often in future.
And Dr. Narula, with your nuclear imaging background, can you shed us light on what are the advances in the nuclear imaging for myocardium, which is going to change the future or the way we manage the patients?
So nuclear imaging, as you very well know, specifically with the single photon imaging, you very well know that it has the most important historical role to play in the patient management, specifically for the assessment of the ischemia in these patients. It is time-tested technology, largest number of patients that it has been tested upon, and gives us the value. Now, essentially in the coming years, the most important expectation is that we would have the PET related radio tracers or the positron emission tomography, quite like flopyridaz and all, which are undergoing the testing at this point in time, and we might be able to identify the myocardial perfusion at a much better level with the quantitative assessment, so many milliliters per minute per gram of the myocardium. And I think the major role of the functional imaging is going to be specifically that from PET more so than SPECT, is going to be in the patients who are the patients with known coronary artery disease. Unknown coronary artery disease, probably we would be going more with the CT angiography, but the known coronary arteries, we probably would be more focused upon the functional imaging, and if the PET becomes available, it will be a great achievement. The second important area which I think is going to be picking up is the neuronal imaging. A lot of PET tracers are now coming up, quite like the MFBG and all, which are under trials, which will be able to address the neuronal component. So we have talked about the myocytes, we have talked about the interstitial imaging, but we have not talked about the neuronal imaging, which may have an important role to play both in the assessment in terms of prognosis of the patients with heart failure, as well as for the assessment of the patients who are likely to be needing the defibrillator therapy or ICDs in the patients with low ejection fraction.
Good morning, friends. I am Dr. Nitin Burkule from Mumbai. And with me, the panelist is Dr. Mona Bhatia. She is the Director of Cardiac Imaging at Fortis Escort Hospital, New Delhi. And we will be discussing about the multimodality imaging of the heart. As you know that the most of the clinical cardiologists are doing echocardiography, and that remains the mainstay of imaging. And we'll discuss with Dr. Mona Bhatia how the CT and MR are going to enhance this imaging and help in managing our patients. So we'll start with the first kind of a scenario that we have the patients who comes with chest pain, and he doesn't have many coronary risk factors, but you find the troponins going high, and you are wondering he has got tachycardia, and you are wondering that he looks sick, whether he has got some myocarditis. So the thing is, can you elaborate how the CMR will help us in diagnosis and also the prognostication of these patients who are having troughs high, have chest pains, but normal coronaries?
You're very right, Dr. Nitin. This is absolutely the condition that happens. In our country, we get a very large number of patients who are the chameleons. They're the patients who come with troponin positive chest pain. Their coronary angios, or whichever way they have assessed their coronaries, they find them to be non-obstructive and relatively normal. And then the question is, what is it that they have? The echoes may or may not show functional abnormality, and then they come down to MR. In our hospital, in fact, we consider cardiac MR almost as an emergency procedure when we're thinking of a myocarditis, because these are not infrequently little children in our country. They have respiratory distress, they come and then they suddenly have a dilated cardiomyopathy, or they have a situation where their function has gone down to very low levels, even less than 20% of the left ventricular ejection fraction. So what we do is we do an MRI. On the MRI, the best thing about MRI currently is that one, it is the gold standard for functional evaluation. So we get a very precise documentation of the ejection fraction. The second thing is that myocardial characterization is very well done on CMR. So we can actually tell areas of edema. The question often is that what will be the prognostication of these children? So a lot of them also get IVIG immediately after we see the edema, so that we actually prevent fibrosis and any deterioration. We in fact have children who have gone into relapses also and come back with recurrent situations of myocarditis. Such situations also exist in our country. So it's very important to establish the etiology of these situations of myocarditis and to prognosticate them. As far as etiology is concerned, we have tuberculosis, and then we have other viral myocarditis, and depending on the extent of late gadolinium enhancement, we can actually assess if there are granulomas within the myocardium, and if we can actually document them as tuberculosis or any other form of granulomatous involvement. We also want to evaluate fibrosis, because if fibrosis does set in, then the prognostic value of this test is a lot more, and then we have the chance of MACE events also increases. So one has to be very aware not only of function myocardial edema, but also fibrosis, all of which together actually make a tremendous tool in prognosticating these patients. The recent situation is we also have T1 mapping that is possible on cardiac MR. Using T1 mapping, we can actually tell where is fluid within the extracellular space and where there is T1 mapping helping us. So even without contrast, we can evaluate what are the areas and not only prognosticate but follow up these patients even without giving gadolinium to assess how they are doing and how the areas of edema are doing.
That's excellent. So the myocardium, the CMR is a great tool to characterize the myocardium, because at the ultrasound level we are not able to distinguish between an inflammation and the amount of fibrosis, and especially pinpointing the diagnosis. Now the thing is, there is a lot of complacency when you have got a patient with chest pain, trops high, but the coronaries are normal. But actually when you do the CMR and give this diagnosis of myocardial inflammation, actually their acute events are as high as the acute coronary syndrome, and also their mortality is also as high as the acute coronary syndrome. So there should not be any place of complacency, and MRI should be definitely ordered at that time. So I have a question to you is, from the patterns of this edema and the lead gadolinium enhancement and the other tools of edema imaging, can you differentiate whether it is a viral myocarditis versus a sarcoidosis, or whether it's a tuberculosis or any infiltrative cardiomyopathy? Is there a way that the cardiac MRI can give us a histology level of diagnosis?
Absolutely. So the late gadolinium enhancement is actually an excellent tool, and depending on the location, we can actually tell you what is the nature of the non-ischemic cardiomyopathy that is taking place. So while the ischemic cardiomyopathy happens in the subendocardial space and then goes on to a transmural waveform, in which case it also follows a coronary artery territory, whereas the non-ischemic cardiomyopathies are usually more mid-wall and subepicardial. We also find that in sarcoid, they're more along the RV aspect of the septum. Viral myocarditis has its own nuances and its own situations, and particularly with tuberculosis, not infrequently we see small granulomas. So depending on the nature of the infection, inflammation, we can actually come to some sort of an etiology on the nature of the non-ischemic cardiomyopathy. In situations like hypertrophic cardiomyopathy, we have an interstitial fibrosis that takes place in the entire hypertrophic myocardium. But in addition, we also have scars which help to then prognosticate these patients and then tell us what will be whether these patients actually need to go in for ICDs. There are also situations like amyloid, where not only does T1 mapping help us to a great extent, because it almost helps us to tell whenever there is a thickened myocardium, whether it's an infiltrative form, and particularly with amyloid, it can even tell you the nature of the amyloid that has been deposited within the myocardium. And in addition, we also have a very typical global circumferential subendocardial enhancement that happens in amyloid. So different natures of late gadolinium enhancement actually help us to differentiate the nature of the problem, the etiology, and prognosticate these patients. Because whenever we have a quantification of the late GAD enhancement, that then takes us to the level of actually predicting future MACE events.
That is great. So actually where the echo leaves, the MRI takes over. Like where the echo shows an LV dysfunction or a regional wall motion abnormality or just an hypertrophied ventricle. And the further characterization, I think the CMR takes a lead, because that has got not only the etiological significance or prognostic significance, it has got a direct impact on your treatment.
Absolutely.
Because when you have diagnosed a sarcoid or when you are diagnosed an amyloid, it has got a completely different connotation for the treatment. So that is a great insight from MRI. So I think we will shift gears and go to the cardiac CT imaging. Now the thing is, many times the clinicians just feel that the cardiac CT is just a cardiac coronary angiography. But as you know that with the techniques which has evolved, we have got plaque characterization and also the FFR measurement. So can you elaborate us the CT FFR and the plaque characterization, how they are useful in the clinical practice?
See, the prior cardiology practice was very simplistic. They believed the greater the stenosis, the greater the reduction in flow. So there was a greater mismatch between oxygen demand and supply, and this led to coronary coronary angiography, the invasive coronary angiography being the gold standard, and stents and various other modalities and angioplasties being done based on just stenosis. But when you actually think of it, almost 73% of the patients, if they were randomly taken to the cath lab, they would have non-obstructive coronary disease or none at all. So if we have to reduce the number of patients going to the cath lab and having unnecessary caths, then we have to have a gatekeeper which would prevent unnecessary caths and only take it to the level where obstructive patients would go to the cath lab. So in that situation, we really needed to have a gatekeeper to the cath lab, and that is where CT came into play. Now the CT angiography is an excellent tool because non-invasively we can look at not only the extent of stenosis, and it has a negative predictive value of 99%. So a lot of patients who come with chest pain, if you have a negative coronary CT, which means that there is no stenosis, no plaque, then you can actually have almost a warranty on it, and that this is not going to really land up with obstructive coronary artery disease in the near future. So that is one point. Now the second thing is that coronary CT is an excellent tool not only to look at stenosis but also to look at the plaques. And today it's not only stenosis but also plaque imaging, particularly the vulnerable plaques, which are becoming important in ischemia assessment. So we're looking at stenosis, plaques. CT is also going to the point where we can look at myocardial perfusion. The newer industry standards and the new CT scanners can very well assess stress, rest, perfusion, and also look at the presence of scars within the myocardium. So CT is becoming an excellent tool for stenosis, plaque assessment, myocardial assessment, functional tool, because if you have a 0 to 100 image, you can actually look at function, and to the point that the same images and the same data that is acquired for a non-invasive coronary CT can be taken to the level where you can actually do the CT FFR. Because the CT FFR now is possibly the highest tool, and it possibly beats all the nuclear medicine tests and all other stress tests in order to giving you a complete, very, very high sensitivity and a high specificity towards ischemia. Because finally in ischemic heart disease, we're looking at not only the morphological and anatomical evaluation of the coronaries, but we're also looking at functional evaluation in terms of the impact of any stenosis in terms of ischemia and infarction.
Great. That was a great insight, Dr. Bhatia. So I think we'll have to end up our session here. I know you are enjoying the CSI conference.
Absolutely.
You come from Delhi and they say Dilwalon ki Delhi, and Mumbai is always upper stiff and very professional. But are you looking at our hospitality? How do you find it?
I think it's been a brilliant CSI conference. We've had a lot of space, and in fact the cultural program yesterday really had me enamored. Just to have, we started with the Ganpati Bappa Moria, and that for people who come from Delhi, the high energy Maharashtrian dancing that we saw from there to the Lakshmi Puja to the Adivasis and everything else that followed, I think it was so high energy that everybody was totally enraptured. So I'm really happy to be here. Absolutely wonderful conference. Thank you.
Hospital and Holy Family Hospital, Mumbai. I have the pleasure and honor of having two stalwarts in the field of hypertension. One is on my right is Dr. Venkat S. Ram. He is the President and CEO of the Medicity Hospitals, Hyderabad, and President of the Board of Governors of the American Society of Hypertension. He has had an immense contribution in the field of hypertension, both from the US and in India. And we look forward to an interesting chat with him. And on my left is Colonel Dr. Chopra, past President of CSI, also a great contributor in the field of hypertension. And so we start the ball rolling with a question to Dr. Venkatesh Ram. Dr. Ram, we start with something very fundamental, the measurement of blood pressure. Now we know that the correct way of taking the office blood pressure is well laid out, all the precautions that have to be taken, we all know. But the question I want to ask is, in the office, given that you are taking the blood pressure correctly, how many times do you take the blood pressure, or what is your advice, and at what intervals do you take the blood pressure? And after taking 2 or 3 or whatever you would like to advise, you take the average or you ignore the first 1 or 2 readings? What is your advice?
Thank you, Akshay, and greetings to Dr. H.K. Chopra also, and all the best wishes to the audience. Akshay has asked a very fundamental question, and actually my former colleague Dr. Norman Kaplan stated that one of the most important things that you do as a doctor is to measure the blood pressure. And then he also said that one of the sloppiest things that you do as a doctor is measuring the blood pressure. So that says it all. As Dr. Mehta has mentioned, that the entire evaluation and management depends on the accuracy of blood pressure measurement. For over 100 years, we were following a sphygmomanometer with mercury, measuring Korotkoff sounds, hearing, and calling it systolic diastolic. It has served us well for a long time, and many of the clinical studies were done utilizing this technique. But what has happened is, unfortunately, this technique that we do is very simple, is not reproducible and fraught with many errors. So more recent guidelines do suggest to take the blood pressure with digital technology rather than manual blood pressure. Manual blood pressure measurements are eroding rapidly, and there is also a Government of India order against using mercury in clinical practice. So there is a Government of India order, and there are new guidelines suggesting that one should use digital measurement of blood pressure with automated devices. At the present time, Akshay, I can say with confidence, almost all the digital techniques are validated, and there should not be any suspicion about the accuracy that we used to have until 5 years ago. If you had asked me 5 years ago, I probably would have been somewhat skeptical. Now the instrumentation and the approval of the instrument by the Government of India, TCGI, is all standardized. So I could say that almost all the digital blood pressure measurement machines are reasonably accurate unless you have a reason to suspect it. So the proper way of measuring blood pressure now, I would strongly recommend, would be with a digital blood pressure which is automated, which comes with a cuff. It records systolic and diastolic, and one would take the blood pressure, if possible, about 3 times 5 minutes apart. And that is, if possible, I say it, because in clinical practice, it is not possible the way we talk in the surroundings or when we talk in a conferences. In clinical practice, 50 or 100 patients are waiting for you, and you don't have the luxury of dedicating 20 minutes. What I suggest is, as much as possible, try to use automated digital. If you use it at least about 2 to 3 minutes apart, that is good enough. And the second reading is preferable over the first reading. Ideally, 3 is recommended, but I don't think that it is possible. So let me summarize then, Akshay and others. One should try to take the blood pressure with automated device as much as possible and use that as the guide to diagnose and treat hypertension.
Right. Anything else you would like to add?
I think Dr. Venkatram has just mentioned very meticulously.
Correct.
That the blood pressure measurement is an art.
Right.
It's not only a science. And what he said, that we must ensure that the doctor who is taking the blood pressure is equally comfortable as the patient.
Yes.
Sometimes I've seen the doctors are great in a hurry.
Right.
And they don't have time to take the blood pressure. And mostly in India, it happens that the blood pressure is checked by nursing staff or by a paramedical staff or by junior resident who commit a lot of mistakes. If you want to know the correct blood pressure, we must ensure the proper ambience in the room, proper temperature in the room, a person is not consumed adequate amount of coffee, he is not anxious, he is not in anxiety. I think all these factors are very important to measure the accurate blood pressure, as already mentioned by Dr. Venkat.
One more advantage what I have seen of the digital instruments, they can give you a mean reading without you calculating. There is another thing the Europeans or the British people have just kind of suggested, that if you have 3 readings and the difference between the readings is too high, that means the first reading is very high and second, thirds are low, there is a suggestion that these people, this could be predictive of white coat hypertension.
Yes.
Is that true? Okay.
That is true. If the blood pressure varies significantly in the office from same visit quite a bit and the first reading is very high, they could have this phenomenon of white coat effect. In this context, Akshay, I want to mention something which is amazing in India. Of all the countries, India is able to embrace the medical technology much faster than many countries. Many countries like North America and Europe talk about it, but in reality, India is one country that embraces medical technology very fast. I can tell you in my own experience, this could be only limited to cities, I know it. But there are new machines that are now available that take the blood pressure automatically 3 times, and then digital printout will come. And that printout can be with the patient as a guide. They can see you or they can see somebody. So I think more and more digital technology has to be used. I know that some people don't believe it, but on the other hand, you have to accept the scientific advances.
Okay. And you think we can use this digital technology for home readings? Of course, we know we take it at daytime, but can they be used for taking night readings also? I mean, I know ambulatory blood pressure measurement is possible, but if that is not possible, are these machines can be used for night reading? Say you go to sleep and program them?
No,
Okay.
Very good question. That is the drawback of any measurement manually.
Okay.
Which is digital is also manual because you're
Right.
inflating the cuff.
Correct.
Is that this is not a substitute
Possible
to ABP.
ABP. Okay. All right. Now we come to the big everything in the blood pressure is controversial. So the other thing is the definition of blood pressure. The American guidelines and the European guidelines. What do we follow? Are they really different or they appear different but more or less the same? So 130 by 80 is the cutoff or 140 by 90 is the cutoff. So what is your take on that?
Okay, I will comment on it. India has a population of 1.3 billion.
Right.
And it is estimated when you combine rural and urban together, it is estimated 30% of Indian adults have elevated blood pressure, and the implications of untreated high blood pressure on India are enormous because of the country's size, 1.3 billion people. It has been estimated that annually we spend $24 billion in managing cardiovascular disease, which means $2 billion monthly, and this is a figure that came to us from ASSOCHAM, with which Dr. H.K. Chopra has been associated with. So ladies and gentlemen, this is enormous burden on cardiovascular disease, management, disability, loss of income, stroke, end-stage kidney disease, dialysis, etc., which are very expensive. Compared to the expense of treating disease, prevention of the disease is much, much better because medicines in India are not that expensive. Dialysis is expensive, bypass surgery is expensive, angioplasty is expensive, stroke management is expensive. Right. So we can prevent this from appropriate preventive cardiology. Now the guidelines, as you have mentioned, American guidelines have downgraded the definition of high blood pressure to 130 over 80 and above. European guidelines have kept the previous definition of 140 over 90, and these two guidelines are now the latest guidelines, and I don't think we'll have any new guidelines from globally for the next 10 to 15 years. I think the era of definition of hypertension has come to a stop with these guidelines. So there is a difference of 10 millimeters mercury between European guidelines and American guidelines, but the goal blood pressure that is recommended by both the guidelines is the same. Less than 130 or 80. The question that is often asked of me and Dr. Chopra and of you also is whether these guidelines are applicable to India. I mentioned yesterday that hypertension is a hemodynamic abnormality. It does not depend on your zip code, where you work or where you live. does not depend on your PIN code where you work. If there are certain PIN codes in the country where there is no blood pressure, I would like to migrate there. So most important thing is it does not matter whether you live in India or Uzbekistan or US or Sri Lanka or Myanmar.
Right.
Blood pressure is blood pressure. So the most important thing for us is to accept that wherever you live, you are subject to manifestations of high blood pressure, and Indians are much more susceptible to cardiovascular complications from hypertension. And you mentioned European guidelines. European guidelines have identified South Asians as a high-risk category of complications from hypertension by 40%. So at the same level of blood pressure, South Asians are at a 40% higher risk. By South Asians, ladies and gentlemen, don't be fooled that they're talking about Pakistan or Bangladesh or Sri Lanka or Nepal. They're talking about India. When people say South Asia, it is a code word for India because it has got a large population. And Europeans have also identified high uric acid as an additional risk factor in patients with hypertension. And there are data now from India, from your own wonderful city of Mumbai, showing that the incidence of hyperuricemia in Indians is very, very high. So based upon the new guidelines, they have actually identified Indians as a high-risk category of patients. So I don't think one should argue whether these data are applicable to India. They're eminently applicable to India based upon this. And myself and Dr. H.K. Chopra have written an editorial for circulation, which is going to come now, that the ultimate beneficiary of the American and European guidelines is India. In fact, we have our concluding sentence was, India is a receptacle of the new guidelines.
So I think that's a very important take-home message, that though the thresholds or the definitions are different, the target is the same. For example, from the American guidelines, if a person has 130/80 but is a low-risk patient, lifestyle.
Right.
And if it's high risk, then treat. European guidelines, even if it is less than 140/90, if it is high-risk patient like South Asians, better to treat. So the target is the same for both. It is only the definition which is different. But taking from there, supposing you have a low-risk patient, a very normal-looking person, no risk factors, no family history, 40-year-old, 35-year-old, and his blood pressure is 134/84. Is labeling him a hypertensive going to affect him in the future? Putting a label on him, he was okay, but now I'm a hypertensive. Or should we not label him and just advise him maybe?
Sure, thank you very much, and I think HK will also comment on it.
Yes.
In fact, this has come when the new goals and new definition of hypertension has been proposed. One of the things, as Akshay, as you have mentioned, is the psychological impact of converting a person into a patient.
Yes.
For no fault of his.
Yes.
You go to sleep one day as normotensive, and next day you wake up as hypertensive because new guidelines have come the night before. So suddenly a person has become a patient.
Right.
But we have to accept it.
Right.
We have to accept the way we have downgraded diabetes definition, the way we have downgraded hyperlipidemia, the way we have downgraded BMI. We have to accept it. The feeling is there could be a psychological impact of it, but the benefit is by early detection and management, the long-term benefits are overwhelming. You are absolutely correct calling somebody hypertensive, but we have to accept hypertension is a phenomenon that is unavoidable in some families. You can't do about it. But we have to manage it and we have to accept it. And of course, the first step, all the guidelines recommend lifestyle changes. In fact, from a pharmacoeconomic point of view, the estimation is that if you follow the guideline definition of aggressive treatment, if you follow the definition of lifestyle changes, the increase in pharmacological treatment will only be 10%.
Okay.
The increase will only be 10%.
Oh.
Not the way that everybody is taking it. So very, very important. One comment I want to make for our public and for all of us is that when you increase the number of people who are eligible for treatment.
Right.
Who are eligible for treatment, it is a public health burden. But if you increase the number of people who are diseased, morbidity, the burden is much greater. You have people who are surviving stroke, that is more difficult to treat than prevention of stroke.
Right.
And this is very, very important. The way, for example, in your own wonderful city of Mumbai, you see how the traffic has increased in the last 10-15 years.
Oh, yes.
But you are managing it.
Yes.
And you see how many flights are there in the sky, increased, but you are managing it. So the demand has increased, but you have to manage it.
Right.
And 1.3 billion people, their requirements for water and milk have increased.
Right.
But we are managing it.
Correct.
We are not running away from it. So suddenly you increase the number of people with hypertension, you manage it, and you don't run away from it.
That's very nice.
I think it's very wonderful. I think
Yeah.
I totally agree with Professor Venkatesh Ram. Akshay, you asked a very good question. I personally feel that India is the world capital of diabetes. India is the world capital of hypertension. India is the world capital of obesity. And India is the world capital of many diseases like hypothyroid, like inappropriate consumption of NSAIDs. And we see a lot of people consume oral contraceptive pills. They take steroids. And there is no proper control of blood pressure at all.
Right.
India is highly vulnerable. I personally feel that hypertension is like every day's tsunami in India.
Wow.
It's very unbearable.
Right.
I remember the words of Dr. Venkatesh Ram when he came to Delhi. He gave a very nice nomenclature to hypertension. And I think Dr. Venkatesh Ram remains now. He said that hypertension is like a hemodynamic malignancy, which is true. The reason is nobody knows who is going to be a victim of hypertension and infected complications. They come to us with epistaxis, they come to us with a stroke, they come to us with MI, they come to us with CKD.
Right.
And I think it is the number of blood pressure which is very, very important. Dr. Venkat Ram's emphasis was that we must ensure lower the better.
Right.
And I totally agree. Whether it's an AHA or ACC,
Right.
lower the number, higher will be the longevity, good
Right.
will be the prognosis, and less will be the morbidity and less will be the mortality.
Right.
Whatever method we use. And I personally feel, which again I discussed many times with Venkat on many occasions, that CBPM or OBPM is not the answer.
Right.
It's the ABPM.
Right.
After the age of 40, I feel in India, everybody needs at least every yearly ABPM.
One ABPM.
And every 6 monthly in resistant hypertension.
Right.
Resistant hypertension is very, very common in India.
Right.
I just quoted yesterday in a data I was presenting a Spanish resistant hypertension trial and registry where they mentioned that if we take the prevalence rate of resistant hypertension by CBPM, it is 12.3%. But the same thing, same patients, if we take the prevalence of resistant hypertension by ABPM, it jumps to 64%. From 12.3 to 64% in a place like Spain, Spanish registry.
Does it mean there are so many masked hypertension people?
Absolutely.
Oh.
So many mass, so many have underlying white coat hypertension,
Right.
so many are undetected. So I think a time has come that we must ensure what is the exact burden of uncontrolled hypertension,
Right.
what is the exact burden of resistant hypertension, and how meticulously we must manage them.
Right.
We do not know in India.
Correct.
I think Venkatam also gave a very nice statement yesterday. They don't think reduction of blood pressure by 2 or 3 per day, millimeter of mercury per day will make a difference. Count it over a year. Count it over years.
Correct.
That was a beautiful word he expressed yesterday. I think the morbidity and the mortality of blood pressure is the overall burden of hemodynamic variation
Right.
of the blood pressure in the whole day. Just taking one reading will just give you an idea,
Right.
but it is the tip of the iceberg.
Sure.
So it is the ABPM which gives you a complete circadian variation of blood pressure, and we have an idea he or she is the candidate where the blood pressure is highest at night. What is the persistent rise of time elevation in the night?
Correct.
How much is the burden of so-called nocturnal
Nocturnal
non-dipper?
hypertension.
How many has reverse dipping? How many has extreme dipping?
Right.
What is the hyperbaric index? What is the double product? So I think if we meticulously manage them and correlate with various variables like PRA, plasma renin activity, or aldosterone renin ratio,
Right.
or echo variables, I personally feel echo has a tremendous boost in knowing the morbidity which is hypertension inflicted.
Right.
We did a lot of work. We find LA volume is increased, LV and LV filling pressures are increased, LV mass is increased,
Correct.
LV hypertrophy is increased, and there's a lot of comorbidity correlates. So I think hypertension should not be taken lightly.
Right.
It's a matter of great concern in India.
Correct.
And I personally feel, after working almost for last 45 years of my life, that hypertension is number one silent killer,
Right.
which is misdiagnosed,
Yes.
underdiagnosed, mistreated, and undertreated. And time has come. We all have to act if we
Correct.
really want to reduce the morbidity and mortality. One more thing, Akshay, we are very lucky and very privileged that we have a person like Venkat with us.
Oh, yes.
We are honored that he left USA and joined
came
us.
here, right.
India is very lucky
Absolutely.
that the real
Yes.
pioneer
Yes.
and the real experienced person is with
Yes,
us.
absolutely.
We should take advantage of every minute
absolutely.
of our alliance with Venkat.
Correct. Since you mentioned this, the widespread incidence of hypertension being asymptomatic, can we replicate something what was done in the US, like the barber shops taking blood pressures? Can something be done, something like that over here?
Yeah, it can be done. It can be done and should be done. Akshay, it's a very good question. The only thing is, in India, the patients are also, they want their doctor to
Oh,
tell
yeah.
them. We can have any healthcare provider, you can have the most experienced nurse
Right.
who is actually better than doctors in taking the BP, they still want to talk to the doctor. So there is a cultural barrier in
okay.
India. Can you imagine a barber telling a person that you have high BP? Indians, somehow we have a culture,
Yeah.
we have to break that cultural barrier.
Okay.
If you break it, yes.
Okay. Okay.
Taking a clue,
yeah,
Akshay, I think it's
yeah.
very important, this point which you raised.
Culture.
We must create a kiosk for a blood pressure measurement
Absolutely.
everywhere, what is happening in USA.
Right.
The time has come. We must create a red alert on hypertension.
Correct.
If you really want to reduce the stroke, as mentioned by Venkat,
Yeah.
if you want to reduce the STEMI,
Yeah.
if you want to reduce ACS,
Correct.
if you want to reduce CKD, please control the blood pressure. That
And
is
you
the
can have a
message.
paramedical person rather than if you can't have a medical person.
The
But
message is
yeah.
control the blood pressure by
Right.
whatever best methods you
Correct.
can.
Yeah. One last question. Actually, we know that the lifestyle changes can affect blood pressure. Exercise 5 millimeters, DASH diet 5 millimeters, maybe some meditation 5 millimeters. Has any study been done combining all these lifestyle factors? Or do you expect that the numbers will go down substantially if all factors are taken into consideration?
Akshay, you know the answer, that's why you have asked the question, which is fine. The prerogative of the host. There are studies showing that there is a synergy and additive effect of multiple lifestyle modalities. Low salt diet, weight reduction, exercise, you combine them, it is like combination therapy.
So how much do you reduce? Would it reduce the blood pressure?
12 to 6 millimeters of mercury, double digit. So combination therapy, you're talking about combination of lifestyle changes, has same effect as combination drug therapy.
Drug therapy.
So if your lifestyle is just not one thing, you start the day and you end the day with that.
Right.
And one more comment I'll make since your last question is when you treat hypertension as doctors, I'm talking about doctors, don't fall into patients saying that it's a little bit of BP, chodo mujhe. Nobody says, I'll postpone the treatment for a little bit of lung cancer, little bit of breast cancer, little bit of colon cancer. Patient will never forgive you if you say that. But patients negotiate with you. But don't fall into the negotiation because blood pressure does not disappear.
Akshay, is my last message. What I get a clue here in this discussion, of panel discussion today, that we must control the blood pressure.
Yes.
We must grow younger and live longer. The only method is if we control the blood pressure.
Right. I think that's a nice way to summarize it. And thank you very much.
Thank you.
Thank you. Thank you, Dr. Walker.
Thank you. Very good.
I'm Dr. Rajiv Agrawal. I'm a practicing cardiologist in Western UP, which is a big agricultural hub of the country. I'm going to speak about inflammatory coronary artery disease today. As you know, the unmet needs in management of residual risk is a continuous challenge to treating cardiologists. Lipid-lowering therapies have reduced the risk by, say, 30 to 35%. They had been boon to our patients, but still 60 to 65% of our patients continue to suffer from events and morbidity and mortality. It's a big challenge. Recently, we have come to know that lowering LDL up to 20 milligram per deciliter is possible. It translates into reduction of event, and in some patients where the background risk is high, it reduces mortality also, as shown in Odyssey trial. We had abundance of literature both in primary prevention and secondary prevention trial, where it has been shown that despite achieving ultra low level of LDL, the residual risk continues to be high, and this has been shown in Jupiter trial, this had been shown in TB trial, and recently, if we look at the 4-year trial, it had been shown that at levels up to 20 milligram per deciliter, if your CRP is more than 2, you continue to have more events, proving the hypothesis that inflammation is probably an independent axis where we have to work upon. It is independent of lipids. And that is a very good beginning. So 4-year trial also has shown that in primary and secondary prevention trial, patients who achieve 20 milligram per deciliter of LDL, there is a linear correlation with CRP levels. On top of it, we had CANTOS trial, which showed the possibility of using anti-inflammatory drug, which is IL-6 inhibitor, to be used in such patients, and it had been shown that it reduces events and cardiovascular mortality as a primary endpoint, not independently. But the problem with CANTOS is number needed to treat is something like 150 plus. So it is far from reality and not a clinical tool in treating doctors in their busy practice. What I'm going to convey through this short talk is that residual risk, one of the important determinants are beyond LDL is CRP. It should be a reality with newer modalities in times to come, but at the moment we don't have tools, and we as a fraternity continue to have to work upon how to devise those simple clinical tools like statins and PCSK9 when we are handling inflammation axis. Thank you very much.
I am Dr. S.N. Rautray, Professor of Cardiology at SCB Medical College, Cuttack, Odisha. Presently, I am the convener CSI registry data. Coming to the importance of data, the importance of data cannot be overemphasized. Few months back, a caption came in Economist that oil is no longer the most powerful resource in the world. The most powerful resource in the world is now data. Is that whether it has got any importance in cardiology? If you ask me, I will say yes. It has got immense importance in cardiology. Because if you see, I will give an example. Our society, Cardiological Society of India, was created in April 1946. If you see, this SEC or American College of Cardiology was created in 1949. We are 3 years older to SEC. But from the very inception, SEC was associated with Framingham study, which collected data that gave them the importance. and whatever the guidelines and recommendations are being created or produced by the SEC, that is being followed by the doctors, cardiologists all over the world. So at present, SEC as a society commands highest respect. We have abundance of data in our country. If you see, to get a data of 7,000 patients, then SEC take 400 centers from different areas. So also European society, they take 400 to 500 centers from different areas. If you take in our country, if you consider 400 to 500 centers, we can have data which in thousands, maybe 40,000, 50,000. So to taking into all this, to get our own data, CSI took an initiative to start 2 registries. One is SCS or Acute Coronary Syndrome Registry, and another is ADHF, Acute Decompensated Heart Failure Registry. And at present, I am the convener of the registry, and the chairman is Dr. Venugopal and Mohanan, the research council, and the 3 national coordinators, Dr. P.K. Dev, Dr. S.S. Mishra, Dr. Givar Zakaria. And this is a pilot project. It has been started in eastern India in 4 states, starting from Odisha, West Bengal, Bihar, and Jharkhand. The most important thing to collect data, we have decided to get authentic data. That's why a separate agency has been associated with us and produced a software, and software is incorporated in the tab so that data can be produced, can be incorporated through the tab, and from the patient's admission to the discharge, that will be uploaded, and the discharge that will be synced into the main server. To start with, the centers have been identified in 4 states, and each center there is a site coordinator, and each state has a state coordinator. And the state coordinator will coordinate with the doctors, and with the help of the private agency, the doctors and paramedic staffs are trained to how to collect the data, how to enter the data in the tab in the particular software. And that tablet has been given to the each center, and the site coordinator had the password to that tab so that the site coordinator can only enter the data. And the same data, once synced into the main server, cannot be accessed or retrieved by the site coordinator or the state coordinator. That can only be seen by the convener or the CSI president, secretary, or the national chairpersons, so that this data can be authentic, data cannot be manipulated, and the manipulation of data can be minimal. So gradually it will spread to the other states, and by that we can get data as regarding the risk factor profile, as regarding the comorbidities, and this treatment pattern, management, all the things in different disease conditions, so that we can plan, we can have our own data, we can have our own treatment pattern, and we can improvise our own treatment pattern. It can compare with the other national bodies and international bodies. So let us come together, associate with the CSI registry, cooperate, and contribute data to get CSI powerful, so that we can have our data in different part of the country. Our country being a large country, in different regional area will have different type of data. It can be correlated with the food pattern, it can be correlated with the lifestyle, it can be correlated with the seasonal change, it can be like this. So that's why I will request all of you to join hands with CSI and contribute your data to make CSI powerful one. Thank you.
Friends, I am here to interview Dr. Prakash Didwania from USA. He is one of the authority in the lipid disease, and I am going to ask him today how the cholesterol hypothesis is sort of still criticized at times. So what do you think is that? Is it true that still some papers or some authors are writing cholesterol is not the cause of atherosclerosis? Sir, what is your opinion about that?
I think the cholesterol hypothesis is way beyond being hypothesis. It's now well established, and I'll tell you there are 4 lines of evidences. We have evolutionary evidence that suggests clearly that people who live in forest, the hunter-gatherers we call them, or in the pre-saturated fat era did not have atherosclerosis. So we have that evolutionary evidence. Then we have now the data from some of the Mendelian randomization where people who cannot make cholesterol, they don't get the disease, and people who have other characteristics where they're high cholesterol, they get very high atherosclerotic burden. But more important than that is we have experimental evidence. So then in any animal model where we have fed cholesterol, even in the setting where animals don't get atherosclerosis, such as rabbits, we can produce atherosclerosis by feeding high cholesterol diet. And then we have experimental evidence also showing that higher the cholesterol, greater the atherosclerosis burden, or the plaque burden, if you will. We also have evidence from early studies that were done in Korean war veteran, the young people, 20 plus years of age people, who when we had autopsy done on them, they had died of natural causes, accident, war-related deaths, and they already had atherosclerosis, and it was related to cholesterol deposits. In addition to that, we have evidence from the young studies that are done in children, followed for 20 years, that when the high cholesterol was high, then there was a progression of their atherosclerosis. Now, of course, those evidences are still, one can always argue about it, but clear evidence is that drugs that reduce LDL cholesterol, specifically when we talk about statins, they significantly not only reduce atherosclerosis burden, but more importantly, they reduce cardiovascular events, particularly ischemic events. Let me give you a few examples. So we have evolved into this area. Early on, we learned from the studies that were done to look at regression with what we call angiographic studies. And in those studies, we found that even though the atherosclerotic stenotic area was reduced minimally, 2 to 3 or 4%. However, the events were reduced by 80%. So that proven the fact that there is something else going on, and that's where the concept of stabilizing the plaque came. So that's what was going on, even though we could not see angiographically. And then subsequently we have evolved very rapidly, and we now have evidence both with pathology, but more importantly with clinical trials, that we have clear evidence that when we reduce LDL with statins particularly, that are, despite what the press or the bad press is somewhat, which is not based on facts, that we substantially reduce the risk of coronary heart disease related events. And now the fact is, we have now series of trials that go beyond statin. And clearly if we can and we need to, we can reduce the risk of events even further. So we showed in the Fourier trial, in which of course I was a PI for Indian cohort, and we have shown that lower the LDL, and we looked at the LDL down to 10 milligram per deciliter. The lowest was the risk of coronary events. So I think there is no reason
so for us.
No more, I think, the cholesterol is the reality, and
absolutely.
We have to see that the cholesterol is controlled well, and we have now got the evolution of the management, and so it is no more, I think, should be hypothesized.
No, I think it's well proven.
Well proven.
Yeah, it's a well proven.
Sir, how is your sort of a concept about primary and secondary prevention?
Yeah,
like
so
many times, personally, I feel that primary and secondary prevention is a very narrow or a very gray area.
So
so you think just a prevention is the right word? How do you?
Well, actually, I've written 2 books on this, so-called the Cardiology Clinics of North America, where I wrote, it's a continuum. There is really very rapid transition from primary to secondary prevention. If we talk about true prevention, we should be talking about primordial prevention. What we mean by primordial prevention is that we basically don't let the culprit happen. So in other words, if we make sure that our children in childhood do not have high cholesterol, they will never develop atherosclerosis. If we can do it, it's easier said than done because it's hard to remove the fats from the diet. So I think if one can be cognizant of the fact that primordial prevention will be the best strategy, as difficult as it seems to do, that will be true prevention. After that, when we talk about primary and secondary prevention, the terminology are used kind of to define certain distinction. Primary prevention means that somebody who has not had an event, so somebody who has not been diagnosed with coronary artery disease or atherosclerosis, if we use interventions there, then we call that as a primary prevention. On the other hand, if somebody has a positive treadmill, CT angiogram, or coronary artery calcium, and we treat them, some people can call it primary prevention because they have not had an event, but as far as I'm concerned, they already have the disease, so that is secondary prevention. Now, traditionally, the secondary prevention term is utilized mainly to define a group of patients who have already had an event, for example, myocardial infarction, be it non-STEMI or STEMI. Those patients are described in secondary prevention. So as far as I'm concerned, it's a continuum.
I know, suppose you see a person with the high lipids, the abnormal pathology, the biochemistry and all. Now, to categorize him like primary or a secondary, so you necessarily try to do some subclinical atherosclerotic, the investigation, or maybe some simple methods. Why I'm asking this, because very, very relevant for us in India, because we see, premature atherosclerotic disease not only in coronary, but in the other vascular tree also. For example, we see people with between the 30, 35 or maybe 40 years, almost 20 to 25% of patients, particularly the coronary artery disease, So if I could prevent it, primordial is okay, we have gone beyond that, at least the primary prevention. Say if I get an abnormal lipid report, a person who has come for a routine checkup, at the age of 30, 32, and suppose if I find, abnormal lipid which may be borderline, may not be the level as per the guideline base. Because whatever we guideline recommendation, the ACC,
But talking about the guideline, let me freshen you.
Yeah.
So we just had the newest guideline that was just introduced last week. My friend Scott Grundy and many of my friends were on the guideline committee, and I convinced them that we should put South Asians cohort as a high risk. So being South Asian is already high risk.
It has been
in the
put
guideline.
One of
it has
the
been
risk enhancers.
Exactly, and also in terms of what should we do, it is recommended that in high risk cohorts, generally one should start with statin therapy if they have abnormal LDL beyond the whatever limits we have described in there. So I think there is not a simple answer to your question.
Correct. Yeah.
The most
I know, but I'm looking into. I understand. I went through that atherosclerotic. The cardiovascular disease enhancers. In that, the triglyceride more than 175 also is put as one of the enhancer. Plus, as you said, South Asians, particularly,
well,
for example.
yeah. So I think.
So my point here, because what type of lipid abnormality what we see are a little different than typical the Westerners. Like our problems time and again. Like I'm an intervention cardiologist. When we see a patient of ACS, acute MI, more than 50% of the patient they have LDL or even the total cholesterol, just a borderline, but they have high triglyceride, low HDL. They're typical triad.
So typical triad,
how to tackle those aspects?
Right. So I think I will refer you to several studies that have been done, including the ancient study called ProCam. And all of these studies, as well as the other gem fibrosis study, they actually, and the Canadian cohort, they showed that triglyceride will have a lot more importance if there is simultaneous increase in LDL. It becomes highly atherogenic, as you know. If the triglycerides are there, they have atherogenic triad, then they have what we call small dense LDL. And I would recommend people not to worry about doing this different kind of lipid test. You can project. If somebody has high triglyceride, they by all means will have small dense LDL. So one doesn't need to get sort of confused by doing these expensive tests. I think it's very important to keep in mind that a family history in our Indian cohort plays a very important role. It has never been proven, But I would say in India it's very, very important. We have to do more research. But if we have a strong family history of premature coronary artery disease, premature coronary heart disease in Indian cohort, I would say, is 10 years younger than in Caucasian. So I think for a man having disease under 45 and for woman having a disease under 55, that will be considered premature.
Yeah.
And if you have persons like this, I would definitely strongly consider doing a lipid profile in them. And if they have any abnormalities, whether atherogenic dyslipidemia, which is a triad, as you mentioned, or high LDL by itself, I would consider intervention in them.
Yeah,
also, let me tell you that we should not be focused on coronary event. Lately, I've been getting calls and I've seen many patients, young patients having stroke.
Exactly.
Stroke is a very disabling consequence of atherosclerosis.
Correct.
And sometimes we don't realize, but imagine a 32 or 34-year-old recently married Indian subject who has a stroke. I saw patients like this when I was in Durban 25 years ago. That changed my thinking altogether.
So what is your recommendations? Suppose if I see a patient post ACS or a post procedure, maybe the intervention or maybe acute MI. Now is LDL just a borderline? Triglyceride is truly high.
What is borderline? My question is, what do you consider borderline?
What I'm saying, maybe about 80, 85, 90 LDL.
That's high, too high.
I agree. So now about the therapy, I'm saying pharmacotherapy. Are you going to consider beyond statin any other additional?
I would say
how is your,
first and foremost, anybody with acute coronary syndrome should go on maximum tolerated statin. We generally will recommend them to be on Atorva 80 or Indian cohort. We can consider 40, but it's not evidence-based. Or, although there are no data with rosuvastatin in acute coronary syndrome per se in a large prospectively randomized trial, you can consider 20 milligram of rosuvastatin. This is what we have defined in the guideline as what we call high-intensity statin therapy. And what high-intensity statin therapy is, any statin that can reduce
50%,
by 50% or more, and these are the only two statins that do it. Now, after we have exhausted that, the current guideline emphasizes that if you have exhausted, then LDL is still high. And for anybody with acute coronary syndrome or diabetes, it should be below 70 at least, and I'll get to how low we can go in a moment. But below 70 LDL should be achieved either by maximum tolerated statin, and if needed, adding ezetimibe, 10 milligram. Because the ezetimibe can further reduce by 15 to 18% LDL. So, both of those drugs are very well tolerated, despite bad publicity that has been there. I don't see any basis for that. Yes, few people will develop myalgia, but rhabdomyolysis is very rare unless patient has significant impaired renal function and levels of statins are very high. These were the other statins that are not around anymore. And in terms of the hepatic dysfunction, high intensity statin we have shown in very good control trial. There is about 2% incidence, it's reversible. We have not seen a case of hepatic failure with high intensity statin in last 10 years that I've given high intensity statin to hundreds of thousands of patients.
But suppose you have used rosuvastatin 40 or Atorva 80 equivalent dose plus 10 milligram ezetimibe. Maybe you get into the LDL target maybe around 70 or maybe little less than that, or maybe like after improve it, it has come up like the additional the benefit beyond that 70.
Yeah, but the improve it is somewhat misleading trial. Let me correct you.
Okay.
In improve it, and I just gave this talk at major CME program, and we were talking at American Heart Association. Improve it only showed benefit in diabetic patients.
Only diabetic.
You take the diabetic patient out, there was no benefit whatsoever. So improve it does not give a license
for
diabetic individual.
When you really recommend, because we are in India at least, me personally, little strong advocate of getting something like a triple target. You get the LDL low, you get the maybe triglyceride also less, because like now even the ADA 2018 and the other guideline do tell us if the statin maximize, maybe ezetimibe used, but if the TG is more than 205 or HDL less than 35, there is an indication to use the triglyceride lowering therapy.
Yeah, but
so
the evidence
at least in India, we have been very forcefully doing that. You think are we doing the right thing?
No, the evidence is not in favor. The evidence just appeared last week in the study called Reduce It. And I'm going to show those data tomorrow, and my good friend John Chapman is going to show those data in the morning, and I'll talk in the landmark trials in the afternoon. But clearly, there is evidence only for one class of agent, and this is icosapentaene, which is a specific omega-3 preparation. And they have shown when you use it in proper dose, that's the key.
2 grams per day.
4 grams, 2 grams BID.
Okay.
Very high dose, and I think people may say that I smell like a fish or whatever. So it's not easy to it's not palatable. But if you use that, then we have seen dramatic reductions in all of the events, coronary event, cardiovascular death, across the board, 20% reduction. So that is the first trial that has shown. The fibrate trial, unfortunately, were not done properly. I'm not saying fibrates don't work, but all the trials have been negative because they were done improperly. For example, the field trial. Field trial, if you look at cardiovascular coronary events, they were reduced, but they include amputation. So this was the primary. So that didn't improve. You don't expect amputation to improve either. Then in terms of the core trial that we did, NIS trial, we didn't include the patient with high triglycerides specifically. So if you don't include the patient who are the target of therapy, then you're not going to get the benefit. So we don't have the answer to your question specifically. I would say, yes, case by case, one can consider using good fibrate like fenofibrate in addition to
we have
statin.
been using, particularly in a diabetic individual, because in diabetic individual, this type of, the abnormality, like what we call it, it's not like a hyperlipidemia, but a dyslipidemia.
Yeah, atherogenic
dyslipidemia. And therefore, our observation, at least the figure, it does have an effect of, triglyceride lowering, and the HDL comes up a little bit because
but
it is a mechanism.
Well, we had a talk this morning by my good friend John Chapman on HDL. HDL coming up doesn't mean anything.
No, but indirectly, you are looking into the pathology of, why HDL is coming low in our substrate.
HDL goes up because it goes inversely. If you reduce triglyceride, HDL will go up because these are two inversely related.
That's what I'm saying.
They are interrelated. But
so you don't recommend for being no,
I would have to individualize. There is no evidence for this kind of therapy. Yes, if somebody has high triglyceride, they have very high risk.
So you intervene at what triglyceride in the US or how would you?
I look at case by case. I would say if the triglycerides are higher than 200 with a strong family history,
then you
and I've used the maximum dose of statin still is the first line therapy. I would not do any of this without using a statin maximum tolerated dose. That still remains the first line therapy, primary or secondary prevention in these patients. In diabetic patients, you may be or you may not be aware, the STENO2 trial, which is the best trial, very small number of patients, but showed clearly there was a better than 50% reduction in these hard events, MI and death. And this 70% of this benefit was attributed to statin therapy, even though they did multifactorial intervention. So statin therapy is the standard for all these patients.
Final question for you. Now with the advent of PCSK inhibitor, you think now since all these trial, 4-year trial and the other trial have shown the safety of LDL even 20-25.
Oh, safety is not a concern at all.
Not a concern. So you think now with the coming up of PCSK, even for us in India now it's available for last few months. You
but
think
the cost,
LDL cost is okay,
the main
but
consideration.
I agree, but there are some patients who can still What I'm saying, you think our LDL target will go down, like if you have to see LDL, mild to moderate risk less than 100, say high risk is 70, very high risk 50. Even our Lipid Association of India, which is also supported by ESC and other guidelines. But now you think with the PCSK, now we are in the process with CSI as well as the Lipid Association of India in another couple of months, going to have one more category after the high risk, extremely high risk.
Right.
Like people, like a CKD.
That has been already
so we are
defined.
trying to get up to 40.
Yeah. So that has
so
been.
You think it is?
Well, I don't know about that. I won't go that far. I would say that American Association of Clinical Endocrinologists have already described this extreme high risk category. And they suggest that in extreme high risk category, based on expert opinion, no evidence that LDL should be below 50. And I'd say expert opinion, emphasize it. However, in 4-year trial, we have shown
safety of
lower the LDL, fewer the events. So I think there is indirect evidence. And again, I suggest indirect evidence. That does not make the guideline, but individualization is the key. So and I have just presented, we have yet not published the paper, I just presented the data at the most recent ESC in the late breaking trial, showing within the 4-year trial, 16,000 patients with metabolic syndrome. They have a profile like what you're saying. the atherogenic dyslipidemia, that reducing LDL in them could be substantially benefit and provide greater benefit than those who did not have metabolic syndrome. So I think clearly we have data emerging, and perhaps future trials will show. But yes, if LDL is not controlled by what we have discussed, PCSK9 inhibitors are a very, very good solution. If they were to be cheap, then we can use it more liberally.
Thank you, sir. I think you have cleared many doubt on the lipid management. I'm thankful to you.
Thank you. It's a pleasure.
Hello, Dr. Raj Makkar. How are you?
Good.
Okay. So, welcome to the city of Mumbai, to India. Back again, your own country. I am Dr. Praveen Chandra. I am interventional cardiologist from Medanta Medicity Hospital, Gurgaon. And with me is Dr. Raj Makkar, who is one of the biggest exponents of structural heart diseases in the world. And he's presently the chief of cardiology and interventional cardiology at Cedars and Eye Center in Los Angeles. So welcome, and I'm sure you are going to tell us so many things about this new upcoming field of structural heart disease and specifically transcatheter aortic valve implantation.
Pleasure. So I think as you mentioned, TAVI is one of the most exciting areas today in interventional cardiology. I mean, the concept was introduced by Henning Anderson almost 30 years ago, and Alain Cribier did the first procedure 15 years ago. And in the US, the field has matured because the FDA approval, which occurred about 6 years ago, has led to quite a dramatic adoption of this technology. But I do see that there's a lot that still needs to be done in India. I mean, where the TAVI is still in its very infancy. And it's true that even in the United States, though we are doing a lot of procedures, and though now, in fact, we have exceeded the number of TAVI procedures that are done in the United States exceed the number of surgical aortic valve replacements that are done. And in 2017, there were 52,000 TAVR procedures done. But these procedures are being done in patients who are not surgical candidates or in patients who are at intermediate risk. But nonetheless, we still don't know, and there is not much adoption, rightfully so, in absence of data in patients who are at low risk for surgery.
Good. So that means that the indication of this procedure is expanding rapidly. It started from very high risk patients, and now as we see the data, it is coming up with patients who are at very low risk, and those patients who are young patients, those patients who are in the range of about 65, 70 years of age. Because in India, the issue is that compared to the West, in West people are very, very active up to 80, 85. In India, people start feeling old at the age of 65, 70. So do you envisage or you see that this indication of TAVR can be easily used for our patients who are in the range of 65, 70 and they do not want surgery? Is it okay to do that?
So Praveen, I think you raise a very important point. You know, low risk for surgery doesn't necessarily mean that these are young patients. For example, the NOTION trial, which was done in patients who were low risk for surgery, you know, the average age was still in mid-70s, though the STS score, the risk for mortality from surgery, was less than 3. And the same thing holds true, for example, for the low-risk study which was done in the United States. It was a registry done by Ron Waxman, where, once again, the STS of the risk for surgery was 1.9, but the average age was still about 72 or 73 years of age. So I think it is important to differentiate. So there is data for low STS risk, all right, which comes from the NOTION trial, that the outcomes were very good, all the way up to 6 years. It's not a very large study. It's actually a small study. The 2 large studies in low-risk patients have been completed, the Medtronic study and the Edward Sapien 3 study, the Partner 3 trial. You know, together there are about 2,500 to 3,000 patients in these studies, and they're going to be presented at the ACC. So I think from that we'll gather substantial amount of data on the low-risk patients. but you're mentioning about the young patients. And the question is, do we have data to do this in young patients? Well, the first thing that supports it is, for example, in the Ron Waxman low-risk trial in 200 patients, the mortality was 0, stroke rate was 0, pacemaker rates were only 5%, and more than moderate aortic regurgitation occurred only in about 0.5% of patients. These are very good results, in fact. So I think clearly, and 80% of these cases were done without general anesthesia under conscious sedation. So I think not only were these results impressive, but they actually were done at multiple institutions, and they were not all high volume centers, all right? So I think it is feasible to get acute results that are really superb. The question arises about the durability of valves. So can we use this technology in patients who are young without really knowing a whole lot about the long-term durability of valves is the key question, right? Now, there are some interesting concepts that have been floated around about using this in young patients. And one of the concepts is that you could make an argument, this is something that has been popularized by Michael Mack. It's a very thought-provoking concept. Why not start in a young patient with a TAVI, all right? Do another TAVI maybe 10 years later, and then 20 years from the time of the first procedure is when that person could actually have a first open heart surgery, and then 15 years after that, maybe he can have a TAVI in that surgical aortic valve, all right? Rather than starting with a surgical aortic valve replacement, having 2 TAVIs in that, and then needing a reoperation around the same time. So I think it's a little out-of-box concept, and I think that I will not be surprised, especially in India, if you start to see this technology being adopted in younger patients.
Okay, so this is about the indication. So let me just simplify for our viewers that, because most of the viewers will not be actually knowing all these terminologies of STS score, etc. So the indication of doing a percutaneous valve, or which is known as TAVR procedure, which is a non-surgical replacement of the aortic valve, is clearly indicated for patients who are above the age of 70 years and are having severe symptomatic aortic stenosis. And also, as Dr. Makkar mentioned, that it can be used in patients with the data which is available where even surgery is indicated, but this procedure can be done. But definitely, it is not the first procedure of choice for patients who are below the age of 50 years or 55 years. So that is the situation right now. And for rheumatic heart disease patients, what do you say? Because we have a lot of rheumatic heart disease. So patients come with just aortic valve disease with mixed aortic stenosis and aortic regurgitation. So you have to say something on that. Can we take these patients up, or we have to still select a few from them?
Yeah, so I think that once again, I think technically there is nothing that would prevent us from using, for example, balloon expandable or self-expanding technologies in patients with rheumatic heart disease. It so happens that a lot of patients with rheumatic heart disease happen to be young. So I think you have to take that into account and see what is the best treatment for them. Is it surgery or is it transcatheter aortic valve replacement? And I think it's important for me to clarify. I think what I was talking about earlier is that I will not be surprised if it is used in young patients here, which is a little bit different from having data in very young patients. I think that data is still lacking.
Yes. Yes. Yeah. So this is very clear that you said that this technology is expandable. It can be used in a very wide spectrum of patients and is safe. So the safety has been now compared with surgery in all subset of patients. It has been checked against medical therapy also. So this is a safe procedure. So tell me, what are the routes through which we take this valve inside? Is it the femoral artery only, or we can do it from some other locations?
So I think you get the most bang for the buck, as you can say, when you use the transfemoral approach, because it is one of the safest approaches. In the early days of transcatheter aortic valve replacement, transapical route was often used. It's a minimally invasive surgical approach, and so was the transaortic approach, where the surgeons made a small incision in the aorta and then we introduced the catheter valves. But these approaches have really fallen out of favor.
Okay.
The device size, the catheter size has actually come down significantly. So 90+% of the times, in fact, you're able to do this procedure using the transfemoral approach. Now, one of the other approaches that has substituted for the transapical and the transaortic approach is the subclavian or transcarotid approach. So I would say in the United States, in the TBT registry, the use of subclavian and transaxillary approach is about 3%, while 95% of these procedures are being done using the transfemoral approach. There are other interesting approaches, such as the transcaval approach, where you actually enter the vein and make a hole and enter into the aorta above the bifurcation, and then sort of do the procedure through the sheath that has gone from the vein into the artery. But nonetheless, that requires special expertise and learning.
So in your lab, I know and I have seen also that this procedure is done like simple angiography and angioplasty, which is phenomenal. The way it has progressed and the training which comes with experience has led to you the situation that you can do this procedure in 15-20 minutes.
Well, yeah, I mean, I think that things are simple till they are simple, right? And then when we have issues, we have to be very careful. So I think what you've seen in our lab is a culmination of, or a result of the experience we've had with more than 3,000 TAVR procedures over the last 10 years. So it's very important, though, not to forget that this is a team effort. It's a hard team approach that is absolutely critical. Imaging is absolutely critical. You need a very expert imaging person. You need a good anesthesiologist that can work with you to get these procedures done. Not necessarily with general anesthesia, but with conscious sedation and local anesthesia, but be there in case it needs to be converted to general anesthesia. So yes, you can do multiple procedures. You can do up to 8 procedures in 2 labs. And occasionally we've done 10 in a day. But nonetheless, I think it's important to have a very dedicated group of people that are committed to doing this procedure very reliably and reproducibly in a safe fashion.
So you mean to say the heart team concept is supreme in this case?
Absolutely.
And a cardiac surgeon in US, they have to be in the lab or around when the case is being done. But is it necessary for the heart surgeon to write on the file that this case can be taken for a TAVR procedure? Do we need a clearance from them or really not?
In the United States, CMS is the body that approves the reimbursement, and the CMS has mandated that the surgeon certify that the patient is either high risk or inoperable or intermediate risk.
So when the patient can go both ways, is there a fight between the surgeon and the cardiologist?
I have to say that those things have dwindled away. At least at my hospital, we have a very collaborative environment. And I think people have come to appreciate each other's strengths. And I can tell you that the heart team approach has really made our program much stronger. And in fact, it's increased our volume.
So this is a very...
For TAVR and SAVR procedures.
So this is a very important ingredient to start a TAVR program, that the heart team should be a good heart team. They should understand each other, they should know the strength and weaknesses of each other, and then only you can give good results to the patients. Is that right?
That's
Okay. And now, it appears that the TAVR is good, it has good results, the durability is good, and the long-term follow-up, the longest follow-up patient you have is how many years? 10 years?
Well, we started doing TAVR 10 years ago, but we were doing these procedures early on in patients
in the studies.
Were not going to survive that long, where we knew that their valve was going to outlast them. But we have a few patients that are 7 years out and 8 years out.
And the gradients are okay?
And the gradients are okay. But we've also seen a few patients that have actually had an increase in gradients, and where we went back and actually did a repeat TAVI procedure in them. So demonstrating that you can do a second TAVR in the first TAVR.
So do you get some sense of the durability? Because in the same time span, you have been doing surgical valves also with the prosthetic, these bioprosthetic valves. So do you have any idea of how both are comparing to each other in terms of durability?
I think the whole issue of durability of surgical valves has been misunderstood because durability of surgical valves has not been looked at very rigorously. Traditionally, in the earlier days, the definition of a durable valve was freedom from reoperation. So you could have a valve that is degenerated, but if a patient doesn't come for a reoperation or is not good enough for a reoperation or is dead, it qualified as freedom from reoperation. So I think now we have uniform definitions that are going to be applied to TAVR
because many times
and surgical aortic valve
patients ask that whether my valve, which is done through the percutaneous approach, will be as good as the surgical valve.
So,
what is your answer?
So Praveen, this is what I tell them. I tell them that we have data now up to 6 years in randomized control fashion, and if anything, there is no difference, and if anything, the hemodynamics or the valve areas are actually larger with the transcatheter aortic valves than they are with the surgical valves. I will also tell my patients that the transcatheter technique allows us to put bigger valves compared to the valves that are actually put during surgery, because during which time patient's heart is on a heart-lung machine and the heart has shrunken. So it is harder for a surgeon typically to put a larger valve. For us, when we're doing TAVR procedure, the heart is expanded and we can put much
take a
larger
bigger
valves.
valve.
So this diminishes the risk of what is called patient prosthesis mismatch. All right, so I think that's another advantage. And we can also tell our patients that the way we've looked at surgical valve durability has been somewhat flawed. And in fact, I often tell them that I'm using TAVR procedure for patients who have failed surgical valves. And guess what? In the VIVID registry, 20% of the patients with degenerated surgical bioprosthetic valves that were treated with TAVI procedure or TAVR procedure were actually done within 5 years. All right, so I think that is a glimpse of the flawed method in how we've been looking at surgical valve durability. All right, so if there was no TAVR, most of these patients would not come back for a procedure, and these valves would be considered to be durable.
Good. So which means that this procedure is very safe, very, very effective, and can be used for a large number of patients. Now the last thing about the cost of this procedure, because in India, cost is a big issue. Not everybody can afford this, and there are not state-funded agencies to support this. So do you think that the cost is going to go down, and what is your crystal balling for the cost of it? Because we have now Indian valves which are in the pipeline now. So
yes. So I think let's talk about cost. So in the United States, the Medicare reimburses this procedure. All right, so the patient is not charged any significant amount of money. But even in the United States, according to some studies, only 1 out of 8 patients with severe aortic stenosis undergoes aortic valve replacement either by surgery or by transcatheter aortic valve replacement. So clearly there's a disconnect from the data that we have that clearly shows that aortic valve replacement saves lives and the number of patients that are actually being treated. So even eliminating the cost factor, there is a disconnect, and I think we need to work on that in terms of spreading the message that this is technology that should be utilized more often.
And it is a cost-effective technology, which has been proven.
That's correct.
And so now let me tell you that in India we have now crossed about 600 valves, and in our own center we have done the fastest 100 in India of these valves, and really the patients, I can tell you, vouch for them that the experience has been really good. They feel very good, and they really feel that there is a cost effectiveness in terms of getting this procedure done for themselves. And with this, I can also let you know that the 2 Indian valves which are being tested at this time, and they are also doing very well. So it will bring down the cost quite dramatically.
I agree with you, Praveen. I think with the large number of patients that India has, it is important for the cost to come down. And I think that once you have the cost come down, you're going to be doing a lot more procedures than any other country. So this is the bottleneck, and I think it's exciting to have indigenous technologies that are being developed, which will hopefully result. And I've challenged these companies to actually reduce the costs so that this technology can be made available in a widespread fashion.
Thank you, Dr. Makkar, for these wonderful inputs and your experience we shared with us, and also your help you have been doing for the treatment and for the this therapy being advanced in India. Thank you very much for being here.
My pleasure, and I'm committed to helping and growing transcatheter valve therapies in India.
Thank you.
Hi, good afternoon, everybody. My name is Kirti Punamia, and on the auspices of the CSI 2018 in Mumbai, I have the honor and the privilege to introduce and interview one of the stalwarts of cardiology. Here we have Dr. Ashwin Mehta, a long career, an achiever, and today, and the recipient of the Lifetime Achievement Award at the CSI this year, one of the many Lifetime Achievement Awards that he has received. So may I please introduce you, Dr. Ashwin Mehta. Good afternoon, sir, for being here with us. And thanks for joining us in this informal chat with us. So, may I start off with some questions with you?
Before that, I want to tell you something. I feel a little strange. You know, you have been my undergraduate student, you've been my postgraduate student, and there have been many, many occasions when I examined you. And then it was I who used to ask questions, and it was you who would reply. Now the tables are turned. You're going to ask me questions and I have to reply. But one fact I want to make with you. I know that I asked you very probing and difficult questions in exam. You don't do that.
So I must tell you something on the same tone. That's when I was asked to interview you 2 days ago, I had sleepless nights because I remember my exam days. I still prepared all night to make sure I ask you the right questions.
So did I.
On that note, sir.
Okay.
You have been an achiever all your life, sir. Yeah. I have tracked your career right from your school days back to your present time. Every award that is possible, you've received. So where do you see yourself going from here? Where is your next destination? In your personal capacity, in your professional capacity, in every way?
Good question. You see, realization and the recognition that you are mortal is becoming firmer and firmer when you get Lifetime Achievement Award. I mean, when people say lifetime, neither time nor life is over.
That's right.
In fact, I feel that the life begins now.
Right.
So your question is well framed and really thought-provoking. Like, can I simply continue to do what I'm already doing? Maybe. The same zeal, same force, same urge? No. The answer is clearly no. Because you people like Kirti Punamya, Mardikar, Bharat Dalvi, and all of you are my investment. You are deploying and you are using the training, the art of medicine on hundreds of people. And that's the investment that I have made for our country. So then next comes what else? You know, it's like this. I have 3 facets in my life. 1, as a doctor, a professional. 2, as a family member, the head of my family, the father, the husband, and also the grandfather now. So that facet, have I fulfilled adequately? Did I do justice? Professionally, you people have recognized, I don't want any more recognition. What more can I opt for? What more I would like to have? I'm okay. And the 3rd, the member of the society. I think the last 2, as a family member and as a member of society, I think I have not done a full justice.
Wow.
So people say posterity. What posterity? I mean, I create a monument like a temple, which many Jains do. How does it matter? He is no more there to watch what he has done.
Right.
And it does not have any impact. So therefore, I feel that if I live a life which people would remember that this is the way Dr. A.B. Mehta lived, this is the way I would like to live, then I think my day is done. This is what I guess.
So awesome, and that means you are actually, as you lived your life, you've been creating monuments all along, and your students who are there, and look at the organization of this conference today, it's your monumental students that have created this conference, haven't they? So you must feel a proud moment.
I'm very proud, like Samira, my daughter, often used to say, Dad, she's an architect.
Right.
Now she's a senior architect, but in those days when she was a junior architect, she says, Dad, every time wherever I go, I'm being introduced as Dr. A.B. Mehta's daughter. And I said, yeah. And then one day when I was traveling by plane, the famous musician, Hari Haran, he told his colleague and said, look, meet somebody, Samira's dad. So Kirti, you are my very precious and proud investment. And I think this was Dr. Kirti Punamia's teacher. That would be a great day for me.
Oh, thank you. So thank you. It humbles me to say.
Yeah, okay.
So I know this journey has been impactful for all of us. I mean, your journey has been impactful for all of us. We've learned so much from every step. What I want to know, and what I think most of us are eager to know today, is what have been the high points in your career? And I want you to follow that with telling me, what are your regrets? There must be moments when you felt like, oh, this is something that I should have done and I never did. And on the other hand, there were things that you did which you shouldn't have done in your own assessment. I want the world to know what Ashwin Mehta thinks about this.
Long question. All right. Kirti, sometimes people express, he's lucky. What is lucky? Well, if I analyze, the luck is series of fortunate accidents which happen in your life in sequence, and anyone who's able to grab it and make the best use out of it, the accident, is not only lucky but successful.
Very nice. Yes.
So in my life there were several fortunate events that took place, and that I cashed on it, I'll be honest with you. And then that is what helped me to achieve and to reach.
So those are your high points of your life.
Yes.
And if I were to ask you to enumerate 3 of those, what would you?
When I came back from the United States, and then at that time Jaslok Hospital was in making, and I'm talking of year 1973, and then there was everywhere an atmosphere, an impression that anyone who's attached to Jaslok Hospital should be the best, must be the best, because that is what they wanted.
That's right.
That is what they announced.
Yeah.
And when I got selected in Jaslok Hospital, it started my career. What happened is that one day, chairman of Jaslok Hospital said that, Dr. Mehta, would you please go and see my friend? I said, who is your friend? He said, Jai Prakash Narayan. And when I treated him, because he was a very important man, his doctor became also an important man.
Right.
So it fell into my lap automatically.
Right.
That I think was a major event in my life, and then that took me sky high.
Very good.
And second one was when I went to see Vinoba Bhave, and that was in Pune, and at that time the Prime Minister Ms. Indira Gandhi also came there.
Wow.
And I had a interaction with her, and he said Vinoba Bhave had given up food and water both, and has wanting to invite death at will, which I think is an extremely rare and very, very admirable action. Okay, that when my job in this world is over, I should not live anymore. So he invited death by himself. And so he said, Dr. Mehta, what do you think? I said, ma'am, somebody may think that Vinobaji is attempting suicide and I am abetting. So what should I do? So she replied to me, Dr. Mehta, you are such an experienced doctor, and you might have come across such kind of moments, events. What have you done at that time? I said, ma'am, then the Prime Minister does not count. The blood relation counts. So she said that I'll call his brother and you can interact. So that impressed me. And then thereafter, I wrote an article when Rajiv Gandhi expired, Rajiv as I knew him. And all those things are very pleasant moments in my life. And in one way or other, they must have contributed to my furtherance in my progress, my success, my name, my achievement, whatever you want to call it.
Right.
Sorry. Yeah, sorry.
Please go ahead. Go ahead.
And you asked me regrets.
Regrets, yes.
Yes, I'll tell you. It was a very heavy rain. And I was going by the Saifi hospital and I saw two children in a jhopadapatti. And they were protecting themselves from the rain. And children were 7 and 4 in age, the two, the boy and the girl, the brother and the sister. And it touched me, it hurt me. So I came down and went there. I said, where is your father? So he says, working in municipality, so he's gone. Where is your mother? I think she's a maid, so she's cleaning bartans and whatnot, so she's also gone. So what are you doing? I'm taking care of my sister. Now a 7-year-old boy, instead of playing on the playground, has to do this duty. It hurt me. And I feel and I regret that instead of wasting my time in looking after sick people, which so many people can do, wouldn't it be better for me that I spend some time with this kind of kids and be personally involved? Sometimes invite them at my house. I don't want to give a donation. I want to be with them. I want to feel what they feel. That's what I missed.
That's a regret. That's right. It's interesting. It's a great message for people because we see that all around and we just go blind on this, isn't it?
You're right.
So it is again all encompassing. I mean, we've seen so much of Ashwin Mehta all around, and I have been hearing you and following you for so many years, as I mentioned earlier. So yesterday I was amazed. I witnessed one of an amazingly spontaneous speech of acceptance of the Lifetime Achievement Award. One of the things that I saw move is that you used to speak about Mahatma Gandhi.
Yes.
This time you spoke about Swami Vivekananda. And for me, I ask a simple question, for Ashwin Mehta, who spoke about Mahatma Gandhi all along, today he speaks about Swami Vivekananda.
Yes.
Is spirituality, I mean, it comes from the spirituality in Ashwin Mehta, and is that also a moving target? Or was that deliberate?
Well, I didn't read much about Mahatma Gandhi at the time when I was impacted by Swami Vivekananda's preachings and teachings. I didn't know much about Mahatma Gandhi's life. And therefore, at that point of time, I wanted motivational inspiration which can keep on keeping me on the drive all the time so that I can go closer and closer to my goal.
Right.
And in that respect, Vivekananda's message, arise, awake and stop not till the goal is reached, impacted me.
Right.
It affected my psyche. It drove me and it was a driving force. Gandhi is a man who believed in sacrifice. He believed that don't live for yourself, live for others. That came later in my life. But between two, if I have to choose, whose life you would like to emulate,
right?
I would say Gandhi.
Wow, strong sentence, very strong sentiment. Awesome. So, and this is absolutely amazing that you say that. And therefore, I want to kind of bring out, and I want to bring out the ideology. I mean, one of the ideologies that Swami Vivekananda talked about is religion.
Yeah.
Brings away communities together.
Yeah.
And in that he said, he justified that in that it made a brute in the man a man. So it, from the brutal man, made him just a nice man. But the same religion makes man a god. My question is, how do you separate and where do you draw the line? Is it good for man to become God or play God? It happens in our profession all the time. So I want you to lend some perspective on this.
Look, I'm not an atheist, But at the same time, I don't believe in God the way people believe in God.
Right.
People believe in God as a form, or people believe that kind of what existence. I don't believe that way. And about religion also, in my books, religion is code of ethics, code of conduct. What happened is that the crime has, any crime or criminal activity has 3 stages. Thoughts. I feel that I want to pickpocket you, or I want to rob you. So that thought came to me. Then comes the arrangement, that I always will watch what time you leave your house, what time you are alone, and so on. And finally, delivery, the action.
Execution.
So whereas the action and delivery is obvious.
Exactly.
But the thought, nobody knows.
Nobody knows.
If I create a fear that there is a superpower
Right.
who also knows about your thoughts,
Right.
then I think I'm curbing the crime at the thought level.
The deterrent.
At thought level.
Exactly.
That is what religion has done.
Awesome. Awesome, sir. Now, I mean, talking and chatting with Ashwin Mehta can just go on forever. There's so much that he can contribute and say. But, the last words of wisdom, sir, from you. What would you tell the fellows and cardiologists in the first 10 years, people like myself, who have watched you, who love to just be the next Ashwin Mehta? What is your message to them?
What is lacking in our system is that I impart knowledge. Truly speaking, you reproduce the already established principles in exam, or when you practice established facts, but you don't innovate.
Right.
And as a teacher, I badly failed that I did not stimulate you all people to imagine and think. Albert Einstein always believed that the knowledge is already known, but the future is imaginations. When the imaginations become reality, then the discovery takes place.
Wow.
So therefore, I wish I could have spent time to stimulate you all people to think and to innovate.
So I'm telling you, you have. It's just that we've been insensitive to realize it. And on that note, sir, thank you again for spending this absolutely wonderful afternoon with us at CSI Mumbai 2018 for this absolutely splendid interview. And congratulations from all of us for this amazing achievement. Thank you so much.
Pleasure.
Thank you. Thank you.
I am Dr. Jayaprakash Shantar. I am a professor of cardiology at the Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore, India. I have here with me Dr. Pamela Masson, who is the Director of Electrophysiology in the University of Virginia, United States of America. Welcome, Dr. Pamela.
Thank you.
So how has your time been in CSI today?
It's been wonderful. This has been my first time attending the conference, and it's been an incredibly rich experience. As someone coming from a foreign country, it's amazing to get to see the different ways people do things. And of course, there's a lot of similarities too.
Okay, how do you compare this with a large meeting like an ACC?
So I find it to be a little bit more of a personal experience. The American College of Cardiology meeting has 25 to 30,000 people every year and is a little bit overwhelming. This has been really nice because it's been a little bit more personal, and you feel like you get to meet more people and make more connections.
So has it been your first CSI, or have you been to the Cardiology Society conference before?
This is my first time at the meeting, but I'm hoping to be able to come again.
Oh, well, we'll invite you. Not a problem. So now I know that you are the Director of Electrophysiology and you deal with lead management issues. Am I right?
That is correct, yes.
Yes. Can you tell us something about lead management, please?
Yeah. Lead management is a very specialized field, and I think that this is something that you'll see worldwide, and certainly it's true in the United States. To do it safely requires a good bit of training, and having the facilities to be able to support it safely. And if you look at the literature and the data, it's actually a fairly safe procedure as long as it is done by somebody who has the experience and the training.
So how many centers in the United States do you think do lead extractions?
I don't know exactly how many in the United States. I live in the state of Virginia, and in the state of Virginia, there's probably about 5 centers total for the state.
Okay, so that's not too many, is it?
No.
So it requires specialized training.
Yeah.
Now, can you tell me something about the indications for lead extractions?
Yeah. So the biggest indications we have for lead extraction are, of course, infection. And that includes both pocket infections and lead infections or device-related endocarditis. And I think there's oftentimes the fallacy of people thinking that pocket infections don't need to have a full system extraction, but really they do. The literature shows that if you have a generator that's infected, the leads are infected as well, and if you don't extract the whole system, the patient's very likely to have recurrent infection, which could be sepsis, so a very dangerous infection.
So how quickly do you think you're going to consider extracting a lead in a patient who's got either an infective endocarditis or a pocket infection?
The most recent data shows that early extraction is always going to provide the patients with the best outcomes. It appears that earlier extraction, the patients are more likely to clear the infection quickly, they're less likely to have complications.
So would you adopt a transvenous extraction or a surgical extraction? Are there any differences in the outcomes, or which one is better, you think?
Yeah. I think we've reached a point where the vast majority of patients we recommend for a transvenous extraction as opposed to a surgical approach. The surgical approach is obviously much more invasive, and the data is really quite good for transvenous extraction, even in the setting of having vegetations which could embolize. The patients seem to do quite well.
So when would you suggest surgical extraction in a patient?
So surgical extraction we tend to reserve for patients who have endocarditis that has damaged a valve to the point that they need surgery anyway. So if a patient has developed severe aortic regurgitation, an abscess, or has a fungal infection, something that would indicate that they need surgery anyway, then we just let the surgeons take out the leads at the time of the surgery.
So what is your impression of doing an extraction in a small child? Do you have any experience?
So I personally don't do pediatric cases. I do a fair amount of patients with adult congenital heart disease who received leads as a child and then as an adult develop lead issues. But for children, I think the concern many people has is the size of the child versus the size of the sheaths. That you don't want to certainly cause them complications, vascular tears with the very large extraction sheaths.
So can you tell us something about the various tools that are available today for lead extraction?
Yeah, there's we call them powered sheaths. And generally what we think is when leads have been in place for more than a year, you have to assume that there's fibrosis involved, that the leads have been scarred into position, and you're going to have to do something assistive to get it out rather than just retract the helix if it has one and pull it out. So the two forms of powered sheaths are either a laser sheath, which is manufactured by Spectranetics, or mechanical sheaths, which Spectranetics has its own set of those sheaths, and then Cook Medical, which I don't think is available currently in India, also has its own set of mechanical sheaths. Most of us originally trained on the laser sheaths because that was the initial way that we started extracting the leads. It has great data behind it. There was a large registry now more than 10 years ago called the Lexicon Registry that showed that high volume centers had very good outcomes with the laser sheath. But increasingly we're getting really good data with the mechanical sheaths as well. There's actually the Cook mechanical sheaths actually just published a fairly large prospective study showing that those patients did very well with those sheaths as well. And we assume those to be analogous to the Spectranetics mechanical sheaths as well.
What are the lead locking stylets that you use in your practice? Because for all these extractions, you need to put something inside the lead to stabilize them, to pull it out, because otherwise I think the inner coil gets sort of distracted. So
the hallmark of using those powered sheaths is having created a rail such that you have something to safely advance the sheath over. And so you have to lock the inner lumen of those leads. Spectranetics makes a very nice system that actually expands and locks the entire length of the lead. Cook Medical makes one that locks just at the tip. So many people prefer the Spectranetics ones because it locks that entire length. But once you've locked the inside, then you can pull back on that lead and create a rail such that those powered sheaths can safely advance over them without pushing into the wall of a vessel.
So is there a difference between the Cook locking device versus the Spectranetics, or now I think it's called the Philips?
That is correct, yes. Yes, I'm calling it Spectranetics, but they were recently purchased by Philips. The Cook Medical one, I've used both of them, and I've had good outcomes with both of them. As I said, the Cook locks only at the very tip of the lead, but I haven't noticed any particular problem with that. Yeah.
Now, when do you use the telescoping sheets? Do you use them at all nowadays?
So I do sometimes use the telescoping sheets. I like to avoid it if I can. The things that make me more concerned that they're needed are advanced age of the lead, defibrillator coils, and of course if you know there's going to be a lot of calcium, which it always makes it more difficult to get the leads out.
So is there a difference between extracting a passive fixation lead and an active fixation lead?
I feel like there is. If you look in the literature doesn't actually bear out that there's all that much of a difference between extracting passive fixation and active fixation. Anecdotally, I do feel like there's some benefit to the active fixation leads. The tips do come free more easily. The passive ones, of course, those tines are embedded in the trabeculae. And of course, that's one of the areas where we worry about complications is perforation of the right ventricular apex, trying to get the lead out.
Now, what about the defibrillator leads? What about single coil versus dual coil leads? Do you have any difference?
Personally, so being an extractor affects the choices of what you choose to implant because you know what's easier to get out and what's easier to deal with from a lead management standpoint. Personally, I almost never use dual coil leads anymore unless there's a particular reason I'm worried about the patient's ability to defibrillate successfully.
Is it more difficult to extract the dual coil leads?
Yes, I believe it is.
So which leads do you think are more difficult to, defibrillator leads are more difficult to extract? Any particular company?
Yeah. Well, one thing we've been dealing with in the United States is the St. Jude Reata lead.
Yeah.
So the St. Jude Reata lead was a defibrillator lead that was recalled by St. Jude, which of course is now Abbott because they were purchased by Abbott. And it was recalled due to this problem where the interior cables would erode through the exterior wall. And the early experience with trying to extract those leads was very complicated because with the powered sheath sliding over the lead, they would essentially snowplow those cables forward. Now I think most of us are trying to pull those cables back into the lead and either marionette them or tie them with a little device we call a bulldog or something of that nature, and they come out fairly easily. In general, I think Medtronic leads are very straightforward to extract. They hold together very well, the inner lumen stays together. Boston Scientific tends to be they're much more friable leads. They tend to come apart, the inner coil lets loose. The St. Jude ones, if it's not one of those Reatas, tend to be fairly straightforward to get out.
So now when you're doing a transvenous lead extraction, you can go either from above or below, from the femoral. When would you sort of go from a femoral route to do a lead extraction? And what sort of equipment would you sort of use to sort of extract the lead from the femoral site?
We tend to use a gooseneck snare to try to get out these leads. Issues that would prompt us to take that as a primary approach. The biggest one is when you have a lead that's been cut. So once in a while we'll have a patient referred into us that somebody previously cut and abandoned the leads, but often the leads are infected and still need to come out. And so certainly there's nothing to grab from the pocket to be able to extract it that way. So that's probably the biggest case that in my practice we go straight to a femoral approach.
Now people have the habit of cutting the leads. What would be your advice if a person wants to abandon the lead? Should he cut it or just cap it and leave it in the pocket?
in general, it's probably going to be better to cap it and leave it in the pocket. Even if a patient doesn't have an infection, they could develop one in the future. And so especially if someone pulls the lead taut, cuts it, and it retracts into the central vein where we can't get to it, you could be leaving your patient with a very bad problem, and then they could need open heart surgery, essentially, to get out an infected lead, as opposed to they potentially could have had a transvenous, very safe procedure had it been accessible.
Is there any difference between a lead explant versus a lead extraction?
We tend to use the terms interchangeably, but it is worth noting that leads, especially if it's younger than a year old, oftentimes pull free without an assist device, and it's very, very safe and a low risk.
Assist devices meaning one of those specialized devices other than the stylets.
Yes.
The regular stylets
Yeah.
which we use for an implant, suppose we use something like a stylet, then we get the lead out very easily, then it's called an explant. And if you use some specialized equipment like a lead locking stylet or a lead locking device and the powered sheets, you would call it as an extraction.
Yep.
So what are the complications that you would be worried about, and how would you explain it to the patient about complications of extraction?
Yeah. So one of the challenges as somebody who does lead extraction is that how do you prepare for very rare but potentially catastrophic complications? If you look in the literature, it's overall a safe procedure provided that it's at a high volume center with very well trained extractionists. But the things that could go wrong that are really concerning are an SVC tear. Okay, so that's the first thing that we worry about, and that goes to your question about the dual coil leads, because of course having that superior vena cava coil probably increases that risk of the patient having an SVC tear. And then the other problem, of course, would be right ventricular perforation when we're trying to get the tip of the lead out. If you look in the lexicon data, the risk of dying from a lead extraction was well under 1%. In fact,
I think it was 0.28%,
0.28.
which is much, if you look at the major complications, it's about 0.28% in the lexicon registry, versus in a PCI, it's about 4 to 5%, which is probably, but one should realize that it should be done in a very specialized center.
Yeah.
Now, how would you prepare your lab, you know, when you're doing an extraction? What sort of, is it done under local anesthesia or
No, we take a very multidisciplinary approach to doing this procedure. It involves cardiac anesthesia, cardiac surgery, our echocardiography colleagues, and the way we do the procedure is we do it in a fully OR-capable electrophysiology laboratory. So it has all of the OR equipment as well as fluoroscopy and all of those things. We use general anesthesia. There's a transesophageal echocardiography probe placed, and there's monitoring during the extraction procedure. And then our surgery colleagues we actually have the perfusion equipment available, and they stand by should we have one of those very concerning complications. And hopefully they're bored and have nothing to do.
What about the bailout balloons? Do you keep them in as standby? Do you keep a wire in the SVC before you start the extraction from the female?
We keep a wire in the SVC before we start. We do keep the bailout balloon available. If we think it's a very high-risk situation, so maybe a defibrillator lead that's very old with the superior vena cava coil, sometimes we will prep the balloon and have it, more closely available should we need it.
So can you tell me how the bailout balloon works? Because obviously when you inflate the balloon, you're just going to obstruct all the venous flow from the head and neck. For how long do you think you could keep the balloon open?
Well, it's interesting because that was always everyone's concern.
Because you'd have cerebral edema if you had the balloon.
Yeah, so that was always the concern when that product was released, is what does this mean for the patient if we're obstructing the flow? So basically the idea is if you have a superior vena cava tear, you blow this balloon up and basically tamponade it. The data that's available actually shows that probably due to other venous collateral flow, that the patients seem to do fine until they can get to the OR.
So how long does it give the surgeon to open the chest once you have the balloon up?
From our perspective is that those patients need to have surgery available so that they can get in several minutes, regardless of what kind of complication or regardless if the balloon is used. So we always have a full chest wall prep, all of the equipment available, the surgeons in the room. We've got transesophageal echocardiography and fluoroscopy, so if there is a complication, we know immediately, and the patient has what they need immediately for the surgeons to get into their chest in several minutes.
Is it much easier to extract a pacemaker lead or a defibrillator lead? And what about a coronary sinus lead? How easy or how difficult is it to extract a LV lead?
So the easiest leads to extract are usually the coronary sinus leads.
But we are scared, right? We think that there is likely to be more complication because the lead is in the coronary veins, and if you tear that vein, you might have a tamponade. But fortunately, it comes out much more easy. What is your experience with the new active fixation lead from Medtronic? Is it easy to remove?
Coronary sinus lead?
Yes.
I actually don't have any experience extracting that as of yet.
So we don't know how difficult or how easy it is to extract. So is it more easier to extract temporary pacemaker lead or a defibrillator lead?
Pacemaker lead for sure.
For sure.
First, they're smaller.
Yeah.
And then those defibrillator coils, even with all the advancements that the companies have had as far as backfilling and coating them, they still provide a nidus for scar tissue growth.
So coming to the backfilling, does the backfilling make any difference to the way the leads get adhered to the venous system?
Yeah, I think it probably helps some, but again, those coils are just prone to ingrowth, and it's an issue.
So, what should be the training program for a lead extraction? A person who wants to do a lead extraction, can anybody sort of just go ahead and extract a lead, or do you think that you require some training to extract these leads?
Yeah. So the Heart Rhythm Society actually has a consensus statement about training for lead extraction, and actually has very specific guidelines, not just about training, but about maintenance of qualification to do it. We really want to avoid a situation where someone's doing 3 or 4 leads a year. This is an area where every case is different, every patient is different, every lead is different, and there's really no substitute for experience.
Yes.
And so, in general, I believe the Heart Rhythm Society guidelines recommend 70 leads to even say that you're competent to do it, with 20 per year to maintain competence. And when I actually do train fellows to do this, and I advise them when they go into practice to still have a mentor available, that you probably don't want to go into practice and be doing them completely by yourself to start.
So how many, to maintain the competence, how many extractions should you do per year?
How many did the guidelines say, or how many do I think?
Both. Let us have it both
I
ways.
believe 20 leads is what the guidelines say.
But for you, what do you think it is?
I think, first of all, there's the whole issue of leads versus patients, which is actually a different thing. I think 20 leads, that could be in 4 or 5 patients. So personally, I would think a minimum of 20 patients, and ideally more.
Yeah. There are various indications which include, one of them is infection. Then what are the other indications you would suggest extraction?
Yeah. Other reasons we do is, in the US, we will extract non-functional leads for several reasons. One, if they're causing the patient a problem. For example, superior vena cava syndrome, that we'll sometimes see if people have just dropped in more and more and more leads. And the guidelines actually do say that if you're going to have more than 5 leads total through the superior vena cava, or more than 4 leads from one side through the superior vena cava, you probably should start taking out leads.
What about the abandoned leads? And some of these leads, if they are cut, they can cause arrhythmias. So would you try to extract them also?
Yeah, it's certainly an indication to extract if you think that the lead is going to mechanically cause a problem for the patient, whether it's the risk of perforation because it's fractured and has externalized components, or as you said, if it's causing arrhythmia because of loose components.
Now, what is your thoughts about pulling out leads which have perforated? The perforated, acute or subacute perforations, and some of them are chronic perforations.
Right. For the acute and subacute perforations, we almost always get away with it, as far as just pulling it back. Of course.
So the right ventricle is very
muscular.
Muscular, and Yeah.
Yeah, so we're cautious about it. We have echo available and pericardiocentesis kits, but we generally just pull them back and the patients seem to do just fine. As far as chronic perforations, we don't see so many of those, but there is concern that it's fibrosed and the hole is more likely to be durable once you pull the lead back. So then we're a little bit more cautious with having surgeons available.
So how many times do you think that you require the surgeons to be ready to open up? How frequently do you have a complication in your lab?
For lead extractions?
Lead extractions.
I've been doing lead extractions at the University of Virginia for 12 years. I had one other colleague who was doing it as well. And in 12 years, we've had to open 3 times.
So that's not too bad. So are you going to be here for some more time?
Yes.
Are there any interests other than electrophysiology that you have?
Yeah. I'm a comprehensive electrophysiologist.
So you don't have any other?
Well, my general area of interest is complex device management in general. Particularly, I enjoy dealing with biventricular devices, but I do ablations as well.
So do you do complex ablations or just?
Yes.
So I think we will end the talk here.
All right, very good.
At Mumbai 2018, and I am Dr. Brian Pinto, Chief of Cardiology and the Director of the Cardiac Cath Lab in Holy Family Hospital, Bandra, just across from here. And today with me, I have Dr. Martin Mann. And it's a pleasure to meet you. It's a great pleasure to meet you.
It's great to be here.
Yeah, because, I have read so many papers that you have published, and, it's a wonderful opportunity, I think. And Martin actually is the Director and Chief of cardiomyopathies at the Tufts, which is, I think, one of the leading institutes in the United States of America, and has published all through his life, I think.
Yeah.
And it's a great pleasure to have you, Martin.
Thank you.
Yeah.
It's great to be here. Appreciate it.
So, I had the opportunity to go through your slides and attend part of your lecture, and really enjoyed it.
Thank you.
Because, hypertrophic cardiomyopathy is dear to me as well. I've had patients who've had different kinds of presentations, and the one that worries me the most is sudden cardiac death.
Sure.
In India, we have estimated that we have 2 million people who die of sudden cardiac death every year, not all because of hypertrophic cardiomyopathy. But I'm sure that in the younger people, that could be one of the more important causes. So Martin, tell me this, is this hypertrophic cardiomyopathy one disease, or is it, a spectrum of diseases? Is it a spectrum of situations, or it's just one disease?
Well, yeah, so I think we consider it to be one disease in the sense that there's a unifying mechanism for disease expression, which is the mutation. These are mutations, of course, of the cardiac sarcomere that we believe lead to disease, and that there is a diversity, though, it's true, an incredible diversity to the spectrum of the disease with respect to the phenotypic expression, which really what I'm talking about is the wall thickness, which can be really almost any pattern, location, and distribution, with the unifying diagnosis being a wall thickness of 15 millimeters or greater anywhere in the LV chamber, of course, in the absence of any other cause of hypertrophy.
Right,
right. And so the spectrum is diverse, but it's a unifying cause.
Right. But the expression may be different in different individuals. Would you say that any patient with hypertrophic cardiomyopathy, if you pick him up by chance, would you also screen all family members, or would you just ask history and then screen?
Yeah, so we would recommend that family members be screened of that index case, the proband. That would include, for sure, first-degree relatives and potentially beyond that, depending on the family pedigree.
Right.
But definitely we would recommend screening, and we usually recommend it in the following way. It would be every year to year and a half of echocardiographic screening in the children of the proband or index case through the end of adolescence, and then usually we still extend echo screening in the children every 3 to 5 years until midlife. Sometimes we can see conversion to HCM beyond adolescence, so that's why we do that. And then usually we stop screening at midlife if the echo is normal at that point.
That's for children. Do you screen also in the generations above, because somebody may not have been picked up and Does that come into
Yes,
the
other
screening?
close relatives,
Other
including siblings of
Yes,
the index
of the
case,
index case.
and possibly parents.
Right. So that would be your screening protocol.
Correct.
What would be your genetic? How far do you all go as far as genetic testing is concerned?
Yeah.
For these HCM patients.
Yeah, so here's the deal. So, what we have now in 2018 is a panel that you can order. It's a genetic testing panel that includes the most common mutations responsible for HCM. And that's usually a one blood draw that gets sent out to a laboratory that does that testing. And the question then is, why do genetic testing? And the answer really is the following. First, to be clear, if you find a mutation in your patient, it doesn't dictate changing management of that patient. In other words, mutations don't impact whether a patient needs an ICD or not.
I agree.
Two, is perhaps most important and powerful, is that it allows the opportunity really to tell whether other family members are at risk of developing disease if they have the same mutation as the proband.
Right.
If they don't have that mutation, they're not at risk and they don't need screening.
Absolutely.
Right.
So
that's what we do.
I think screening is important because
Sure.
if you do genetic screening, if you don't have the same mutation, but everybody won't have a mutation.
That's right. That's the what we call the Achilles heel of genetic testing in HCM. It's upwards of 60 to 70% of patients with a clinical diagnosis of HCM have no mutation identified. So then at that point, you can't go on and you have to do echo screening.
Absolutely.
Right.
So it's not like you've got a genetic mutation in everybody.
Correct.
So
That's important.
That's
because
important.
when you offer genetic testing to your patient, you have to tell them, of course, that
Right.
there's a majority chance we're going to find no gene.
Right. So when you echo test these patients, do you have, as you said, there's a protocol do you have a protocol for the index case? Does he have an echocardiogram done every year? Does he have an echocardiogram done once in 2 years?
Yeah.
What's your protocol to test him out,
Yeah,
depending upon what he has?
Yeah.
I'm not yet got into the sudden cardiac death issue.
Sure, yeah, sure. I mean, in general, our strategy is echoes every year in young to middle-aged patients with HCM, really to evaluate for potential changes in wall thickness, although that's uncommon, but also changes in ejection fraction, which can be important, or other valvular changes as well. So it's an echo every year in young to middle-aged patients. That also includes potentially an MRI every several years, depending on the situation as well. Those are our two main imaging tests.
This is what I wanted to bring up. I test all my HCM patients with MRI because I believe it's very, very important. The LGE to me is of utmost importance. So I want you to tell us about the MRI for HCM patients.
Yep.
You said you do it every couple or every 3 years, something like that.
Yep.
So what is your protocol with the MRI?
Yeah, so this is the deal. With MRI and HCM, we get an MRI for sure on every patient on the initial evaluation.
Absolutely.
And we do that for two reasons. One is the MRI can define the morphology of the LV sometimes more reliably than echo. What I'm talking about there is more precise assessment of maximum wall thickness, which itself is a predictor of risk when you've got massive hypertrophy.
Correct.
So we do it for wall thickness to get a precise estimate, and we do it for LGE, late gadolinium enhancement, which we equate in this disease to scar, fibrosis, which has now become an important marker of arrhythmic risk and also future risk of developing systolic dysfunction, or what we call end-stage or burned-out HCM.
So you think the MRI is so important that you need to repeat it maybe every 3 to 5 years or something like that, because scar initially may actually progress.
Correct.
You may not, that scar that you see of less than maybe 10% may get to more than 15% after a few years.
Exactly. Yeah, that's exactly correct. We actually have some data that will be coming out soon to suggest that there are an important subgroup of HCM patients who progress with scar.
Yeah.
Somewhere on the order of 1 to 1.5% per year.
Right.
So if you've got a patient at 10% at baseline, you got to keep going. You got to repeat it.
You can't say 10% and then you don't just receive anything.
Yeah, right.
Because 5 years later you've got 20% scar.
Exactly. So we recommend 3 to 5 years repeating.
You repeat the MRI.
Correct. That's exactly right.
This can happen quite easily in India because MRIs are reasonable in cost.
Yeah, that's good to hear.
In our country.
Yep.
The other thing that I wanted to ask you is about the one area as to which of the patients whom you suggest to go for a reduction surgery, and whether you'll send any of your patients for alcohol ablation at all.
Yeah. Yeah, it's a great question. So this is how we view it. We consider the surgery, which is the myectomy, to relieve subaortic obstruction, again, from mitral septal contact, to be an incredibly important intervention in patients with HCM who have limiting symptoms. They're frustrated by drugs haven't worked in that patient, and therefore they become a candidate at that point for myectomy. We believe that the operation, because it's an opportunity to, under direct visualization, to take care of all the anatomy that leads to obstruction, to be the gold standard. And unless a patient has high surgical risk because of other comorbidities, including age, or doesn't want surgery, that's a patient then would be a candidate for the alternative option for relief of obstruction, which is the percutaneous approach with alcohol septal ablation.
Absolutely. So, we've also gone through that, and, we did alcohol septal ablation at one stage, but we just refer patients who, as you mentioned, are very, very high risk for surgery or whatever. Now, to get back to the fact that the drug therapy for it, would you say that every patient with a gradient, with a particular gradient, would have to be on a beta blocker or on verapamil? And when would you bring in disopyramide into these patients?
Good question. So this is the deal. If a patient has obstruction, but they're asymptomatic, they tell you they're doing great, they don't really feel any limiting shortness of breath or fatigue, that may be a patient that we don't put on any drugs. So we have a subgroup of patients we follow, even with high gradients, who are completely asymptomatic.
Don't put a single drug on.
Don't put a single drug on.
Suppose
That's right.
gradients more than 50.
We still don't, actually.
Really?
Yeah, we have patients with 100 millimeter mercury gradient who
Doing well.
feel great, who have great exercise tolerance on the treadmill, who are on nothing, no AV nodal blocking agents.
But if they have such a gradient, do you think they have a lot of LV hypertrophy also?
Well, they have hypertrophy because they have HCM, but there's no evidence, and this is the bottom line, there's no evidence that the beta blocker in an asymptomatic patient, even with high gradients, will change the natural history of that patient.
So you're using the drug basically to relieve symptoms?
To relieve symptoms, correct.
If you want to really look at
That's right.
You're not using it to treat gradients.
Correct.
You're using it to relieve symptoms.
Right. We treat patients, not numbers.
We don't treat numbers.
Correct.
So I think that's an important message that we need to give out over there.
Yep.
What really fascinates me is these scores that people have developed. The ESC has developed scores for sudden cardiac death, because you've been a master of this, and we know that if a young man dies suddenly, we would certainly think of HCM as a cause, besides anomalous coronaries and whatever. But these scores to me sometimes become very non-flexible. So I want your view on the ESC score, and then on the American Heart Association and the ACC guidelines.
Yeah. So I think we're on the same page about this. I mean, I think that our view about the ESC risk score is it is inflexible in a way. I mean, it's a static, model that gives a 5-year risk, but because it's set in time, so to speak, it's not incorporating the changes in evolution that come along, even in HCM, with new markers like LGE, exactly. And by the way, apical aneurysm patients, which we can talk about as well, but those are a high-risk subgroup because the aneurysm increases risk for VT. And patients with burned out HCM, which is defined by an EF of less than 50%.
Which is 3 to 5% of people.
3 to 5% of the HCM population has that. Exactly,
I
that's
had
right.
that patient which I spoke to you about.
That's
before.
exactly right.
So I think we are kind of inflexible with that less than 4%, 4 to 6%, and above 6% mortality in 5 years. And I'm quite, I always sit back and think, what happens if you have a patient?
But let me make a point about that, because I think just to be clear about that. So I think just compare that to the ACC AHA, which is a different kind of strategy, which relies on the non-invasive major risk markers and can include, because of that, new markers like LGE. And also, the strength of the ACC-AHA is that it incorporates this concept that you just talked about, which is physician judgment. Looking at the individual patient and being able to take the whole clinical profile, the age, the weight of the markers, the desires of the patient, to make the best decision about risk for that patient.
Absolutely. You have a first-degree relative who had a sudden cardiac death.
That's right.
I'm worried.
Right.
I'm terribly worried.
You're terribly worried. How about this? We got a young patient who's got an ambulatory monitor. It's got a lot of NSVT on it. Not one, but a lot of NSVT, because you're able to look at the entire arrhythmic burden to kind of make a full assessment. You're able to better inform your patient about their risk as opposed to a binary yes or no.
I think that's like a line in the sand.
Correct.
You say yes or you say no.
Right.
But I don't think it's that. It's a spectrum.
It is, because that's the disease. It's a heterogeneous disease. It doesn't fall into, binary issues.
Right.
And that's why a risk score is a little bit limited here.
Right.
And that's why the strength of the ACC, in my view, is much more powerful.
So I want to get into this LGE stuff with
Yes.
you. I want you to give us a little more about LGE. Tell us how important you think it's going to get in the future. Do you think it's going to change our patterns of putting ICDs in for patients?
Yep.
What would you say if you were Moses and supposed to tell us about what's the future of HCM?
Well, I think that the answer to that is that the impact of LGE on informing us about future risk of arrhythmias and heart failure is really pretty strong right now, even in HCM. I mean, there's been a number of different studies and meta-analysis that have all showed that it's a very powerful marker. So extensive LGE, which right now we define as 15% or greater LV mass occupied by scar, really elevates risk for two things: VT, potentially life-threatening, and this burned out end stage phase with heart failure.
Right.
So I think that even now in 2018, we look at LGE in every patient to help us inform about ICD and tell the patient their future risk for end stage. Right. Two, I think that this concept of LGE being a marker cuts across not just HCM, but to other forms of heart disease, as we were just talking about. Even in non-ischemic cardiomyopathy, it's a stronger predictor.
Very strong predictor.
Even maybe, than EF.
I think the EF of 40%, a lot of fibrosis there, a lot of scar there. I would go towards an ICD if there was some other data also. I would certainly not leave him and say, you've got an EF cutoff of more than 35, you don't need an ICD.
That's right.
And then you have another guy who's 30%, he's got not much scar tissue in.
Yes.
And his wall thickness is good. He's been doing well for years and years.
That's right.
And then you want to put an ICD in him. So that's the binary marker, with the MADIT score and all those things. I'm a little bit against that.
I am too. That's right. By the way, though, another important point, that I think is worth raising is that the opposite with LG is true too. If you don't have any scar, that's lower risk.
Lower risk.
Right. And patients like to hear, particularly in HCM, that they have no scar, and that's a sort of a source of reassurance for patients. That's right. That's right. That's right. So that's powerful, kind of both ways.
Absolutely, absolutely. I think that's so important for us to understand these things. Now, what is your feature regarding age? I think age is also so important, at which the index case has actually presented to you.
That's right.
The clinical symptom comes in at age 55 versus age 18.
That's right.
What would you say about that?
Completely agree. Age is really important in HCM, and this is the deal with age, that the greatest risk of sudden death events is in younger to middle-aged patients, particularly younger patients. And that what we now know is that risk of sudden death really decreases substantially once an HCM patient has achieved advanced age, which we define sort of as 60 years and beyond.
Right.
Not old, but advanced age.
Yes, you call it advanced because now youth is up to 75.
That's right. That's right. That's exactly right. Advanced, not old. Right. I want to be clear about that. That's right.
The other thing I wanted to ask you was that, you look at patients there in NYHA class 1 or 2, and they have more sudden cardiac death than patients who are maybe in class 3.
That's right.
I don't think the NYHA class tells you who's going to die and who's not going to die.
That's correct. It doesn't do that in HCM. And it's actually not a very good application in this disease, because it just doesn't fit either with sudden death or heart failure, because we don't have the same kind of limitation. It's a different kind of heart failure than ischemic or non-ischemic cardiomyopathy.
So I think you got to realize that, because if you're NYHA class 2 and you think you're safe with HCM, you better get your MRI done.
That's right. No, those are very important.
And know what's really happening to you.
Yep.
The other thing that I wanted to bring up was the sudden cardiac death doesn't always occur during exercise or following severe exercise. Not that I'm telling the HCM patient to do severe exercise.
Right.
But a lot of them die even in their sleep.
That's correct. In fact, most HCM patients die suddenly not doing intense physical activities.
That's what I want to bring up.
That's actually true. Absolutely.
Because that's so important.
That's
People
right.
think, that you'll only die during exercise, and that's not true for HCM.
That's right. That's right.
So
That's right.
This is important, information that I think we need to pass on to people. That sudden death doesn't mean that it will happen during exercise, or
That's right.
Can happen.
It can happen sedentary as well. Exactly.
Yeah.
But I think it's worth pointing out on that note that it is also true that intense physical activities, as you just mentioned, and what we talk about is organized competitive sports, does increase risk in an HCM patient.
It does, and you don't want them to do that.
Exactly. Now that doesn't mean that they sit in a corner.
No, they can walk.
They can do mild to moderate
Walking,
aerobic.
They can maybe swim very
lightly.
gently,
Exactly. That's right.
Man, it's been great, but I need to know something more about you. What do you do in your free time, if you have any?
Well, I'll tell you on an interesting note, and in my free time, which is limited here with everything else, one of my favorite things to do is yoga.
Wow.
Yeah, I love Bikram yoga, actually, hot yoga.
He came to me,
Did he?
He did.
Is that right?
Oh, yeah.
Do you know him?
I know him.
Really? Well, maybe you can introduce me, because I love what he has done with that practice.
Right.
And I love doing it, and I think it sort of helps me feel great.
Right.
And I really believe strongly in that method.
I think basically yoga calms you a lot.
It does. It does.
Anything else? Any sport or?
Well, Bikram yoga is a sport. I also do recreational swimming and biking.
Oh,
basically.
wow!
Yeah.
Wow! It's nice to know. It's
Yeah.
nice to know.
Yeah.
And from Jagat Narola, I heard
Yeah.
you have a great family and lots of good things going on over there.
Yeah,
but
we're
thank
very
you very
tight.
much
Thank you.
for your
Appreciate
time,
it.
and enjoy yourself over here.
Great. It's an
Take
honor.
care.
Thank you.
Take care.
Yeah.
Good afternoon, people. I'm Dr. Robin Pinto, cardiologist from Mumbai, and today it gives me great pleasure to talk with and discuss the future of echocardiography with Dr. Richard Chiselle from Florida, USA. Dr. Chiselle was the past president of ACC, and to no one's surprise, trained with the great Richard Harvey, Dr. Harvey Feigenbaum. He currently is Director of Health at the Lee Health Institute in Florida. Good afternoon, Dr. Chiselle.
Such a pleasure to be here.
So, not to talk about ECHO, but of your trip, this trip to India, has it been rewarding, fruitful, interesting?
Fantastic experience. We've had an opportunity to enjoy the people, most importantly, the food. I need to leave here before I gain another 50 pounds. But we saw the Taj Mahal, the most beautiful building in the world, I'm convinced. Fantastic experience.
And built for love.
Built for love, the only monument built for love.
And is this your first trip to India?
I had been here several years ago in Hyderabad, so couldn't wait to come back. I love everything about it.
Coming back to medicine and ECHO, you have worked from pioneering work in ECHO, and has it taken you the full circle, or what has happened to you in all these years?
Well, I was initially trained as an academic echocardiographer, but diverged from that a bit, and one sometimes comes back to one's roots toward the end.
What I want to discuss today is the future of new technologies. We are all used to transthoracic and color Doppler and spectral Doppler, and we're so used to these images. But there are so many new technologies coming out, and we'd like to spend some time for the upbringing and upcoming cardiologist. So what do you feel have been the most exciting new technologies in ECHO in our field today?
Well, if one looks even over the last 5 years at the difference in the way we utilize echo, not just imaging of structure and movement, but now looking at physiology, particularly in areas like heart failure and cardio-oncology, we're utilizing Doppler technology to measure diastolic function and to estimate pressures. Weren't able to do that several years ago. Being able to use speckle tracing to measure strain, giving us an incredible window into function at a level that we couldn't discern before. We're utilizing more 3D echo, and of course, increasing use of transesophageal echo, which has become universal.
Of all these technologies, you mentioned spectral tracking. What do you see the future of this technology? It seems exciting. I still feel it's early days yet. I don't know, what are your thoughts on this?
I think that it is in the early stages yet, and Yesterday, I was speaking about right ventricular function, and we're starting now to get data on strain in the right ventricle as opposed to the left ventricle, and it turns out it provides a tremendous amount of prognostic value. So I think that the sky's the limit here as both the technology and our leveraging and utilizing the technology improves.
I think all these years we are used to a very, what we call eyeballing ejection fraction. It was not an exact, very subjective evaluation of LV function, which is such an important aspect of echo. Half your guidelines depend on ejection fraction. And I think spectral tracking adds a lot more objectivity to that criteria.
I couldn't agree with you more. And even beyond that, the use of contrast echo enhancement combined with 3D echo changes everything. Because now one can really get a better global sense of what's going on with function without the problems of wall delineation. So if one combines that with the strain information derived from speckle tracking, we're really on the cusp of moving much further along.
With speckle, I don't know, sometimes I think you need a good image first of all to get a good spectral tracking. But are all the machines sort of the same? Is the technology uniform in machines? We used to have this problem with angiography.
Yes.
But is it the same with speckle, or is it going to change in the future?
Well, one hopes that there'll be more uniformity because there is some heterogeneity between vendors.
Right.
And so it's important for all of us to realize that particularly in determining normal limits, it's based on the particular vendor that one is using. And so if you change from one to another, you need to be aware. You hope it becomes more universal. Yeah.
When I do speckle, I do a lot of speckle. I use it basically for GLS. How good do you think is speckle tracking in diagnosing ischemic and regional wall motion?
Yeah. So I believe that we're on the cusp of this as well, and you've alluded to, because just as we've learned that there are certain things that happen in early ischemia before one can visualize wall motion abnormality, and we've learned particularly from the cardio-oncologists that there's reduction in systolic function measured by speckle tracking with strain rates before an actual drop in ejection fraction. One can also surmise that you may be able to begin to detect ischemia earlier by utilizing that modality.
But I think that's not state of the art yet.
I think we don't have enough data yet, and but one could certainly surmise that this is really an area that will be ripe, and we're starting to see this come out a little bit.
And as regards oncocardiology, is it taken off in a big way? Like, for example, in the US, do you necessarily, when a patient refers to you, have to give this data when you follow these patients on chemotherapy?
So it's a great question, and actually it has taken off in the U.S. enough that this has almost become a subspecialty of cardiology. So we now have cardiologists that are identifying themselves as cardio-oncologists. They work very much in concert in a team-based fashion with the oncologists, and at least in most centers, speckle tracking with strain is a standard part of the exam in patients that are receiving at least certain chemotherapeutic agents.
And when you report this, what do you take the absolute decrease in global strain, or you take a cutoff value normally?
I think there's, again, heterogeneity in reporting. I know in our centers, we're actually numerically giving the differences and then an interpretation of what we believe that means. And there are some standards that have been set that talk about percentage change. But I think, again, this is not as well established yet.
Dr. Giselle, it intrigued me. You alluded to LV opacification and contrast. I think that's another field which in India too, when we do dobutamine stress echo, many centers use this routinely.
Yes.
And I think it enhances your diagnostic skills and your certainty of regional wall motion. Has it been taken off in the US in a big way?
It really has. And I still think, however, as much as it's increased in the last 5 to 10 years, I still don't think we've seen the full development and utilization of this technology. you know, the ability to pacify both the right and left ventricle is extraordinary, and we're starting to focus a little more on the right ventricle, the forgotten ventricle, if you will, and often very difficult to see. But with contrast, one can really begin to see these enhancing agents help. Beyond that, though, there may be some future use in looking at myocardial perfusion, not FDA approved at this point in time, but an area for the future.
I was going to tell you, it's great for pacifying the cavity. I think we are a few years away from making it routine for perfusion. A lot of my colleagues in Bombay use it for viability.
Yes.
I think it's quite a good developing technique for viability, and it's always an issue here. You have an anterior wall MI, you don't know whether you should revascularize him, and I think this helps in a big way.
Absolutely.
Another fabulous and fascinating technology is 3D echo. And again, I feel it's dramatically underutilized. I too, myself, in my practice, I hardly ever use 3D, though I have machines for that. I don't know if it's a time constraint of practice, but what is your feeling? What is the future of 3D?
I think it's an untapped resource at this point because so many echocardiographers were not trained in an era of 3D. So we have to go back and relearn techniques. Our technicians have to do a little bit different work, and we need to begin to visualize the heart differently than we did in 2D, just as we had to initially figure out what the 2D images look like. But this is an untapped resource.
I attended part of your lecture, I was busy, but just to talk about the forgotten ventricle, the right ventricle. I mean, there's so much data now and so much emphasis now on the RV side of things rather than the LV. And do you find that strange or it's good for cardiology?
I think we have to. We've focused, if one thinks about, for example, heart failure, for years all we talked about was systolic function, the ejection fraction. Now we recognize more about diastolic function. In heart failure with preserved ejection fraction. And I think now we're beginning to shift over and say there's a tremendous amount of information to be derived from what's going on in the right ventricle as well.
I know the cardiac surgeon, one of them, he's not interested in the left ventricular function. Tell me, is the RV okay? If the RV is okay, I'm going to operate this patient. If the RV is down, I prefer to wait. And
I think that's a very forward-leaning thought because I presented some data yesterday where some early data is suggesting, for example, that strain rate in the right ventricular free wall may be more predictive of what happens in heart failure patients than our other indices. That's fascinating. Yet to be validated in other studies, but how fascinating is that? And that would validate your surgeon.
Exactly. Another interesting field is the use of artificial intelligence. We are seeing it being used increasingly in our day-to-day lives. You have Alexa, you have Google, you have this, X-ray reading. What's the future of echocardiography?
There have been a number of papers, and one in particular recently published, that looked at a study for beginning to read echocardiograms with machine learning or artificial intelligence that really looks very much like this is going to take hold. And you and I were discussing earlier that in our country, we believe that diagnostic radiology is a dying field. And could we find a near future, because of the exponential growth of the computer technology, that many of the echoes, particularly normal or fairly simple echoes, would be interpreted automatically by a computer? And perhaps, I hate to say this, perhaps better than you or I, but in reality, leveraging the experience of thousands of cardiologists.
Yep, I hope we're not out of jobs.
I hope not too. But I think we need to plan for that and evolve how our practices go so that we're not caught surprise.
One last aspect of the future of echo is the miniaturization of everything.
Oh, yeah.
And though it's not taken off in India in a big way, but we also hear handheld echo being given to all the residents now in the US. They have it in their pocket. They go bedside and they put the probe and they diagnose everything, at least some of the important things. What do you see the future for that?
Well, my close friend Jagat Narula made a compelling comment that the stethoscope is dead. And I think that he was really making a point more than anything else, that the ability to image at the bedside is a dramatic extension of our clinical tools, our stethoscope, our eyes, our ears, our hands. And there are now, as you may know, probes that literally fit on the tip of one's finger so that you can get images, and the potential for having something the size of your cell phone where one could get images. So that ability to very rapidly get ideas about a pericardial effusion, left ventricular systolic function, some valvular information, and who knows, maybe strain and diastole. But this is really going to be a growing area.
I think if there's money to be made, the companies are going to put all their research into this.
Well, you know, at one time, I'm certainly old enough to remember that none of us had cell phones. And we couldn't imagine a time when everyone had one in their pocket. And really, if one thinks the technology for handhelds is such that one could conceive a near future where all cardiologists, maybe all physicians, have an ultrasound in their pocket.
It's been fascinating talking to you, Dr. Chisel, and an honor and proud privilege. I hope you have a wonderful time in Mumbai. And for all the people who attend CSI, this is going to be the future of echo. And hopefully we're not out of jobs. And if we are, we better start looking for alternative forms of having money. Thank you so much, and good night.
An epidemiologist, and it's a great pleasure to be with Professor G. Prabhakaran from Public Health Foundation of India. He's not only a great epidemiologist in the country working on chronic diseases for a long time, but also a good friend and colleague for the last 20 years now. So today we are going to ask questions about the burden of heart disease which is emerging in our country. What are various options in front of people, in front of policymakers, in front of the politicians to tackle this burden, and what's the role of Public Health Foundation of India? Dr. Prabhakaran is Vice President of Public Health Foundation of India. He's also adjunct professor at the University College London and the University of Atlanta, Georgia. So welcome, Dr. Prabhakaran, and I welcome you to this program.
Thank you, Dr. Gupta. I just wanted to clarify that it's not UCL, but I'm a faculty at the London School of Hygiene and Tropical Medicine and at Rollins School of Public Health, Emory University. I'm also a cardiologist by training. Look forward to chatting with you.
Today we are going to talk about the heart disease burden in our country and how Public Health Foundation of India is trying to control that. So you have written extensively on the burden of heart disease and basically coronary artery disease, but not only coronary artery disease, but also the old friends like rheumatic heart disease, cardiomyopathies, infective heart diseases, also there with us. So what's your take on that?
So this conference has come at a very opportune time because we very recently completed the state level disease burden in India. And according to the state level disease burden, cardiovascular disease has emerged as the leading killer in India. Nearly 28% of the deaths in India is caused by cardiovascular disease, but there's a huge amount of heterogeneity in cardiovascular diseases. For example, in the south, in the west of India, and parts of Punjab, Haryana, etc., coronary artery disease has emerged, or ischemic heart disease has emerged as the major contributor to cardiovascular disease mortality. However, if you go to the northeast and eastern parts of India, stroke is a major contributor to cardiovascular disease. And in the central parts of India, parts of Chhattisgarh, Madhya Pradesh, Orissa, it's rheumatic heart disease which is a major contributor. The other important thing that we need to note is not only is the prevalence very high, but it has risen very rapidly. In fact, from 1990 onwards till now, there's almost a 60% increase in the burden of cardiovascular disease in India.
So what do you think the root causes of this burden?
So when we look at it, there are multiple causes. Most people who are looking at upstream determinants would say it's a rapid lifestyle change induced by urbanization, globalization, increased use of tobacco, increased mechanization, reduced physical activity, and so on. And that's an important reason. But there are other reasons too, and I think one of the major reasons is diet. Our diet is very rich in carbohydrates, so we have very high propensity to develop diabetes. The second is that we consume salt in high quantities, which also is one of the reasons for high blood pressure. The third, of course, is low physical activity, high alcohol consumption. So these are all multiple causes on a background of high risk. It has been shown that children who are born with low birth weight and who put on weight rapidly have higher propensity to develop diabetes, hypertension and cardiovascular diseases, and that could be one of the reasons. There are of course genetic factors, and the biggest elephant in the room currently is environment. Air pollution is an important factor. Air pollution can produce endocrine disruption, can cause inflammation and can increase the risk for heart disease. So there are multiple factors, and I would say it's multifactorial.
So, in terms of the disease burden, we always look at solutions. So, is Public Health Foundation and your organization providing solution to the problem? Because unless we have solutions, we know the problem is there. What are the solutions at the policy level, at the physician level, at the personal level?
So, before I talk about what Public Health Foundation of India is doing in the chronic disease space, it's important for me to describe what Public Health Foundation of India. It's a public-private partnership which was founded in the year 2006 with support from the Government of India, the Bill and Melinda Gates Foundation and private philanthropy. So essentially it works in multiple areas, but one of the important portfolios is chronic disease prevention, and in that I head the center which is called Center for Control of Chronic Conditions and Injuries, which is also a part of an international collaboration amongst 4 groups: the Public Health Foundation of India, the All India Institute of Medical Sciences, the London School of Hygiene and Tropical Medicine, and the Rollins School of Public Health, Emory University. Now, the main portfolio of the Chronic Disease Center is 3 or 4-fold. First, the mechanism of cardiovascular diseases has not been well understood in India. We have always been relying, for example, on the Framingham risk or some international risk to identify risk for cardiovascular disease amongst Indians. So in that direction, we have established a cohort or maybe multiple cohorts in the cities of Delhi, Chennai, Vizag, Sonipat, and even in rural areas of Vizag and Sonipat, through which we are trying to identify the links between risk factors and cardiovascular disease. As an example, let me give the example of diabetes. Diabetes, a lot of us believe, is because of lifestyle modification, increased weight, obesity, insulin resistance and so on. But from our research, it appears that insulin resistance is not the most important cause, but it appears to be beta cell dysfunction. And there could be multiple reasons for beta cell dysfunction, and we need to identify those reasons. The second thing is, if you look at the pattern of myocardial infarctions in India, we seem to have very high ST elevation myocardial infarction as compared to Western population. The reason could be high thrombogenicity, high smoking. We don't know. And smoking is not such a major factor in the Indian population as compared to the US population. But clearly, there could be other reasons, and the cohorts will answer these questions in the next few years. The second area of work that we are doing is in trying to identify low-cost solutions and improving quality of care both at primary, secondary and tertiary care level. Just to give an example, in terms of low-cost solutions, we have done multiple research in multiple settings that includes creating a cadre of physician assistants, creating a nurses, community health workers in the management of chronic diseases. They are empowered with an electronic decision support system, and we have found that this has a huge bearing, particularly even in tertiary care centers, because it saves time for physicians. It saves at least 8 to 9 minutes from patient consultation time. So the doctor can actually concentrate more on the art of medicine than trying to get nitty-gritties of blood pressure, heart rate, which the nurse can actually do it. The nurse provides the lifestyle advice, and we have shown that this actually improves blood pressure control, improves HbA1c control, and therefore it's got a huge bearing. The third, in terms of quality of care, is we attempted a large cluster randomized trial in Kerala in 63 hospitals. It improved the process of care, improved the quality of care, but it didn't change the outcomes. But that's also important to improve quality of care, where we just did 4 simple things. We provided discharge instructions, we provided audit and a feedback loop to these people. And we looked at, asked them to check the process of care at a management level. And actually these things really improved the process of care. The third area where we have worked is in cardiac rehabilitation. There is virtually no cardiac rehabilitation in this country. And therefore we said, instead of establishing the conventional cardiac rehabilitation, the Western-based cardiac rehabilitation, we thought, why not use yoga as a mechanism or an alternate for cardiac rehabilitation? And we have demonstrated, we just recently presented that in the American Heart Association late-breaking study, and was very well received. We're writing that paper up. Then in terms of the policy domain, we recently worked on the Disease Control Priorities Project, which is funded by the World Bank and the Bill and Melinda Gates Foundation. And I, as the lead editor, along with several international collaborators, submitted that report, which essentially has several cost-effective interventions, but not only it focused on cost-effectiveness, it focused on financial protection. Suppose we have 100 crores with us, how do we use that to protect people from getting into, when they have catastrophic illness, getting into poverty? So that's one of the, it reviewed the whole range of literature for several diseases and ultimately summarized them easily for policymakers to adopt. So our work ranges from identifying mechanisms to finding low-cost solutions, but at the same time synthesizing that information and disseminating it to the policymakers as well as the general public.
So what do you think are the barriers to implementation of quality care? Because I believe that quality is the single most important criteria. You have blood pressure control, you have blood pressure treatment, but unless you have controlled blood pressure, it's not going to benefit the people. You have set up intensive care units across the country. Unless you have good people, they will not be able to. So you are doing some training programs also?
Yeah, I think you hit the nail on the head correctly. One of the things is we may have wonderful programs, we may have wonderful mechanisms of controlling it. These are all very simple things. But if you don't have the people to do it, it's going to be a problem. In fact, if you look at cardiologists in the country, even in the best case scenario, we may have around 6,000, 7,000 cardiologists. I think it's much less than that. For a population of 1.3 billion, is that adequate? Therefore, chronic disease management, cardiovascular disease management has to be at the primary care level. And therefore, we have embarked on a very ambitious primary care physician training program. We run 11 programs right now in the management of diabetes, in management of cardiovascular disease, in hypertension management, in chronic obstructive lung disease, thyroid, so on and so forth. And these are very, very popular. And these programs have been developed in consultation with global experts, in consultation with knowledge partners, academic partners, and through a set process which improves the quality of these presentations. We teach the primary care physicians in a very standardized fashion. The courses are delivered all across the country on a Sunday over a 5 or 6 hour period in a very standardized way. This has been extremely successful. In fact, we have trained almost 25,000 doctors in the primary care physicians in the last 5 to 6 years. It has won several accolades and awards. In fact, we recently won the Quality Council of India Award, the Platinum Award, which is the highest award. It's won award from all the organizations like CII, ASSOCHAM, FICCI, the PhD Chamber of Commerce. So all the industry groups, we have won awards. Now it is being scaled up internationally. In fact, Africa is adopting this program. Myanmar has adopted some of our programs. Nepal has adopted some of our programs. We are in negotiation with China and Sri Lanka. So clearly people feel that there's a need for these primary care physician training programs, and that's going on scale.
So in the last 1 year, the talks at the highest level of the government has shifted away from providing usual care into strengthening the primary healthcare system, as well as to provide health insurance to poor. So how do you think Public Health Foundation can help in both these projects?
Yeah, Public Health Foundation of India has actually been involved in some of the developmental process for a very long time. But I think the Ayushman Bharat gives us a tremendous opportunity in terms of health system design, particularly in terms of the primary health care. The health and wellness clinic, which the government proposes, 150,000 of them, is an excellent idea, particularly for prevention and management of chronic conditions, because they don't have to go to a higher center. Higher centers should be reserved for people with complications or for people who cannot be managed at the primary care level. And I think PHFI has developed curricula PHFI has trained these physicians. PHFI is working with allied health professionals to contribute to this care. PHFI has also provided several state governments in maintaining its health accounts. For example, how do we spend? If we have 10 crores with us, how do we spend? So those are the kind of work it has helped. It also has helped in the evaluation of insurance programs. So there are multiple pieces of work PHFI has done in this domain.
Recently, I was reviewing the issue of risk heart disease, and there are 3 studies. One is the PURE, which showed that in spite of having low risk factors, Indians have high mortality, which is the paradox. Secondly, the global burden of disease study, which you just said, has clearly shown in the last 25 years, India or South Asia is the only region in the world where the mortality is going up. And the same is true for the million death study. From 15 years, in the last 15 years, the age-adjusted mortality from heart disease has gone up. So do you think that all these interventions are going to help to reduce the burden, or they are going to help us to achieve decline in mortality from heart disease?
I think we need a multi-pronged attack in terms of reducing heart disease mortality. We need a systems level approach. I think once the health system is strengthened, because if you don't have that health system connectivity, whatever solutions that you may have, you won't be able to address those issues. And therefore you require that health system connectivity. And I think the government is working in the right direction in terms of reducing that. Of course, along with that, you require non-personal policy measures, particularly in terms of tobacco control. And I think India has done exceptionally well, because I think in the last 6 years or 7 years, there's been a 5 to 6% reduction in smoking. Where we are not doing well is in the non-smoking forms of tobacco, and I think we need to work there. I think trans fat reduction is another area, but there are several areas which are within the domain of our culture and our beliefs. For example, it's easier to reduce salt in industrialized countries or in the Western countries. In India, we add salt when we cook food. So that's going to be difficult unless we get behavior change. But it is also a challenge as well as an opportunity. Opportunity here because if we look at the future, maybe 20 years from now, we're going to get more and more processed foods. So we can learn from the West. The Prime Minister's smart cities idea is a great idea because it gives you an idea in terms of how do we build parks, how do we build green space, how does the built environment influence this, how does the transport system influence. So there are several high-level interventions at a population level which can bring down this burden.
So given the limited political choices, we have low-hanging fruits and we have high-hanging fruits. So what do you think should be the first or second priorities of the government?
So I think the 3 areas which the government, this has also been identified by several others, and I think the 3 areas which we should really focus on if we need to address the cardiovascular disease burden, and we may add one more dimension, is tobacco control, high blood pressure control, and secondary prevention. In addition, we also need to focus on diabetes, because diabetes is also emerging very rapidly, and the bigger problem is the pre-diabetes. Pre-diabetes in urban locations is almost 1/3 of the population, and it gives us an opportunity to prevent people from progressing to diabetes. So if we address these 3 issues by improving the human resources, by ensuring that the essential drugs which are inexpensive are available in the system, by improving secondary prevention, I think we will do a lot.
What's your take on the quality issue? So I think that is the most, I believe there is a more important domain of the whole prevention area, that unless we have high quality, low cost interventions, high quality, low cost people in the system, things are not going to change. So what do you think of that?
I think quality is extremely important, and in that direction we are working with the Quality Council of India, working with healthcare managers, people who are at a lower mid-level of healthcare system in improving quality processes in health system. And that course is very popular because it actually teaches the nuances of quality. It has some theoretical component, but several things in our day-to-day practice as cardiologists, for example, if we make it prudent that, okay, when I ask us our question, when you are discharging a patient with heart attack, are we prescribing all the 4 or 5 things that are really required? And if so, and we can say that we are not doing this because of these reasons, then we would have done our job.
Well, thank you. We had a nice discussion.
Thanks.
And I hope we get somewhere. Thank you.
Thank you.
Good afternoon to you all. A very warm welcome to CSI Mumbai. I would like to introduce to you our doctor here, and that's Dr. Rohit Malhotra. Dr. Rohit Malhotra comes from University of Virginia, Charlottesville, United States. Dr. Malhotra is one of the leading electrophysiologists with a keen interest in ablations of atrial fibrillation, left atrial appendage closures, and as well as CRTs. So the questions that we are going to have to him will cover most aspects of electrophysiology. So welcome, Dr. Rohit.
Thank you very much for having me. It's been a pleasure.
So I'd like to start off with the latest guidelines that have just been published on pacing a couple of weeks ago. And they have expanded the utility of CRT implantation in patients who have a CHB with an ejection fraction between 36 and 50%, and where you expect repacing more than 40%. So I would like to know about your practices in the United States and how are you looking at it?
Yeah. So obviously that data is all based on the BLOCK-HF trial, which was published now about 3-4 years ago. That trial actually took quite a long time to enroll. The full number of patients actually never met the number that were expected to enroll. I think part of that ends up being that our institution, like many in the United States, including those that participated in BLOCK-HF, if we take a simple dual chamber pacemaker implant, that usually takes roughly an hour. If we put in a CRT device, that can take anywhere from 1 to 2 or 3 hours. And so I think that was part of the challenge of that. However, based upon the results of that trial, when we have patients who come to the hospital with complete heart block, our predisposition to putting in CRTP devices now is much higher. One of the other things that has become more commonly used in the last year or so as well in the United States, there's been more His bundle-oriented pacing. Now, the challenge with that ends up being that we don't really have any true randomized trials to look at long-term outcomes. Our experience has been across the United States that lead placement may have higher thresholds in the His position, and those thresholds tend to rise over time. And so we don't know whether, in someone who has complete heart block, whether we're able to actually implant and pace in the His position. True. So if we plan for His position pacing and then have to change to a CRTP, that can be cumbersome. Changes the plan for the day with the lab, or vice versa, saying we're going to proceed with CRTP placement, but then there can be challenging CS anatomy. Or if the patient is, it takes longer to get a lead in and we're uncomfortable with how long they have heart block or how we're pacing them in the interim. So in each of these cases, I think we take it in a case-by-case basis. So for younger patients, we're more likely to implant either a CRTP or a His bundle lead. For older patients, there are often other comorbidities that come with the complete heart block, and so that'll impact our approach and planning for the procedure.
Yeah, I think I would like to add about the BLOCK-HF and the BioPace trial. When you review the data, if I understand that correctly, BLOCK-HF gave very good results if you gave CRT, while BioPace said differently in patients with nearly preserved ejection fractions, and it said that probably you could go in for dual chamber. So I'd like to know from you, for a country like India where CRT would be available largely in metros, and would you consider telling us that maybe if you were to give a dual chamber for an ejection fraction of 40%, it's a good idea to go septal? Or do you think that you're still practicing apical? Would you like to talk about that?
So typically for us, at the Heart Rhythm Society meeting in the United States, I think every year there's a debate, a pro and con of septal versus apical pacing. And I think I've been to one of those sessions and had the one speaker say, if you are implanting in the apex, you are doing the wrong thing. So I typically actually still implant in the apex for a number of different reasons. One is lead dislodgements may be lower. In older patients, that's one of the considerations. So an older woman, I might consider placing more on a septal location rather than an apical implant. But our patients on the whole in the United States tend to be larger than they are in most of the rest of the world. We're winning in that regard.
Yeah.
And so I tend to worry a little bit less about perforation in those cases. And so far, the data for septal versus apical implant really has not demonstrated significant benefit.
True.
And so now the exception to that is likely to be His bundle pacing. The challenge with His bundle pacing is that there is a substantial learning curve both in terms of the implanting physician, but also post-implant management. Most of for us personally in our institution, our post-device implant patients are usually seen by technicians, nurses post-implantation. And so there isn't really a clear way for us to delineate to our support staff that this is a His bundle lead.
True.
And then they need to look at it and understand, okay, how am I supposed to program this device? Am I supposed to program it with the lowest output for the longest longevity, when in fact we implanted it knowing that it would have a higher threshold in order to capture the His bundle? And then in follow-up, how do we maintain that higher output in order to maintain capture in the His, particularly if there can be climbing thresholds over time? And so that experience, I think we still don't have enough of that experience and no clinical trial data to really support that. So if in fact we were to use the most supported data for complete heart block, really CRTP should be the approach that we take.
True.
That has the most data behind it.
So taking the question further, as far as His bundle, I think you have significant experience and excitement about the His bundle pacing. Would you recommend for the newer implanters, it's a good idea to attempt in 6 sinus patients, or would you think that AV block, or do you think we should go ahead and give 2 leads, one in the RV apical and one in His bundle?
So I think generally if one is eager to learn how to do His bundle pacing, then the 6 sinus patients are the ideal patients to learn on, because without needing to do full-time RV pacing, then at least we're putting in a lead into a position that may not have long-term consequences for the patient. If we, the steerable sheaths that we use to implant those very flimsy leads do allow for non-His position pacing. And so if we can't find an optimal His bundle position, we can still implant it safely in the RV. And so learning on patients who have fairly standard anatomy is probably the best way to start. That's not often how we start, but it probably is the best way to start, particularly if one is going to move in that direction.
So moving back to CRT and heart failure, I'd like to ask you, how do you do monitoring of your patients on their follow-ups?
Yeah.
Do you do remote monitoring, or what kind of policies do you all have?
So in general, at our institution, we follow the guidelines, which basically delineate 3 months. So post-implant, we see patients within 2 weeks. That's typically with a device nurse rather than with a physician necessarily. Following that, I usually will see patients at the 3-month post-implant mark. And then after that, they'll follow 3 months remotely and 6 months in office. So in a year, there'll be 2 in-office visits and 2 remote interrogations. In general, those data come to us directly into our medical record, and so we review that data. Typically, most of our heart failure patients are often followed by a heart failure physician as well, and if they're not, then we manage their heart failure therapies as well as examining volume status, which can be interpreted or indicated by device-based measurements, depending upon the device, either the St. Jude Abbott CoreView monitoring or the Medtronic Optival system. There are some nuances to those systems, though, in terms of knowing what they mean and whether they're important or not. I have certain patients who seem to have certain trends where we see that the Optival measurements will go up in a period of time without any accompanying heart failure symptoms. And we've actually looked back at certain patients, and in a year, we can see that every year they have a replicable pattern of Optival changes, which I can't explain, but we can actually see this pattern, often without accompanying heart failure symptoms, but often with as well. And so our device nurses, when they see a change in the Optival, will actually contact the patients and find out if they've had a weight gain or they have any symptoms of heart failure. And if they do that, they will note that and direct those patients to us. If not, then they note in their interrogation note to us, we've contacted the patient, they're asymptomatic at this time. The lead time between changes in thoracic impedance and heart failure symptoms can be disparate though. And so the patients are at least informed of the fact that there's been a change. Sometimes that leads to a change in their behavior and sometimes not.
So in your clinical practice, what is the percentage of patients that you monitor remotely as far as the heart failure devices are concerned?
So institutionally, between heart failure physicians and the electrophysiologists, I would say it's about 90%, 90 to 95% are monitored. The challenge across most institutions in the United States is actually trying to determine who's actually going to follow the data.
Right.
And so there are actually some, there's some quirks to the billing associated with interrogation of these devices.
Absolutely.
And so whether we interrogate devices remotely for electrophysiologic parameters versus heart failure parameters, those can actually build differently.
I see.
And they can be actually billed on a monthly basis. And so if one is looking for heart failure parameters, that can be billed more frequently, which can be challenging in a healthcare environment like in the United States, where there are challenges to costs.
True.
And I'd imagine more so here,
Absolutely.
where patients are going to be, I don't know if there are charges to remote interrogation or how that works domestically.
Yeah, so it's a bit complicated here. I would completely agree with you on that. And my question, which I think is very dear to implanting physicians who implant CRT, is to reduce the burden of non-responders.
Yeah.
So I want to hear from you, pre-implant to post-implant, what is your strategy to reduce the percentage of non-responders?
I think the most important thing with regards to non-response with CRT is to pick the right patients. And so truly following the guidelines. For patients with optimal guideline-directed therapy for 3 months with class 2 heart failure symptoms at least, if they have a left bundle and a QRS duration of greater than 150, those people I usually can say with some confidence, you're likely to have a good response to this therapy. For patients whose QRS duration still with a left bundle is between the 120 and 150, I usually will counsel those patients that you may not have as great a response. And particularly with right bundles, I say to them, this is really a decision that you would need to make, and we should make that together.
So if I can stop you here for continuation. In your practice, what is the percentage which would have QRS more than 150 with LBBB versus the other?
Yeah, so the ideal patient for CRT implant is a diamond in the rough these days.
Absolutely.
They're very hard to find. Typically, most of our patients will end up falling in the 120 to 150 range. And those are difficult conversations to have. Typically, when we talk about CRT implant, we're hoping most patients they're interested in extending their lives, but most of what they want is an improvement in quality of life. And so to counsel people on how much benefit they'll derive from CRT therapy can be quite challenging. And those patients end up being the bulk of our patients. So we discuss
pre-implant.
Pre-implant, yeah. So pre-implantation, we will discuss with the patient, look, this may not be the perfect EKG. You may have some response, you may not. And how to assess that response can be challenging as well. So I've had one patient who had several prior attempts at LV lead implantation, all of which failed, had recurrent heart failure hospitalizations and was referred for another attempt. So we were able to find a position, and when I saw that patient back post-implant, he said, I don't really feel better. But I said, you haven't been in the hospital in 3 years.
Right.
And so how do we temper that perception of what response is?
Right.
And so he actually had quite a successful response to LV pacing, but didn't perceive it that way. And so I think part of what we also need to do in speaking with patients is lead them to expect and what to expect. You know, if we start off telling people you're going to, you know, 3/4 of the time you're going to feel better, that isn't always, you know, people expect, oh, I'm going to be able to get up and run around, when in fact that's not likely to be the case. We may improve somebody from heart failure class 3 to 2, but we're certainly not going to take somebody from 3 to 1.
True.
So, and explaining that to patients, having them understand that, gain some insight prior to the implant, I think can be very, very helpful. Again, particularly here, where patients are going to be guided by, you know, I have to pay for this device potentially, knowing which device might benefit them more and what they're seeking in terms of quality of life versus quantity of life can be potentially very helpful.
Right. So, in your post-implant, what is your practice in programming the device? Do you have the RV pacing on, or do you like to do it with pacing off? I'd like your inputs on that.
So typically, particularly with the current generation Medtronic devices, which will do adaptive pacing, in people who have a normal PR interval and a prolonged QRS, those devices can be very, very effective in avoiding RV pacing, which, as we know, can be deleterious to heart function and precipitate as much heart failure as not pacing, or as not BIV pacing. And so typically in those devices, I'm very happy to see how much LV only pacing they're having. We won't typically turn off RV pacing. We'll keep it on for the adaptive element of that. But in other device companies, we tend to have more fusion pacing, more RV and LV pacing combined. So I think there are some distinct advantages to that. You know, based upon the studies that we've seen, there does appear to be distinct benefit to avoiding RV pacing. But I don't typically turn off RV pacing in those. So in St. Jude devices or Abbott devices, they'll actually sense LV and sense RV. So one could program those devices, but they don't have the predictive nature that the adaptive CRT does to track the AV delay and appropriately pace so that there's fusion between intrinsic RV activation and then the LV fusion pacing. So that ends up being quite limited to just one device manufacturer, at least for us.
Another question which I'd like to ask you is, for the responder rate to increase, would you do an echo-guided optimization for every patient that you implant, or is it something which is reserved for the subset which does not respond?
So typically, we reserve echo optimization to non-responders. The data on echo optimization the challenge is just the dynamic nature of people, right? We're up and moving about. We do echo optimization while people are recumbent, and so it can be quite challenging, but that's usually reserved in our institution for people who will not respond. We are a research institution where we're doing pre-procedural MRIs in order to determine both optimal. It helps us determine both the venous anatomy pre-implantation as well as areas of scar and areas of delayed activation in order to determine what the best site of implant may be. So perhaps that leads to some better responder rates than perhaps otherwise, but in general we still reserve echo optimization to the non-responder.
Is there any role of, coming back to the HIS bundle, do you ever think there is a role of seeing the QRS duration when you do your pacing? Because what we've begun to do in our centers, a few of us, is supposing we're giving a dual chamber and we are giving a HIS bundle, would you like to consider that, let me see the QRS duration at various sites and then go ahead and do the pacing?
Yeah, so the data on that still, there really just isn't enough data to suggest that pacing in multiple sites is going to be helpful in terms of long-term outcome. The challenge ends up being that just in terms of doing echo optimization for CRT, you can also do QRS optimization for CRT. Yes. And there really isn't good data for one versus the other. And in the same way, there isn't necessarily good data for shorter QRS duration based on pacing.
Right.
So I think the one exception to that ends up being direct His-Purkinje pacing, right? So if we get into the conduction system when we pace, then that may have long-term benefit. But beyond that, having the QRS look more narrow doesn't mean that there's not going to be dyssynchrony.
True.
And so I think that ends up being one of the challenges. The other issue ends up being that just because the QRS is narrow doesn't mean that depolarization of the ventricle is done in a more synchronous fashion as though it was going through the His-Purkinje system. There's lots of evidence to suggest that fibrosis within the ventricle can lead to disparate conduction and dysynchrony. And so just because the QRS looks narrow doesn't mean that LV depolarization or RV depolarization is synchronous. And so I think that makes us feel better, but there's no evidence to suggest that there's long-term benefit to that.
In the post-Danish era, how has your practice changed?
The reality ends up being, I think, for most of us, we still are practicing in a pre-Danish area. For most of my patients, we talk about the advantages of CRTP versus CRTD. And so, particularly now, in about February of this year, the U.S. Medicare changed its guidelines and actually mandated that we have documented shared decision-making. Now, my practice had always been to do a degree of shared decision-making with my patients, talk about the risks of implant and post-implant management of the device and risks of complications. But now we talk a lot more about the benefits of CRTP versus CRTD and the time differential in terms of longevity between those two, on average in studies, being just months.
Right.
So.
I see. So, I think, would you like to speak on AF ablation a bit? We'll just touch one subject on one question.
Yeah, I think earlier in the CRT discussion that we had, there was a lot of, we talked specifically about AF ablation in the setting of heart failure. And I think, with the recent publication of Castle AF and how that impacts how we manage heart failure in the setting of atrial fibrillation, the challenges with AF ablation in an environment where we are doing a lot of it, the success rates are not always what we'd perceive them to be or what we'd hope they would be. And in particular, in patients with heart failure, those results can be poorer. And so I think we still have to approach those patients with, as long as they have an understanding that I'm going to get a procedure to manage heart failure and to help me symptomatically that may fail after some period of time, as long as they understand that and are have eyes wide open about that, I think that's a very reasonable approach. And I'll be seeing a 30-ish-year-old man with heart failure who's developing AF to talk about ablation I think on Tuesday when I get back to clinic. And so patients are very aware of the fact that the outcomes of ablation are not always perfect. But when you take a young patient who develops AFib and an AFib-induced cardiomyopathy, for example, those patients would much prefer to manage AFib with an invasive approach rather than putting in a long-term device. And so I think a lot of that depends. So the patient I'll be seeing next week already has an implanted device. I'm thinking of another patient who is in his 50s, woke up one morning with severe heart failure, was hospitalized for 2 weeks, and cardioverted, maintained sinus rhythm, but then his AF was all a tachy-induced cardiomyopathy. And so he underwent ablation and has been doing quite well, but now anytime his heart rate doesn't feel quite right to him, he's quite anxious about the potential for recurrence, particularly of heart failure.
So I think my last question to you would be about left atrial appendage closure devices. So I want to understand that in your clinical practice, how often do you find a patient who you cannot offer an OAC and deserves to undergo a left atrial appendage closure?
So the challenges with that are actually quite deep. So just last week in the hospital, I was taking care of a patient that I'd done an appendage closure on 2 weeks prior. That patient had had a bilateral lung transplant, developed atrial fibrillation post-lung transplant, which one would think would be quite uncommon, but it happens a fair amount. we implanted the device knowing that she'd had prior bleeding episodes, and we discussed, you may bleed after we put this device in because we put people on anticoagulation.
Right.
And so I was seeing her in the hospital because she'd bled quite a bit, and we talked about what to do. She had upper examination, lower examination with no source identified, and she left the hospital on aspirin alone. So not ideal anticoagulation. But these patients are not a perfect population. We don't have good answers for them with regards to anticoagulation, because almost all of the patients that I'm implanting these devices in have bled already.
Yes.
And so I discussed with all of them, how are we going to approach anticoagulation post-implantation, and what do we do if there is recurrent bleeding? So they all understand that there are limitations. There is no perfect patient for this device. The studies all show that often patients have more issues with bleeding post-implantation than they may have beforehand until they get off of the anticoagulation. And managing that risk in the long term, determining how best to anticoagulate people, I think is going to be a big problem until we're doing. So ASAP-2 is a study that's being done to evaluate the safety of anticoagulation and what approach should be taken. So that's a very important trial, but it's very, very difficult to enroll patients in. The randomization is to either continued therapy with current anticoagulation, whatever strategy that may be, or device implantation. Most patients aren't willing to be randomized to no intervention. So they're not willing to enroll in that study. Right. So the companies had a very difficult time enrolling patients. But again, I think part of the way to manage that is to have patients understand what is going to happen to them afterwards and what the risks are. So as long as they understand that, as long as we have a therapeutic relationship, I think that it ends up being helpful to them.
So I'd like to thank you very much, Dr. Rohit, for being here with us, and look forward meeting you in the next upcoming CSIs in the coming years. Thank you very much.
Thank you very much. It's been a real pleasure.
I am Professor Dr. G.N. Mohapatra, Senior Consultant and Chief of Department of Nuclear Medicine and Nuclear Cardiology Division and the Cardiac Imaging Division of Seven Hills Hospital, Mumbai. You all know that ischemic heart disease is a #1 killer in India day-to-day practice. There are so many other imaging modalities which are invasive and non-invasive available to diagnose coronary artery disease and to advocate further treatment planning. But nuclear cardiology plays an important role and a crucial role in the diagnosis and the further treatment planning of the coronary artery disease in Indian scenario. It is a non-invasive, cheap, easily available, exclusive, no radiation to the patients, no contraindication except pregnant patients who can be subjected to these nuclear cardiology procedures. What does this nuclear cardiology procedure does? We inject a very short-lived radioisotope when the patient will be walking on the treadmill exercise, and we inject at the peak of the exercise, and then we ask the patient to lie down under a dual head SPECT-CT gamma camera, and here we take the images, and the images is reconstructed, sliced, and projected in a sequential manner with the stress imaging. After 3 to 4 hours in the resting image, we take the resting slices in the similar way, and then the scan is ready for interpretation. So the scan is the stress slices and the rest slices that shows the myocardial perfusion at the stress level. There are many indications where thallium or technetium labile system by myocardial perfusion scintigraphy can be performed. Number one, if the patient having strong family history of ischemic heart disease or uncontrolled or controlled diabetes mellitus, especially type 2, or patient having hyperlipidemia, the cholesterol and triglyceride levels are high, or there is a strong history of smoking, or there is a family history of ischemic heart disease. These patients they can be subjected for a stress thallium or stress system by myocardial perfusion scan, because the non-invasive, no side effects, no contrast, and we can get enormous informations by doing this type of studies. Here we can find it out in a form of a stress perfusion defect, where the radioisotope failed to reach into the myocardium, whether it is anterior part or the lateral part or the posterolateral part or the inferior part or a apical part. And this perfusion defect, after 4 hours of the imaging, we take a resting image, and this perfusion defect which fills up in the delayed image, that shows a ischemic, viable, hibernatic myocardium, where the patient can undergo, if it is a small perfusion defect, no symptoms of angina, the patient can go for a medical treatment or optimum medical therapy. If there is a bigger defect which fills up in the resting image, and the patient can be subjected for either angioplasty or a bypass surgery. In that case, patient has to undergo a coronary angiography, which is an invasive procedure, followed by angioplasty or a bypass surgery. This is one subset of patients. Then the next subset of patients comes when the cardiologist, when he does a coronary angiography and borderline lesions are there. For example, a left anterior descending 40%, 50%, or some plaque, or some calcium score, high calcium score, and in that case, one can be subjected for a stress myocardial perfusion scan. If a stress myocardial perfusion scan shows a hemodynamically significant perfusion defect or stress which fills up in the delayed image, then that comes where the intervention is required, and cardiologist will go ahead with the intervention, because a borderline lesion, he could not decide whether the patient should be subjected for angiography or angioplasty. Number 3 patient, when a patient has suffered a heart attack, acute myocardial infarction, and patient goes home after the symptom and everything is subsided, and after about 6 weeks, we can assess the amount of myocardium which has been dead because of past myocardial infarction, as well as the other areas of impending ischemia which can contribute again a second heart attack, that also we can rule out and we can give the information. Then the patient subjected for a coronary artery bypass graft, or the patient which has undergone a coronary angioplasty, then in that case the patient comes with symptoms like shortness of breath and everything, then we would like to know whether the patient has got any closure of the shunts or the closure of the graft. Then we can subject the patient for a stress thallium or stress system by myocardial perfusion scan, which will reveal it out. We will find a myocardial perfusion defect, followed by a filling it of the area, which is a typical pattern of graft blockage or the stent blockage. And if another group of patients, when the patient had already a heart attack, that is called chronic stable angina, in my opinion, every patient of chronic stable angina, the person or the patient has to go for a non-invasive stress myocardial perfusion scan, which will tell whether the patient should continue the medical treatment, whether the patient should continue the invasive treatment like coronary angioplasty or bypass surgery. For example, if there is already a dead scar which has been formed because of the past heart attack, and it is there in the stress defects, stress images, and also in the rest images, that is called infarcted scar dead myocardium. In that case, patient would not get benefit out of CABG or angioplasty procedure. Even if they do a angioplasty or CABG, patient would not get benefit out of CABG or angioplasty procedure. Then another group of patients has to undergo always this type of angioplasty, this type of perfusion scan. But another group of cases where there is a balanced ischemia, means the perfusion, the defect was there, but the other areas are showing perfusion, so we'll get a reduced perfusion in all the images, all the areas. Like anteroseptal, anterolateral, posterolateral, infraapical. That is called balance ischemia. In balance ischemia cases, if you do a myocardial perfusion scan, it will show a perfusion defect. Then the cardiologist would be very confused which artery to be intervened or which artery not to be intervened. In that case, we have another parameter called coronary flow reserve, CFR. Coronary flow reserve, which will tell about the LAD, right coronary and circumflex, whether there is a CFR less than 1.3 or 1.4 is significant. If there is CFR decreases in all the territories or 2 territories or 1 territory, then the cardiologist can go to intervene that particular artery. Then number 3 indications for coronary flow reserve is that patient having borderline lesion, less than 50%, 40% lesions. In that case, where the patient doesn't know what to do, and if you do a coronary flow reserve says the LAD, circumflex and right coronary arteries showing CFR of less degree, like less than 1.3, 1.4. In that case, the patient has to be intervened. Apart from these uses, there are lots of any other like a atheromatous plaque, whether it's a stable plaque or a unstable plaque. We inject F18 FDG or F18 chloride, which will go and pick up. If it is an unstable plaque, it will show a hot area. So the cardiologist, when he is treating the patient, he should see, look, here there is a unstable plaque which can move from one area to another region and block the artery and produces a massive myocardial infarction. So these are the area. And PET, which is the gold standard for the myocardial viability, which is called the emerging giant. It is an established giant where patient having poor ejection fraction, having multiple perfusion defect, and in those areas, if F18 FDG PET study shows there is metabolism in all these areas, then even if the ejection fraction is 15%, 18%, 20%, the patient can be subjected for bypass surgery or angioplasty. In that particular case, if there is metabolism, then the patient would get benefit out of revascularization procedure. As compared to perfusion defect on the stress system by images, and there is no metabolism. So this is called match pattern, where the patient would not get benefit out of angioplasty or the revascularization procedure. The dead myocardium, in that case, in this type of patient has to continue the medical treatment or cardiac transplantation. These are the 2 choices. With these, I think I welcome.
Good afternoon. My name is Prabhakaran Dorairaj. I'm a cardiologist and an epidemiologist, and I'm currently Vice President Research and Policy at the Public Health Foundation of India. Welcome to this TV show. We have a very distinguished guest here, Dr. Regina Benjamin, who was the Surgeon General during the period of President Obama, and she has several other awards, qualifications, and I can go on and on, but I want to read out a few. She's an American physician, formerly Vice Admiral in the US Public Health Services. She served as the 18th Surgeon General of the United States. In 1998, she was awarded the Nelson Mandela Award for Health and Human Rights. She has the badge of Office of the Secretary of Health and Human Services. She was American Medical Association Foundation Leadership Award, and she was recognized by the Time magazine in 1999 as the nation's 50 leaders under 40. Right. And she also received one of the most inspiring awards called the National Caring Award, which was inspired by Mother Teresa. Yes. And there are many, many more such awards. I don't want to get into all the awards because we will finish off this whole half an hour with that. With this background, I read through your CV. Your early life was very, very inspiring. Please tell us briefly about that.
My early life?
Yeah.
I grew up in a small town in Alabama, and basically had a normal life. We weren't very wealthy. We were poor, but I didn't know we were poor. So because we had enough to eat, we had land and that sort of thing. But my mother and my grandmother always taught us that we should do for others. And so I grew up with a sense of service. And I learned that from them. And servant leadership is so important.
Right. Can you talk briefly about the rural clinic that you established and how it opened up your horizon in terms of the health systems in the United States?
So when I was, as you mentioned, I was active in the American Medical Association, and I attended their meeting, and one of the intense issues that was being debated was that sexually transmitted diseases needed to be taught in medical school. So I stood up in a room with maybe 15 people, and I told them I'd never seen certain diseases except in a textbook, and I thought there was a need. They passed that resolution and they forwarded it to the American Medical Association. And once they forwarded it, they sent me to speak to it. And the resolution passed. And within 6 months, every medical school in the United States was encouraged to include sexually transmitted diseases as part of their core curriculum of all medical schools. So I learned that one person can make a difference, whether it's in medical policy or in medical practice. So I learned I can make a difference when I went to my little small town of 2,500 people and started practicing medicine there.
So from the proverbial young boy who was trying to save one fish at a time on the long beach to a good shepherd, how did that transformation happen?
Well, you know, that starfish thing, it does make a difference what you do one person at a time, and I still believe in that. I believe that once every person we interact with matters, and that if we can just make a difference for one person, you'll eventually make a difference for everyone. When I left to go to the national and international stage of medicine and prevention's my whole thing, I just went from being a doctor, the only doctor in town, to be having 300 million Americans as my patients. And so I just looked at it the same way. The same thing with policies. We make sure that the policies that we put in place can affect people in a positive way. We first do no harm. I want to make sure that we can get people access to care and those sorts of things.
So in your acceptance speech as Surgeon General when President Obama invited you, you expressed your dissatisfaction with the health system. How did you go about changing it?
Well, I wasn't dissatisfied with it. I just felt like we needed to cover more people who didn't have access to care and people who didn't have a way to get to the doctor. They didn't have insurance, in our case, to pay for it. We needed to make it available. And we also needed to give people an opportunity to be healthier. And as I always say, we needed to make the healthy choices the easy choices. And it's hard to be healthy if you don't know where your next meal is coming from. It's very hard to be healthy if you don't have sidewalks to walk on, if you don't have the infrastructure in place. And I think that's one of the roles of government, is to help that. So we needed to put together some sort of plan to make sure people can be healthy and encourage them to be so.
So in India, we are at the threshold of making history in terms of healthcare, modification of the health systems and so on. Before I come to that, I just wanted you to share your experience on the Affordable Health Care Act and the so-called Obamacare and how it transformed the United States. What are the challenges that you face? What are the things that you changed? It will be very useful for us in terms of lessons learned from there.
So with the Affordable Care Act, or the Obamacare, we went through the political process of debating back and forth, but at the end of the day, it was the right thing to do. We tried to put things in place that would protect people, protect the fact that they needed access to care. So one of the parts that I was responsible for once it was passed and was the part about prevention. The Affordable Care Act had in it the National Prevention Council, 17 cabinet level members who reported directly to President Obama, the Secretary of Health, the Secretary of Labor, the Secretary of Transportation, the Judicial, which is the Attorney General, all sitting around the table for the first time to talk about prevention. And I had the honor of chairing that council called the National Prevention Council. And so we developed what's called a National Prevention Strategy, and that strategy is a roadmap to being healthy. The U.S. uses it, many cities use it, a few countries are using it as a roadmap to try to figure out how to make a healthier community, a healthier population. And so prevention is the start. And one of the things in the U.S. and other countries is we're very good at tertiary care. We're good at treating things after they get bad. We need to go upstream and try to prevent people from getting sick in the first place. And so that's the whole idea, is let's try to do what we can to either prevent them from getting sick or preventing it from progressing.
So I think it has a lot of lessons for our healthcare too. And if I were to briefly tell you about the Prime Minister's plan, which is called the Ayushman Bharat, I think it's a very revolutionary idea. In fact, when we talk about affordable healthcare, we probably spoke about 10, 20 million people, I'm not sure how much. But in terms of Ayushman Bharat, I think we're talking in terms of impacting 500 million people. And there are two revolutionary ideas in that. One is redesigning primary care, where we're going to have 150,000 health and wellness centers, which will focus on primordial prevention, health promotion, and lots of other things that you spoke about. And in terms of secondary and tertiary care, it speaks of financial protection for individuals. As you know, catastrophic illnesses can push people into poverty. I think a quarter of urban people and rural people are pushed into poverty because of catastrophic illnesses. And in that sense, it's going to protect millions of people. So, from your lessons in the Obamacare, what is your advice as to where should we see what the problems are? What do you think, some nuggets that you can give us?
Well, my idea is all about prevention. So I want prevention is to be a key and a basic part of any plan. And I think that would be a good platform to be on, particularly at the primary care stage and in the early stages, and giving people an entry into the health system itself. You should be able to enter it before you get to a catastrophic time. You got to start somewhere. It's a big problem. It was a huge problem for us. It still is a big problem, but our numbers are much less than the numbers you're talking about. But those are the people that can be helped. And so you have more of an opportunity to help people. It's nothing like having a mother who has a sick child and don't know what to do and don't have anything to do. It's so heartfelt to see a mom who wants to do something and can't, and we should be able to help them get access to that care. The other thing is that a parent who's a full breadwinner should be able to have a healthy life so that they can provide for their families, and health is part of that. It's just as much a part as a good job, as having food on the table. Having your health really matters. I would say that people will block change. And so we saw a lot of people who were afraid of change, and change is frightening. But once they saw that this change was for the good, for example, one of the things the Affordable Care Act was, it told insurance companies they couldn't discriminate based on pre-existing illnesses. At first that was not a big deal, but now people have experienced it. They don't want to lose that. They understand that I shouldn't be prevented from having care because I actually had a broken arm one time, and so that shouldn't stop me from getting coverage. So stick to it and just do the right things for the right reasons. Yeah.
I thought I should highlight some of the differences between the Affordable Healthcare Act and our Ayushman Bharat, or the Modi Care as we call it. I think one of the fundamental differences is that yours was insurance based and it was compulsory. I mean, the whole population needed to have. But here we are talking about close to 40% of the population. Do you think we need to extend it to our whole population? If so, what do you envisage that we should do?
Well, we talk about health equity, and so we started with, and I think you are too, starting with those below the poverty line. Because those below the poverty level really are in urgent need of taking care. And you could have another phase, but at some point it's going to need to be extended because those folks in the middle portion will need some services as well. And if they're, it's their government too. So they should have some sort of access. But if you can't take care of the most vulnerable and the poorest, you got to start there.
The success or failure of every great idea is dependent on the nuts and bolts, the infrastructure. So what's your advice? What are the, let's say, 2 or 3 essential things, essential ingredients that are required moving forward?
Like I said, the prevention part, the access to care. People also need, this is new, so they're going to need some some education. The patients are going to need education, the providers are going to need education, the clinicians, the government, and no one can do it alone. So in our national prevention strategy, we talk about how we need to join forces, and everybody has a role to play. Everyone in education, everyone in law enforcement, the taxi drivers, everybody has a role to play. So the more we can do things together, it'll spread out that burden. It's going to benefit everyone, and as it benefits everyone, you have a healthier workforce, you have a healthier society. So that's major. I also would say figuring out how to pay for it is going to be the most difficult, and and you may get things right first, and you may have to change it and tweak it, and you may get things wrong. That's going to be difficult, but that's to be expected. But you got to start, and you got to get it started.
So to summarize what you're saying is, I think you're saying from the patients or the community perspective, we need to create awareness, we need to empower them, so that there's a demand generation from their end. In terms of the providers, I think they need to radically shift and think that they are partners in the healthcare rather than the providers, actual providers, that they are partners and influence the care. So I think there are lots of things.
We're partners. I mean, we need to be partners,
Yeah.
but we are providers. But we also, patients tend to believe. I mean, they trust us,
Yeah.
and so we have a real strong leadership role because our patients do trust us. And if we say something to them, they'll trust us before they would trust someone else. So in that respect, it's much more a responsibility for providers. One of the things that I've noticed here at this conference is a lot of technology, and I gave a talk on mHealth. I think technology can help bring down some of those costs by getting things out to people where they are. And so if you can get technology out there, for example, with an EKG machine, you could save people the time from coming in, but you also can catch things early. And if you saw an abnormal EKG, they could go to their local hospital, get it taken care of quickly before something really bad happened.
Right, I just, because you brought up technology, there's one more aspect which I didn't mention, because I just wanted to know your experience in the United States of task shifting, particularly nurse practitioners, physician assistants, and their role, particularly in the management of cardiovascular diseases, especially if they're empowered with simple technology. So what's your experience?
So one of my experience is that I was very involved in licensure and medical education, and so what we call the scope of practice, and that's what you're describing, that scope of practice extending from not just the doctor, but the other clinicians, the nurse practitioners. We have physician assistants, and we're even going now into the patient navigators, and so those other clinicians and have a real role to play because they can spend time educating, they can get to spend more time with the patients, and then when we as physicians see them, we can concentrate on where the issues are. The thing with the patient navigators and community health workers, they can go into the homes and find out, why that diabetic blood sugar keeps going up on Tuesdays or not, and that can change how we treat them. And we couldn't do that. You can't take a doctor's time to go out and find that out, but that is a major role to play. What you don't want is to have that that competition and saying, oh, you're getting on my turf, but use it as a team. And we see that the team approach is much better than individual.
So the US spends close to 17% of its GDP on healthcare. In India, I think it is mentioned anywhere between 4 to 5%, but the public sector spending is extremely low. It's around 1 to 1.5%. Now, as we are embarking on this journey, we need to definitely increase our spending on healthcare. So, what are the lessons? Because this has been talked about. Despite spending 17%, the health inequities are huge between states.
My thing is prevention. So I think if you're going to spend your budget on anything, prevention really will pay off in the long term. Clean air, clean water, those things will decrease your cost and the amount of morbidity and mortality in the long run. Tobacco, the smoking, and and as Surgeon General, that's my area. the one thing you can do to help decrease cardiac disease is just have a smoke-free society. So putting a portion and dedicating an active portion of that budget into preventive services, into public health infrastructure, just making sure we have basic clean water, basic clean air, basic vaccinations, those things will pay off in the long run.
So what I understand from what you're saying is, apart from investment in healthcare itself, what we need to do is to look at upstream determinants, the social determinants.
The social determinants, yes.
And larger policy, non-personal policy measures, if you have to...
And that's where it takes the team. It takes the politicians, the government sector, the philanthropists, it takes business people, it takes education, the colleges and universities, the law schools, all of them to start attacking it as the problem as a social determinants of health. And that's why health doesn't just occur in the doctor's office. It is all of what we're doing. In order for us to truly be healthy, we need to be healthy everywhere we are, at the work site place, when we're driving our car, every place.
The last question I wanted to ask you is, as a Surgeon General, you had a mandate with regard to the health. But as we know, health is beyond the domain of health providers or health policy makers. It's a multi-sectoral concept. How did you manage that multi-sectoral dialogue, and what lessons can we learn from that?
So it was pretty easy once we put in the National Prevention Strategy, because we've got a lot of input from various organizations, various groups. We got the business group on health, with the Fortune 100 companies. We had different people that started to understand that they had a role to play. And as I went around the country and actually the world to talk about how we all can make a healthier society, people started taking responsibility, because the companies, it was taking a big part of their budget, especially the NCDs. The country's GDPs are starting to be affected. So everyone knew that we have to attack it as a group. And as I think as physicians, we can be leaders in that. And we have to play a major role, but we need to engage other people to help us do that.
So Dr. Benjamin, on behalf of CSI TV, thank you very much. It was wonderful talking to you, and I think we have lots to learn from you, and we also have some lessons that you have learned, which...
We've learned a lot. I've learned a lot, and I think the U.S. can learn a lot, particularly around tobacco. You know, I'm very pleased with your leadership the country has taken in banning e-cigarettes, having the 85% package cover, so those things we can learn from you. And so there's mutual relationship.
Yeah, bidirectional, yes, we call it. So thank you very much.
Thank you.
Good evening, everyone. I am Dr. Manish Bansal, and with me is Dr. Rajiv Agarwala, a senior interventionist from Meerut. And we are going to summarize today's key messages from the CSI meeting, day 2 of the meeting. First of all, we must acknowledge the fact that attendance has been very good.
Yeah, this is a wonderful day, and we had a lot of attendance, halls which are full of people listening to international faculty and the national faculty. As you know,
I had more than 4,000 delegates.
Yes,
so
and we had about 1,000 people from the industry. So it's a good mix-up of industry and the people.
Yes.
And we are enjoying the meeting.
And good mix-up of topics also today, right from atherogenesis in the morning to advanced intervention. Almost whole gamut of cardiology was covered.
Yes, the beginning of the day was with the basics of atherosclerosis, and we had good discussions. I in fact talked about inflammatory aspect of the disease, and it's very revealing that even if you achieve very low level of LDL, that means LDL level to the tune of about 20-30. If your CRP is high, you continue to be the high risk. And CANTOS trial, the drug as such is not a reality for clinicians at the moment, but it's a proof of hypothesis that inflammation does matter in this. So we have now at the moment 2 well-defined axes. One is the LDL axis and another is the inflammatory axis. And I think we have to make way forward, because the inflammatory axis is still not managed and manipulated by drugs, which are very expensive and out of hand of clinicians.
Yeah. So we've found the way to lower LDL to very low levels with statins, ezetimibe and PCSK9 inhibitors. Now the next goal is to find effective drug to tackle inflammation also, so that we can reduce cardiovascular events to the lowest levels.
That is very well summarized. And as you are aware that CRP is one of the surrogate markers of IL-1. CRP is lowered by the statins and ezetimibe also, but unfortunately we have a dichotomy that PCSK9, they do not reduce CRP. So that is a new understanding we have to amalgamate in our algorithms. That means each patient we are chasing for low LDL has to have statins and ezetimibe first rather than statin and PCSK9.
And in the same session, Dr. Giver Zakaria talked about molecular mechanism of atherosclerosis, and he mentioned that a lot of research is undergoing in the nanomedicine field, and in future it will be possible to regress atheroma beyond statin therapy itself. There will be new avenues which are being explored.
Regression is, it was a dream say 10 years ago. Now it is a reality, and statins trials have shown that we regress it to a very small level, but maybe in times to come by nanoparticles we may ablate atheroma, we may regress. So good thing is there is a very unusual mix in cardiology, both by interventionists who are trying to treat the disease, at the same time the basic scientists are trying to hit the disease at the cellular level. So this is a very unusual mix, and we are likely to have a bright future for our patients.
There was one more interesting presentation in this session by Dr. Mohanan. He mentioned that with the availability of newer generation imaging modalities like IVUS OCT, it is now possible to distinguish between plaque erosion and rupture as the cause of ACS. And there is data now, early data, to show that those patients who present with plaque erosion resulting in ACS, in them stenting may not be needed. They may just be managed medically.
That is a very good point you have raised, and I think clinically it is not possible to differentiate between plaque erosion and plaque rupture. But what you say, maybe times to come we may non-invasively assess plaque, which is at the moment not a reality, but that is what is very important, that plaque erosion and plaque rupture, they are two different things. And as you rightly said, plaque erosion does not require stenting. They are the good candidate for medical management. They do as well. So let me say once again that cardiology community is very balanced. We are trying to check ourselves that where we can be less invasive, and medical treatment is still our priority as the prevention is.
Now the second session we had about diagnosing CAD, mostly in the emergency setting. So Dr. Chazal spoke about the role of CT, and he said that the initial approach for diagnosis should be based on the local needs. If you want to have rapid turnover, then CT may be a good modality. But if your goal is to diagnose more ACS and be more sensitive, then troponins are the right way to go. But at the same time, there were two other presentations from Dr. M.K. Das and Dr. Satyavan Sharma, who talked about high sensitivity troponins, and they mentioned that while high sensitivity troponin is useful in detecting early births, we need more understanding to interpret it correctly. Otherwise, it can lead to more unwarranted investigations also.
That is true. If you have a very sensitive investigation, then overdiagnosis is a problem, and he used the word troponemia, that large number of patients who do not genuinely have, because troponemia is a very common problem. There are thousands and thousands diseases and clinical subsets where troponin may be high and still you don't have myocardial injury. So that is a difficult proposition. But what I enjoyed about one of the presentation is that if you have TB score less than 1 and troponin is normal, you have 99% probability of not having a disease. So this is, to my mind, a very good information that TIMI score and troponin, if both are negative, you can safely send the patient home. CT is, of course, if you see more, you are likely to be correct more number of times, but I don't think with the given subset of our country, developing nation, CT imaging is not going to be a community-based investigation in times to come.
Yeah, that is a reality for our country.
Yes. So troponin and TB scoring is very important.
So coming to our country, Dr. Valentine, ACC president, he had a very important talk on STEMI care in India, developing countries in particular, and he gave examples of the systems that they have adopted in the US of having robust processes for treating patients who present with ACS, robust processes for transferring the patient, and overall integration of the two systems, which have resulted in reduction in mortality in patients, vast improvement in the outcomes.
This looks very logical, what we had been described as pharmacoinvasive therapy. He said that door to balloon time is an old thing we have to do, first medical contact to the time of treatment. He used the word drip and ship. That means you take the patient in, treat him, and if you are not a PCI capable, then you ship the patient. But during the discussion, we realized that what to say of PCI capable, we don't have hospitals which are thrombolysis capable. Because thrombolysis, medical legal should not be done by a physician or a general physician. So that is a very big challenge, that how many cardiologists will be there in the periphery who can thrombolize a patient. So I feel we have to be realistic that how to make our primary health center thrombolysis capable, and that is how we at least buy time for invasive therapies.
Actually, Dr. Valentine talked a lot about the value of pre-hospital ECG. But as you very rightly said, pre-hospital ECG has much less relevance for us, because even if we diagnose MI, we are not able to thrombolize the patient because of medical legal issues and other logistic issues.
Yeah, I think I do not know how to solve the problem, but the governments and the lawmakers should at least give us a mandate that physicians who are postgraduate in medicine should be allowed to thrombolize a patient, because tomorrow somebody may challenge, you are not a cardiologist, why did you thrombolize a patient? So that is a very big problem, and I think we cannot have so many cardiologists who will be thrombolizing patients all over the country. So the first step I feel is making our hospital legally and professionally thrombolysis capable. And streptokinase is cheap, affordable. Government should mandate that we will provide free streptokinase at least to all our STEMI patients.
That's very much needed for a country like us, which is having such high burden of cardiovascular disease.
Yes.
Now, after that, we had another very interesting talk by Dr. Chapman on HDL, and he made a very interesting point that both low HDL and high HDL are associated with worse outcome, and it's only now that we are understanding the whole pathophysiology of HDL and cardiovascular disease. But I believe it still remains a very mystical agent.
HDL is a very complicated molecule. Its functionality is far more than LDL, and all the trials consistently they have failed in reducing the risk, reducing the mortality. So HDL is one area like inflammation where we have to work upon. At the moment we don't have tools to work with.
Yeah, hopefully with the insight that we are getting now into HDL metabolism, we'll be able to develop some therapies. Then we had important talks on DAPT. In fact, there were two sessions on where we discussed about DAPT. DAPT again is a very controversial issue. Controversial in the sense that there are no definitive data to suggest duration of DAPT in different settings, choice of DAPT, and then again for us logistic issues.
So DAPT is a challenge because we have wide variety of stents. So each manufacturers makes some kind of difference in their technology. You don't know with each stent how the endothelization will take place. And endothelization, in fact, indirectly decides the duration of DAPT. So that is a very big challenge. What I learned today that even if you are a high risk of bleeding, in every subset of patient, drug-coated stent is the choice.
Yes.
That is one mandate and
Second
clarity we had
generation,
that,
yes, that we have
the stent to be used today in every situation, even a high-risk bleeding patient, is DES, and you shorten the duration of dual antiplatelet in these patients.
Yes, yes.
That is something we have to talk about. And DAPT, longer you give, it's a problem. Shorter you give, it's a problem. So what we have to balance is ischemic burden versus bleeding risk. And that exercise should be done in every patient when you decide. Probably many of us are not doing that exercise.
Actually, that is what the should be the key message, that we should more routinely looking at the bleeding risk and ischemic risk and then taking decisions on that basis. But in stable CAD undergoing PCI, the standard duration has been recommended as 6 months, and in ACS 1 year.
Yeah,
And
that continues to be the standard recommendation. And in stable angina, we can reduce it to 6 months, and in ACS, it continues to be a year.
Then we had another important topic touched upon by Dr. Jagat Marula about the plaque composition and its relationship with FFR. So what he mentioned was that even in FAME study, the patients who had FFR positive, in them MI risk was same as patients who were managed based on angiography, not FFR strategy. So what he subsequently showed that even plaques which have low attenuation area, which means high necrotic area, they contribute to FFR positivity. So ideal plaque is one which is non-stenotic and has low attenuation area. So low necrosis, non-stenotic, that is the plaque that we need to identify, and that can be treated less aggressively. But if there is low attenuation area or FFR positivity, that needs to be treated aggressively.
You see, this is a very difficult area because ultimately all these sciences, they have to be translated at the clinical level. So what I'll say, the work like this will generate a hypothesis, and then maybe we have some kind of biomarker in times to come that will decide how to go about with aggressive or less aggressive therapy. At the moment, this is a tool which will create a proof of hypothesis.
Yes, correctly. Then a different topic was SCD risk assessment in hypertrophic cardiomyopathy. And Dr. Maron, Martin Maron, he talked about the two commonly used risk algorithms, ACC-AHA and ESC, and he made some very important points. That ACC-AHA algorithm allows for inclusion of newer risk markers as they emerge. For example, evidence of scarring on MRI, LV apical aneurysm, and reduction in EF. These three markers, if present, indicate high probability of adverse arrhythmic events and need for ICD, which is not covered that well in the ESC algorithm. So, if we use both algorithms, eventual outcomes will be same, but with ACC-AHA will be more sensitive. So he said, I would prefer to err on the side of over-treatment in this population, because even one death because of SCD is not acceptable.
I think this is something very good and simple to understand. And if you look, any kind of population where ICD comes into picture, now it looks MR imaging is going to be must, because if you have a scar, you are worse, whether it is dilated cardiomyopathy, whether it is hypertrophic cardiomyopathy. Even patients with aortic stenosis, you have a scar on MRI, these patients do less well. So MR imaging before AICD may be soon guideline driven, which at the moment it is not.
Only thing is that we will have to overcome logistic issues.
Yes, but AICD is a big decision.
Yes,
so MR imaging has to be included in those trials where we can more judicially use AICD because it's an expensive proposition for the patient.
And Dr. Raj Bakkar talked about TAVR's current status. He beautifully described how the technique has grown over the years exponentially, and now in the US, more number of patients with AS are undergoing TAVR than surgical AVR. And in intermediate to high risk patients, TAVR has become almost the default strategy. Only thing is, what about low risk patients and young patients? So work is going on, and soon we may have data to support TAVR even in those conditions, because over the time the technique has evolved so much that the complication rates have come down drastically.
I think the rates have come down drastically. What we see, the longevity of the valve, that is one very important issue, because if you do in younger patients, the valve life is important, and younger patient, I'll say they will still be out of TAVR.
So one point which he made was that TAVR provides a better platform for subsequent intervention as compared to surgical AVR. So that may be one advantage.
Definitely, because the anatomy of that area is more well defined. If you do surgery, then it is disorganized, and you won't get those planes which naturally exist.
And also the surgical valves have smaller valve area, so fitting in a TAVR valve becomes more difficult as compared to the TAVR in TAVR.
TAVR in TAVR. Yeah, that is true, but I think the industry will take up the challenge, and we will have better valves with long life, because if you are coming towards the younger population, life of the valve is very important, leave aside the technical success and immediate outcomes.
In fact, there are newer surgical valves also now being designed in such a way that if needed, TAVR can be performed later by expanding those valves. So valve which has already been implanted can be expanded.
Yeah, but at the same time, these are upcoming things. We have to watch it carefully, what is due, and balance it about how many procedures a patient can have.
We had a couple of debates also today. One interesting debate was on cholesterol controversy, where Dr. J.C. Mohan and Dr. Prabhakaran, actually they took up different dimensions of the same debate and discussed two different topics, but we got important messages.
We had good discussion, and I think the message continues to be the same, that even today, although the dietary fat contribute just 20% to the blood levels, but fat restriction, to my mind, is still the cornerstone and foundation of any kind of atherosclerotic prevention program. All the guidelines unequivocally vouch for it, that fat restriction is the thing, and diet, exercise, and lipid lowering therapy.
The only thing we need to remember is fat restriction. Carbohydrates are worse. So fat should not be substituted for carbohydrates.
Yes, that is true, because most of the developing countries eat more of carbohydrates than fat, less of protein. So carbohydrate calories are cheap, so we eat more of carbohydrates.
And there is no truth in theories that statins are not effective.
No, that is a misnomer and confusion. It should be criticized at every opportunity, and we at this platform encourage our patient to lipid lowering therapy after diet and exercise.
And Dr. J.C. Mohan proved this point very emphatically.
And we enjoyed the day. I hope the third day will be equally informative and enjoyable.
So I think this is all that we wanted to share with you today from today's presentations.
Thank you.
Thank you.